कृपया अपने अपने स्थान को ग्रहण कर लें और अपने मोबाइल्स को साइलेंट मोड पे कर दें। आप सभी से अनुरोध है कि कृपया अपना अपना स्थान ग्रहण कर लें, शीघ्र ग्रहण कर लें। कृपया अपना अपना स्थान ग्रहण कर लें और मोबाइल फ़ोन्स को साइलेंट मोड पे कर दें। बंद। डोर क्लोज। क्लियर। आप सभी से अनुरोध है कि कृपया अपने अपने स्थान पे खड़े हो जाएं राष्ट्रगान के लिए और अपने फ़ोन साइलेंट मोड पे कर दें। हमारे विशिष्ट अतिथिगणों का आगमन हो रहा है। कृपया फ़ोन्स को साइलेंट पे डाल दें। हमारे गणमान्य अतिथियों का आगमन हो रहा है। अभी थोड़ा सा विलंब है, तो कृपया सबसे अनुरोध है कि अपने अपने स्थान पे बैठ जाएं। मैं फिर से अनाउंस करूंगा। कष्ट के लिए खेद है। प्लीज़ सभी से अनुरोध है कि अपने अपने फ़ोन साइलेंट मोड पे कर लें। सभी से अनुरोध है कि अपने अपने स्थान पे कृपया खड़े हो जाएं। हमारे विशिष्ट अतिथि कभी भी मंच पे आ सकते हैं। जी। कृपया राष्ट्रगान के लिए सभी लोग खड़े हो जाएं। धन्यवाद।
जनगण मन अधिनायक जय हे भारत भाग्य विधाता, पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा, विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा, तव शुभ नामे जागे, तव शुभ आशीष मांगे, गाहे तव जय गाथा। जन गण मंगलदायक जय हे भारत भाग्य विधाता, जय हे जय हे जय हे जय 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 हे।
धन्यवाद। नमस्कार, सुप्रभात। आप सभी का स्वागत है इस संगोष्ठी में। और सर्वप्रथम मैं ICMR के आदरणीय डॉक्टर राजनारायण तिवारी जी को आमंत्रित करूंगा मंच पे कि वह शब्दों से सभी हमारे गणमान्य व्यक्तियों का, अतिथियों का स्वागत करें।
नमस्कार। माननीय राज्यपाल महोदय मध्य प्रदेश श्री मंगूभाई पटेल जी, माननीय केंद्रीय मंत्री जनजातीय कार्य मंत्रालय भारत सरकार श्री अर्जुन मुंडा जी, डॉक्टर प्रभुराम चौधरी लोक स्वास्थ्य एवं परिवार कल्याण मंत्री मध्य प्रदेश सरकार, श्री दीपक खांडेकर जी, श्री मोहम्मद सुलेमान जी, डॉक्टर ग्राहम सर्जेंट और सभागार में उपस्थित सभी अतिथिगण। भारत में सिकल सेल रोग पर आयोजित इस 2 दिवसीय संगोष्ठी में सर्वप्रथम मैं माननीय राज्यपाल महोदय मध्य प्रदेश श्री मंगूभाई पटेल जी का ICMR के दोनों संस्थानों की ओर से निरे के हरित प्रांगण में आदरपूर्वक स्वागत करता हूं। माननीय राज्यपाल जी के सिकल सेल के निदान के प्रति रुचि और अथक प्रयासों के बारे में हम लोग भली भांति परिचित हैं और उन्होंने इस संगोष्ठी को ICMR के तत्वाधान में ICMR नीरे में आयोजित करने का अवसर हमें प्रदान किया। इसके लिए हम उनके हृदयपूर्वक आभारी भी हैं। मैं माननीय केंद्रीय मंत्री जनजातीय कार्य मंत्रालय भारत सरकार श्री अर्जुन मुंडा जी का भी आदरपूर्वक स्वागत करना चाहूँगा, जिनके नेतृत्व में जनजातीय मंत्रालय ने भी जन स्वास्थ्य से संबंधित इस महत्वपूर्ण मुद्दे को अहमियत दी है। आदरणीय डॉक्टर प्रभुराम चौधरी मंत्री लोक स्वास्थ्य एवं परिवार कल्याण मध्य प्रदेश सरकार का भी मैं स्वागत करता हूं, जिनका मार्गदर्शन हमें निरंतर प्राप्त होता रहता है। श्री दीपक खांडेकर अध्यक्ष जनजातीय प्रकोष्ठ एवं श्री मोहम्मद सुलेमान अपर मुख्य सचिव मध्य प्रदेश सरकार के हमारे कैंपस में प्रथम आगमन पर मैं उनका भी स्वागत करता हूं। I would also like to welcome Dr. Graham Sargent from Sickle Cell Trust, Jamaica, who is recognized as final word for the sickle cell diagnosis and treatment across the world because of his vast volume of work on this. Sir, I welcome you. सभागार में उपस्थित प्रियंका दास मैडम, विनीता श्रीवास्तव मैडम, जया मैडम, श्री जामोद जी का भी मैं स्वागत करता हूं, जिनकी उपस्थिति हमेशा हमारा उत्साहवर्धन करती है। अंत में मैं संगोष्ठी में सम्मिलित प्रतिभागियों कार्यक्रम में पधारे सिकल से रोग से लड़ते योद्धाओं और उनके अभिभावकों तथा परीक्षण शिविर में पधारे सभी विद्यार्थियों का भी हार्दिक स्वागत करता हूं। धन्यवाद।
धन्यवाद सर। आगे बढ़ते हुए मैं मंच पर आसीन हमारे सभी विशिष्ट एवं सम्मानीय अतिथियों से अनुरोध करूंगा कि दीप प्रज्वलित कर इस संगोष्ठी का शुभारंभ करें। बहुत बहुत धन्यवाद। आगे के क्रम में अब मैं आग्रह करूंगा आदरणीय डॉक्टर अपूर्व दास जी, निदेशक राष्ट्रीय जनजाति स्वास्थ्य अनुसंधान संस्थान जबलपुर से, कि वह मंच पे आके ICMR's रिसर्च एक्टिविटीज ऑन सिकल सेल डिजीज विषय पर 2 शब्द कहें।
गुड मॉर्निंग। मंचासीन जो हमारे गण्यमान्य अतिथि हैं, महामहिम राज्यपाल जी और श्री अर्जुन मुंडा जी, श्री प्रभुराम चौधरी जी, डॉक्टर ग्राहम सर्जेंट, मैडम आर जया, श्री दीपक खांडेकर जी और श्री मोहम्मद सुलेमान जी, और जो भी जितने भी गण्यमान्य व्यक्ति आए हुए हैं, फैकल्टीज, स्टूडेंट्स, सबको मैं हार्दिक स्वागत करता हूं आज के दिन में। ICMR जैसे कि जानते हैं, इंडियन काउंसिल ऑफ मेडिकल रिसर्च, 27 इंस्टीट्यूट है हमारे पूरे भारतवर्ष में, और कम से कम 6 इंस्टीट्यूट सिकल सेल डिजीज में रिसर्च करते हैं। उसमें ICMR नीथ जो जबलपुर में है, जो ट्राइबल हेल्थ के रिसर्च में डेडिकेटेड है। हम स्क्रीनिंग से लेके नए क्लिनिकल ट्रायल से लेके और जो ट्रेनिंग प्रोवाइड करते हैं हम जो हेल्थ डिपार्टमेंट को स्क्रीनिंग के लिए, मैनेजमेंट के लिए और उनके प्रिवेंटिव एस्पेक्ट के लिए, वो हम करते हैं। 1986 से हम लोग ये काम कर रहे हैं। मेनली मध्य प्रदेश में हमने किया हुआ है काम, और छत्तीसगढ़ और उड़ीसा में भी हमने किया हुआ है। मिनिस्ट्री ऑफ ट्राइबल अफेयर्स से हम लोग जुड़े हुए हैं। हम लोग खुद मिनिस्ट्री ऑफ हेल्थ एंड फैमिली वेलफेयर के ही पार्ट हैं। और बाकी इंस्टीट्यूट में, जैसे मुंबई में इंस्टीट्यूट है और डिब्रूगढ़ में है, भुवनेश्वर में है, तो ये सारे हम लोग मिलके लोकल जगह पे स्क्रीनिंग में, मैनेजमेंट में और जो उनको प्रिवेंटिव एस्पेक्ट में हम उसमें काम करते हैं। जैसे कि ये संगोष्ठी में ये बात चर्चा होगी, जो गण्यमान्य अधिकारी जो आए हुए हैं उनसे हम इसमें सीखेंगे, और आगे चल के इस मुहिम को, जो सिकल सेल डिजीज जो कि एक ट्राइबल डिजीज है मेनली, तो उसमें हम लोग सारे मिल के काम करेंगे। इसके साथ मैं सबको फिर से धन्यवाद दे रहा हूँ। नमस्कार, प्रणाम, जय हिंद।
धन्यवाद सर, बहुत बहुत धन्यवाद। सिकल सेल डिजीज़ के बारे में ICMR की जो एक्टिविटीज़ हैं उसके ऊपर प्रकाश डालने के लिए। अब आगे बढ़ते हुए मैं आदरणीय श्रीमती विनीता श्रीवास्तव जी, स्वास्थ्य सलाहकार, जनजाति कार्य मंत्रालय, भारत सरकार से अनुरोध करूंगा कि वह मंच पे आके आउटलाइन फॉर एलिमिनेशन ऑफ सिकल सेल डिजीज इन इंडिया बाय 2047 विषय पर 2 शब्द कहें। धन्यवाद।
धन्यवाद। सबसे पहले नमस्कार। ऑनरेबल HE, ऑनरेबल यूनियन मिनिस्टर ऑफ हेल्थ, ऑनरेबल मिनिस्टर ऑफ स्टेट हेल्थ फॉर हेल्थ, ACS sir, Khandekar sir, Jaya ma'am, and Dr. Sarjan and the dignitaries of the dais as well, because all are my teachers, so The concern is about that how we are going to eliminate and what is the MOTA's plan, because it is going to be joint efforts of Ministry of Health and Tribal Affairs, where we are going to plan some good screening, which is important. That I'll just show you in small slides. Next, please. So if we talk about that, approximately 3 to 5% of Indian tribal population suffer from sickle cell anemia, and another 23 is it of carriers. So it is very important that we see the gamut of the disease is too big. Nearly all tribal communities living in forest terrains across the country have cause of cases of sickle cell anemia. The prevalence varies considerably among the different tribal groups. Is from 0 to 40. So it's a big, huge chunk, and still certain population groups of various states remain untouched, which is very important. And still in India, if you see much of the states, haven't touched those places still. It is important. So why it is a public health concern? Death occurs in the first 5 years of life. Even if they survive, the time risk of disease remain same. Management of SC has not gained adequate momentum at the national and the state level, which is very important. And now, because of the sickle cell mission, elimination mission, we will be able to do the same. Management of disease is a big task. Still in most of the states, we don't have hematologists to take care of it. And disability is a big challenge which we have recently taken up with the Ministry of Social Justice, which is important. And screening is not a common practice in diagnosis, usually made when the complications occur, so which is very important. And people come to us because when it is a complication, then they come to us. So what is the important and time to focus in information and education and communication with mass media, mid-media and communication, connecting with the Ministry of Information, which we have started working on, Ministry of Information Broadcasting, tribal NGOs and other. IC in regional languages, which is one of the most important tasks which we are going to focus. We are going to advocate these things in the country. Training with ICMR and AIMS, because training is again a very important component. We have much of the doctors at the periphery levels, but they are not trained doctors, which is very important. And now we need to train doctors as well as a paramedical staff, the gynecologists, the pediatricians, the physicians even. Everybody needs to be trained. And screening of sickle cell anemia through public health system, public camps, CBOs, NGOs, and other technologies, which is important. And now genetic counseling, prevention of serious complications through establishment of center of competency, catalyzing with other departments, and research along with IGIB gene editing, which we have recently started. So these are the outlines where we need to deliberate on these issues, which is very important for us. And thank you dignitaries, because of you now the things have taken up. State has taken up in a great way now, because we are going to decide the things how we are going to take up in the different state as well. Thank you so much. Namaskar.
बहुत बहुत धन्यवाद मैडम। अब मैं अनुरोध करूंगा आदरणीय श्री मोहम्मद सुलेमान जी, अपर मुख्य सचिव मध्य प्रदेश शासन से, कि वह मंच पे आकर और सिकल सेल रोग विषय पर ओवरव्यू ऑफ मैनेजमेंट स्ट्रैटेजीज इन मध्य प्रदेश विषय पर सभा को संबोधित करें।
महामहिम राज्यपाल महोदय, आदरणीय केंद्रीय मंत्री जी, आदरणीय लोक स्वास्थ्य मंत्री जी, उपस्थित मंच पर उपस्थित सभी आदरणीय सज्जनगण, सभागार में उपस्थित सभी पार्टिसिपेंट्स। अभी डिजीज़ के प्रेवलेंस के बारे में आपके सामने कुछ जानकारी रखी गई। स्वास्थ्य विभाग पिछले 2 साल से इस प्रोजेक्ट में जुड़ा है। मैं सही बताऊं, जब तक महामहिम राज्यपाल महोदय ने इस कार्यक्रम में लीड नहीं ली, तब तक मध्य प्रदेश के स्वास्थ्य विभाग को इस बीमारी के बारे में कुछ पता नहीं, और ना ही हम इसमें कोई बहुत काम कर रहे थे। राज्यपाल महोदय ने इस पर न केवल हमको मार्गदर्शन दिया, बल्कि स्वयं लीड लेकर कई बार राजभवन में बैठ के आयोजित कराई और विभाग को सेंसिटाइज किया कि वो इस प्रोजेक्ट को आगे टेकअप कर सके। मध्य प्रदेश में करीबन 1.5 करोड़ जनजातीय समुदाय की जनसंख्या है और उनमें प्रेवलेंस ज़्यादा है। उनके हित को दृष्टिगत रखते हुए एक महत्वपूर्ण प्रयास उनके स्तर से शुरू हुआ और उनके ही निर्देश पर मध्य प्रदेश में राज्य हीमोग्लोबिनोपैथी मिशन का गठन जून 2021 में किया गया, जिसमें ये लक्ष्य रखे गए कि हम सिकल सेल एनीमिया की पहचान कम्युनिटी स्क्रीनिंग से करें। केवल ये ना देखें कि जब मरीज सीरियस हो जाए और अस्पताल में डॉक्टर के पास आए तब हम टेस्ट करें, बल्कि उसके स्थान पर हम कम्युनिटी स्क्रीनिंग करें और अर्ली आइडेंटिफिकेशन पे ध्यान दें। जेनेटिक काउंसलिंग की व्यवस्था करें, बताएं कि किस तरह शादी की व्यवस्था से हम इसमें थोड़ा अगली पीढ़ी को सुरक्षित कर सकते हैं, और जो अवेयरनेस, कम्युनिटी अवेयरनेस है, वो काम भी करें ट्रीटमेंट के साथ साथ। माननीय राज्यपाल महोदय के निर्देश पर फिर 15 नवंबर 2021 को जब मध्य प्रदेश में जनजातीय गौरव दिवस मनाया गया, उस समय ये तय हुआ कि 2 जिले हैं प्रदेश के आदिवासी बाहुल्य जिले, झाबुआ और अलीराजपुर, उसमें हम कम्युनिटी स्क्रीनिंग से एक पायलट प्रोजेक्ट की शुरुआत करें और देखें कि वो किस दिशा में और किस तरह से बेहतर तरीके से किया जा सकता है। मुझे ये बताते हुए हर्ष है कि इस पायलट प्रोजेक्ट में लगभग 6 महीने की अवधि में कुल 9.17 लाख जनसंख्या थी जिसका हमने टेस्टिंग करी, आइडेंटिफाई किया कि उसमें किसको कौन से कैरियर हैं और कौन से पेशेंट्स हैं, और जो पेशेंट्स आइडेंटिफाई हुए उनके फर्दर ट्रीटमेंट की व्यवस्थाएं भी हमने शुरू करी और उसकी लगातार हम मॉनिटरिंग करते हैं। इस पायलट प्रोजेक्ट के परिणाम स्वरूप मैं फिर से माननीय राज्यपाल महोदय को धन्यवाद देना चाहता हूं कि उनके मार्गदर्शन में और उनके निर्देश पर प्रदेश के मंत्री परिषद ने ये फैसला किया कि जो प्रदेश के 89 आदिवासी बाहुल्य विकासखंड जिनको हम कहते हैं 20 जिलों में जो हैं, उन सब में इस मिशन का विस्तार किया जाए, और तदनुसार मंत्री परिषद ने निर्णय लिया कि हम 89 विकासखंडों में इसका विस्तार करेंगे। और जो पहले हम खाली 25 साल तक की जनसंख्या का सर्वे कर रहे थे, उसमें भी परिवर्तन किया गया, और ये हुआ कि हम ये देखें कि 40 वर्ष तक की आयु सीमा के अनुसूचित जनजाति वर्ग के सभी व्यक्तियों का हम स्क्रीनिंग करें, अनुसूचित जनजाति परिवारों की समस्त गर्भवती महिलाओं और जो अगर कोई पॉजिटिव पाया जाता है तो उसके परिवार के सदस्यों की स्क्रीनिंग करें, और लक्षण युक्त व्यक्ति चाहे वो किसी भी समाज का हो, उसमें अगर कोई लक्षण पाया जाता है, पॉजिटिव पाया जाता है, तो उनके परिवार की भी हम स्क्रीनिंग करें। इस तरह का 89 विकास खंडों में एक प्रोजेक्ट की मंत्रिपरिषद ने स्वीकृति दी, और साथ में राज्य के बजट में भी इस बात का प्रावधान किया कि हम केवल केंद्र शासन पर निर्भर ना रहते हुए स्टेट बजट से भी इसको हम सपोर्ट करना शुरू करें, और तदनुसार हमने ये काम आगे अब टेकअप किया है। इन्हीं प्रयासों से केंद्र सरकार के बजट में भी इस प्रोग्राम को अब शामिल किया है, और ये निर्णय लिया गया है कि 2047 तक इसका उन्मूलन किया जाए, और सभी 17 राज्यों में इसको लागू कर दिया गया है। 23-24 के इसमें बजट प्रावधान भी हो गए हैं। हमने इसका एक पोर्टल पहले अपने यहाँ डेवलप किया है, वो पोर्टल अब गवर्नमेंट ऑफ इंडिया के माध्यम से सभी देशों में, सभी प्रदेशों में, जो 17 प्रदेशों में प्रोग्राम टेकअप किया उसमें लागू किया जा रहा है। टेस्टिंग एक बड़ा चैलेंज है कि टेस्टिंग किस तरह की जाए, और टेक्नोलॉजी लगातार इवॉल्व होती है। अब पॉइंट ऑफ केयर टेस्ट भी इसका उपलब्ध हो गया है। हम लोग अब ये कोशिश कर रहे हैं कि आगे जो हम टेस्टिंग करें वो पीओसी के माध्यम से ही हम टेस्टिंग करें। केंद्र शासन से भी इसमें सपोर्ट मिलना शुरू हुआ है, तो उसकी भी हमने निविदा बुलाई हुई है। बहुत जल्दी हम पीओसी के माध्यम से टेस्टिंग की व्यवस्था करेंगे। माननीय राज्यपाल जी ने हमें 3 गाइडेंस दी हैं इस प्रोग्राम को क्रियान्वित करने के लिए। पहला ये कि हम टाइमली लोगों को टेस्ट करके आइडेंटिफाई कर सकें कि किसमें इश्यूज हैं, कहाँ दिक्कत है, कौन कैरियर है, जिससे जेनेटिक काउंसलिंग की व्यवस्था की जा सके। तो जेनेटिक काउंसलिंग कार्ड बनाने का हमारा एक बहुत बड़ा काम है। हम लोगों को सलाह देके उनके जेनेटिक काउंसलिंग कार्ड बनाएं। दूसरा, उन्होंने हमको निर्देश दिया है कि जो आइडेंटिफाई होते हैं, जो कैरियर हैं, उनके इलाज की हम व्यवस्था कैसे कर सकें जिससे कम से कम उनका जीवन आसान तरीके से, जितना जीवन है वो आसान तरीके हो सके। हमने इस संबंध में एक जो ऑल इंडिया इंस्टीट्यूट ऑफ मेडिकल साइंस है भोपाल में, उसके साथ भी एक MOU किया है। उनका सपोर्ट लेके हम उनके इलाज की बेहतर व्यवस्था कर रहे हैं। साथ में ICMR के सहयोग से हमने ट्रीटमेंट फॉलो बुकलेट तैयार करी है, जिसको हम सब तरफ भेज रहे हैं, और ये देख रहे हैं कि जो पेशेंट आइडेंटिफाई होते हैं उस बुकलेट के हिसाब से जो ICMR के सहयोग से डेवलप हुई है, हम उनका इलाज की व्यवस्था कर सकें। और माननीय राज्यपाल महोदय जी का तीसरा निर्देश ये है कि समुदाय में हम जागरूकता लाएं, समुदाय को इन्वॉल्व करें, ताकि हम इस डिजीज पे बेहतर तरीके से मैनेजमेंट कर सकें। हम इसके लिए भी जन अभियान परिषद के माध्यम से लगातार काम कर रहे हैं। तीनों क्षेत्रों में हमारा काम लगातार जारी है। मुझे पूरा विश्वास है कि हम महामहिम राज्यपाल महोदय के निर्देश में सफलतापूर्वक इस कैंपेन को संचालित करेंगे। धन्यवाद।
बहुत बहुत धन्यवाद सर। आपने जो होलिस्टिक अप्रोच की बात की, हर तरह से सिकल सेल रोग को हराने के लिए जो हमें एक मल्टी सेक्टोरियल अप्रोच चाहिए, उसके लिए धन्यवाद। अब आगे बढ़ते हुए मैं बताना चाहूँगा कि आज हमारे बीच डॉक्टर ग्राहम सर्जेंट हैं, जो कि एक विश्वविख्यात वैज्ञानिक हैं सिकल सेल डिजीज़ के क्षेत्र में। सो इट इज़ नाउ माय इंडीड profound privilege to invite the world-renowned scientist Dr. Graham Sargent to kindly address the August gathering. And Dr. Graham Sargent will be delivering the keynote address also later today. So we will be very much privileged to hear him twice today. But now I request him to address the August gathering. Sir.
I start with an apology. As one gets older, bits fall apart. And since arriving in India last week, I've got a problem in my left ankle, which is why I've caused enormous trouble to my friends and colleagues with wheelchairs everywhere. So apologies and thanks very much for your diligence and help in accommodating me. The second observation is that of a program for scientific meetings. And one of the exciting features about being in India is how programs change by the day, sometimes by the hour, sometimes by the minute. And that is, to some extent, what's happened on this occasion. And it was only last night at 8:30 that we finally met with the gracious Honourable Governor, who assured me that the program that he was about to give me, and he endorsed it with his signature, was the final version. So I had at least 12 hours in which to prepare a few comments. Enough of the background, let's talk about sickle cell disease. Let's go to the beginning. Not the beginning of the disease, but the beginning of the reports in the medical literature. Between 1904 and 1907, a patient was observed in Chicago with a very unusual combination of symptoms and an unusual blood film. That patient was followed by Dr. James Herrick, who in 1910 published the first recognized report of the disease. The fourth case in 1922 by Vern Mason from Johns Hopkins was the first to actually use the term sickle cell anemia. Before, it was always a case of severe anemia with peculiarly elongated and sickle-shaped red blood cells, a rather unwieldy title. So Vern Mason has described sickle cell anemia for the first time. And he reviewed the features of those first 4 cases. And they were all of West African origin. And that was the beginning of this common misconception that the disease is confined to people of African origin. You all know better, of course. And the next major development was really a French lady called Dominique Labie, working in Francophone Africa, who, looking at the genetics around the DNA surrounding the beta-globin locus, who recognized that there were at least 3 forms of the disease occurring in Africa, named after the areas where they were first described: the Senegal, the Benin, and the Bantu, or Central African Republic, haplotype. An enormous amount has been learned about that disease, and almost all of that has been in the Benin haplotype. It accounts for 80% of our patients in Jamaica, and the great majority of reported cases from the US and from Europe. So, excuse me. So we began to realize that the disease was diverse. And then we moved on to your own disease. And it was in 1952 that the gene was first described amongst tribal populations in the Nilgiri Hills in the north of Tamil Nadu. Gradually, there was increasing awareness and a huge amount of developing interest. And one of the inspiring things about coming frequently to India is that we realize how much has been learnt and how many diligent people are working in sickle cell disease in India. Let me go back in a brief personal note, if I may, to my arrival in Jamaica in 1966. I came with my wife, Beryl, who's a hematology technologist, and together we became interested in the disease in Jamaica. What happened was the disease in the textbooks told us that this was a dreadful disease and everybody died in childhood. Maybe a few people survived to adolescence and early adult life. And yet when we started to do the clinic, we found that in fact many people were 30, 40, 50, even 60 years old with SS disease, homozygous sickle cell disease. There was a clear conflict between our practical experience and what was reported in the literature. And we began to think that maybe the problem was doctors who write papers only saw sick patients. And they didn't realize that out in the community are perfectly healthy people who never seek medical advice, but have the same disease. And so over the next 50-odd years, we have actually, with the help of our patients and our guidance by our patients, and our patients are, of course, ultimately our teachers, we have developed services for 5,500 patients across the island of Jamaica. We have learned, our patients have told us what were the major problems, and we have actually, with our patients, evolved methods of care. So much so that even with this severe genetic disease, our median age for SS disease in Jamaica approaches 50 years. If we turn now back to the Indian scene, after the first description, the first major clinical study was organized by Professor Bimal Kaur. Got to watch the time. In Burla, Sambalpur University in Odisha. And he got together 131 patients that we saw with the visiting team from Jamaica. And we found interesting things. We found, first of all, that the disease had many differences from the benign form with which we were familiar. We realized that almost all the patients had very high levels of fetal hemoglobin. What does that mean? Don't worry about it. It just means that if you have a lot of fetal hemoglobin, you have less sickle hemoglobin, and you have less sickling. So the first observation was the disease should be more mild as a result of that. The next observation was that over half of them had another genetic abnormality called alpha thalassemia. And that means that you've lowered the concentration of hemoglobin molecules within the cell, and that also inhibits sickling. So you now have two factors. Where's my chairman? Where are we in time? How much? 5 minutes. Give me a dig if I go on. Right, thank you. Sorry, I lose time. So anyway, we're going back now to Burla, and we now already recognize that there are two factors inhibiting sickling in our Indian population. Fetal hemoglobin is universally increased in people with what we call the Asian haplotype. Alpha thalassemia is very variable, but we're looking at two factors which should change the clinical features of the disease. So you can learn a lot from the benign haplotype, but you have your own disease which you have to document yourself. And I want to focus on two areas. One is the bone pain crisis, which is the commonest cause of hospital admission. And what's happened elsewhere in the world is the use of analgesia kept by patients at home has made a huge contribution. And now day care for the painful crisis of sickle cell disease is routine, not only for Jamaica, where it was first developed, but also throughout the UK and the US. The other aspect, apart from the bone pain crisis, is the fact that you get the same pathology, you get hip necrosis, painful limitation of movement of the hip. And that is another major problem that may be more common amongst your Indian patients than in those of the benign haplotype. So bones are different. Spleen is different. The spleen sits under the ribs on the left side of the abdomen, very important in early childhood, taking bacteria out of the blood. Your spleens persist for longer, and that's good. But the other problem is they can also become very enlarged, and you have the problem of chronic hypersplenism, which is not good. So you have a disease that is fascinating, it has important differences, you must document your own disease. I'm fascinated to see objectives addressed in the program, future objectives for the disease. It's very important to have objectives. It is also very important that those objectives are realistic and attainable. And if I may end with another personal note, India has become my second home. It is my 28th visit to India. And the reason I keep on coming is out of respect for so many Indian colleagues working in sickle cell disease and achieving a great deal under what are often difficult circumstances. Thank you.
Thank you so much, sir, for your insightful lecture on the sickle cell disease, its progression, epidemiology, and how to manage the whole the problem, and your insightful discussion on the problem, especially with respect to India. Thank you so much, sir. Thank you once again. अब मैं आगे बढ़ते हुए अब मैं आग्रह करूंगा आदरणीय श्रीमती आर जया जी से, अपर सचिव जनजाति कार्य मंत्रालय से, कि वह मंच पे आएं और सिकल सेल विषय पे हमें 2 शब्द कहें. मैडम.
धन्यवाद. महामहिम राज्यपाल सर, केंद्रीय जनजाति कार्य मंत्री जी सर, हमारे पूर्व सचिव और अब गवर्नर हाउस में एडवाइज़र सर, मंत्री जी, राज्य के स्वास्थ्य और समाज कल्याण के मंत्री जी, ACS sir, and Dr. Sargent, and all the experts who are sitting out there. मैं अपने आप को और जो बच्चे आए हैं जो उनके साथ उनके देखभाल करने वाले आज इस सिकल सेल के इस कैंप में शामिल हुए सबको मेरा नमस्कार. मैं अपने आप को आज डॉक्टर सार्जेंट हैं, इतने बड़े बड़े लोग सब बैठे हुए हैं, आप सब लोगों से बढ़कर जो है सिकल सेल के बारे में कौन बोल सकता है, मैं अपने आप को असक्षम महसूस कर रही हूँ. फिर भी 2-3 शब्द जो हम मिनिस्ट्री में कर रहे हैं ये थोड़ा मैं आपसे बहिरंग करना चाहूँगी. सबसे पहले एक बहुत अहम बजट अनाउंसमेंट आया है जिसमें हमने ये प्रण लिया है कि 2047 हमारा जब आज़ादी का सेंटिनरी सेलिब्रेशंस हम लोग करेंगे तब हम इंडिया को, भारत को सिकल सेल डिसीज़ मुक्त करेंगे. तो ये बहुत बड़ा एक अनाउंसमेंट बजट का है और उसके चलते हुए
हमारे माननीय मंत्री जी के दिशा निर्देश में मंत्रालय काफ़ी कदम उठाने का जो है पहले से ही कदम उठा रहा है और उसके साथ साथ उठाने का जो है और अग्रेसर है। एक तो स्क्रीनिंग के बारे में सबने बोला, स्क्रीनिंग कैसे होगा, उसका डेटा मैनेजमेंट बहुत इम्पॉर्टेंट है, क्योंकि स्क्रीनिंग के साथ साथ जब तक हमको पता नहीं होगा कि कौन पॉजिटिव है, कौन किसको ट्राइट है, किसको डिसीज़ है, और उनका ट्रीटमेंट की जिस तरह फॉलोअप होना है, उनका मैनेजमेंट जिस तरह फॉलोअप होना है, अगर उसमें अगर चूक हो जाएगा तो फिर से जो है ये हम जो हमने अपना लक्ष्य रखा है उसमें चूक हो सकता है। इस कारण से डेटा मैनेजमेंट पे हमारे मंत्री जी का हमेशा जोर रहा है और हम इस मंच में ये कहना चाहेंगे कि जो है मोटा इसमें सर आपके सामने खरा उतरेगा कि जो है डेटा मैनेजमेंट, डेटा एनालिटिक्स ज़रूर होगा और फॉलोअप भी होगा। और ये बहुत खुशी की बात है कि मध्य प्रदेश सरकार ने ना सिर्फ इसके लिए जो है अपना दायित्व व्यक्तित किया है, लेकिन उसके साथ साथ फाइनेंसेस भी आवंटित किया है, फाइनेंसेस प्रोवाइड किया है। ये बहुत बड़ी बात है, क्योंकि हमको ये सिर्फ सरकार से ही नहीं, हमको हर जगह से सपोर्ट की ज़रूरत है। मल्टी स्टेक होल्डर का ये एक संगम होना है इस कार्य को आगे बढ़ाने के लिए। तो आई कॉल अपॉन एवरी सिंगल स्टेक होल्डर, चाहे वो डॉक्टर कम्युनिटी हो, चाहे वो पैरामेडिकल कम्युनिटी हो, चाहे वो NGO कम्युनिटी हो, ये कम्युनिटी बेस्ड ऑर्गेनाइजेशंस हों, कई तरह के कोलैबोरेशंस हों, इसमें जो है हम लोगों की जन भागीदारी की बहुत ज़रूरी है और पेशेंट्स की भी भागीदारी जो है बहुत ज़रूरी है। इसके लिए मैं आमंत्रित करती हूँ कि मोटा के साथ हम सब के साथ मिलके चलने के लिए तैयार हैं और हमारे मंत्री जी के गाइडेंस में ये जो है अभी चॉकआउट हो रहा है प्रोग्राम कि कैसे सबको साथ मिला के आगे बढ़ सकते हैं। स्क्रीनिंग के साथ साथ काउंसलिंग, क्योंकि हमने 0 to 40 इयर्स का स्क्रीनिंग का जो है ब्यौरा लिया है, तो 0 to 40 इयर्स में जो है 2 तरीके का काउंसलिंग होगा, 2 तरीके का IEC होगा। और एक तो जो है जेनेटिक काउंसलिंग है कि अगले पीढ़ी को ये ट्रांसमिट ना होए, ये तो जो है हम सब लोग कर ही रहे हैं, लेकिन जिसको जो है जिसको वो डिसीज़ है या ट्राइट है, वो अपने आप को कैसे मैनेज करे, उसको कैसे ट्रीट करे, उसको जो है अपने रोज़मर्रा ज़िंदगी में क्या क्या प्रिकॉशंस ले, ये भी बहुत ज़रूरी है कि काउंसलिंग के ज़रिए, अवेयरनेस के ज़रिए हम आगे बढ़ाएं। उसी तरह उसके परिवार को, जिस माँ को एक सिकल सेल डिसीज़ का बच्चा पैदा हुए, और क्योंकि हम नवजात शिशुओं का भी जो है अब स्क्रीनिंग करना शुरू करेंगे, तो उसमें क्या क्या साइंस हैं जिसके लिए जो है वो सतर्क रहें, वो माँ सतर्क रहें, वो पेरेंट्स सतर्क रहें, कब उस बच्चे को जो है जो मेडिसिन चाहिए, जो मेंटेनेंस का जो एक मैनेजमेंट रेजिमेंट है उसको फॉलो करें। वो करेंगे तो क्वालिटी ऑफ लाइफ भी बढ़ेगा और लॉन्जेविटी भी बढ़ेगा। तो इस पे जो है हम जोर देना चाहेंगे, विथ ऑफ कोर्स द ट्रेनिंग प्रोग्राम्स फॉर स्क्रीनिंग एक्सेट्रा। इसमें हम ना सिर्फ अपना एफर्ट्स देंगे, लेकिन जहाँ जहाँ प्रपोजल्स आएगा, हमारे जितने कार्यक्रम हैं उसमें किस तरह से उनको अकोमोडेट कर पाएंगे, चाहे वो आर्टिकल 275 के तहत ग्रांट्स हों, चाहे वो STC कंपोनेंट में दूसरे मंत्रालयों से जो है हम आग्रह करके फाइनेंसेस को प्रोवाइड कर पाएँ। जितना हो सकता है हम अपनी तरफ से, ना सिर्फ हेल्थ मिनिस्ट्री की तरफ से, लेकिन मोटा की तरफ से भी हम अपनी कोशिश करेंगे। उसके अलावा मैं ये कहना चाहूँगी कि लैंग्वेज, क्योंकि ये डिसीज़ ट्राइबल कम्युनिटी में सबसे ज़्यादा पाया जाता है, तो लैंग्वेजेस में हम चाहेंगे कि ट्रांसलेशंस हो। जितने ट्राइबल लैंग्वेजेस में हमारा जितना भी मटेरियल है, ट्रेनिंग मटेरियल हो या वो awareness mmaterial ho, we would like to translate them into as many languages as possible. We call upon experts in this to please help us out in this respect also. And I really don't have much more to say on this except to say कि मध्य प्रदेश सरकार को बधाई कि इसको ऑर्गेनाइज किया गया और पहला कदम उठाया गया आफ्टर द बजट अनाउंसमेंट, और हम मिनिस्ट्री की तरफ से आग्रह हैं, अग्रेसित हैं कि जो है इसको आगे बढ़ा के 2047 से पहले ही अगर ये अचीव हो जाएगा, क्योंकि स्क्रीनिंग 7 करोड़ लोगों का होगा और साथ साथ ये हम जितना जल्दी इस लक्ष्य को हम अटेन कर पाएंगे वो अटेन करें। इसके साथ मैं आप सब लोगों को भी इस बजट अनाउंसमेंट के लिए बधाई देती हूँ। थैंक यू ऑल सो मच फॉर गिविंग मी दिस अपॉर्चुनिटी। थैंक यू।
धन्यवाद मैडम। आपने बहुत अच्छे से जो मल्टी सेक्टोरल और मल्टी स्टेक होल्डर अप्रोच है उसको बताया, और साथ ही साथ जो सरकार का कमिटमेंट है सिकल सेल डिजीज़ के लिए उसको भी आपने बहुत अच्छी तरह से हमें समझाया। धन्यवाद। और अब कार्यक्रम में आगे बढ़ते हुए मैं अनुरोध करना चाहूँगा माननीय डॉक्टर प्रभुराम चौधरी जी, लोक स्वास्थ्य एवं परिवार कल्याण मंत्री मध्य प्रदेश शासन से, कि वह सभा को उद्बोधित करें। सर।
आज ICMR के जो आयोजित इस कार्यक्रम में हमारे महामहिम राज्यपाल श्री मंगू भाई पटेल साहब कार्यक्रम में विशेष रूप से आज भोपाल हमारे इस कार्यक्रम में पधारे आदरणीय श्री अर्जुन मुंडा जी, जो केंद्रीय मंत्री जनजाति कार्य विभाग भारत सरकार, मंच पर उपस्थित हमारे श्री दीपक खांडेकर जी, जो कि अध्यक्ष हैं जनजाति प्रकोष्ठ के, हमारे विभाग के ACS श्री मोहम्मद सुलेमान साहब, हमारे इस कार्यक्रम में विशेष रूप से उपस्थित श्री ग्राहम सहजट जी, जो कि सिकल सेल ट्रस्ट के जैनिका से आज हमारे इस विशेष रूप से इस भोपाल में उपस्थित हैं। कार्यक्रम में उपस्थित मिस आर जया जी, अभी हमने जिनको सुना विनीता श्रीवास्तव जी, और उपस्थित सभी देवी और सज्जनों। जैसा कि अभी पूर्व वक्ताओं ने यहाँ पर सिकल सेल डिसीज़ के बारे में अपना प्रकाश डाला है, और मध्य प्रदेश ने महामहिम राज्यपाल महोदय जी के गाइडेंस में और हमारे मुख्यमंत्री शिवराज सिंह चौहान जी की लीडरशिप में हम लोगों ने जून से 21 से योजना बनाई सिकल सेल डिसीज़ के पेशेंट्स को आइडेंटिफाइड करने के लिए, ख़ासतौर से जनजातीय समुदाय में ये डिसीज़ होती है। और योजना बनाकर 15 नवंबर 2021 में हमारे आदरणीय प्रधानमंत्री श्री नरेंद्र मोदी जी के द्वारा हमने इसकी शुरुआत की, और 2 जिले जो हमारे ट्राइबल के अलीराजपुर और साहबगा है, जिसको पायलट के रूप में हम लोगों ने काम शुरू किया। जनजातीय गौरव दिवस के 100 वर्ष से जब प्रधानमंत्री जी के द्वारा अनाउंस किया, दोनों जिलों में हम लोगों ने काम किया, दोनों जिलों झाबुआ और अलीराजपुर में। अभी डिटेल में अभी हमारे मोहम्मद सुलेमान जी ने आपको यहाँ पर बताया कि दोनों जिलों में 8,26,000 गर्भवती महिलाओं और 6 माह से 18 वर्ष के बच्चों को सिकल सेल का पूरा स्क्रीनिंग हम लोगों ने किया, जेनेटिक काउंसलिंग भी, उसके प्रबंधन के लिए भी सिकल सेल का जो प्रोजेक्ट हम लोगों ने बनाया था, और इसको 6 माह के अंदर 31 जुलाई 2022 तक हमने इसको पूर्ण समय सीमा में 6 मंथ में इसको कंप्लीट किया, और 9,17,000 जनसंख्या का पूरा स्क्रीनिंग दोनों डिस्ट्रिक्ट में करने के बाद जो पॉजिटिव पाए गए उनके सैंपल का पुष्टिकरण भी हम लोगों ने डिस्ट्रिक्ट में किया, और जो केस पाए गए 16,993 सिंगल तो कैरियर थे और 1,262 इसमें रोगी पाए गए थे। इनको जिला स्तर पर संचालित एकीकृत उपचार केंद्रों में प्रबंधन और उपचार की व्यवस्था हम लोगों ने उन जिलों में वहाँ पर की। दवाइयाँ हाइड्रोक्सी यूरिया फॉलिक एसिड का वितरण और आवश्यकता पड़ने पर निःशुल्क हम लोगों ने ब्लड ट्रांसफ्यूजन भी किया जा रहा है। स्क्रीनिंग में पॉजिटिव पाए परिवार के व्यक्तियों को भी, अन्य सदस्यों का भी, अगर किसी परिवार में एक व्यक्ति भी अगर पॉजिटिव पाया तो उसकी पूरी फैमिली को हम लोगों ने उसकी स्क्रीनिंग की है। द्वितीय चरण में मध्य प्रदेश के सभी जितने हमारे ट्राइबल ब्लॉक हैं, 89 ब्लॉक मध्य प्रदेश में ट्राइबल ब्लॉक हैं, इनको सिकल सेल एनीमिया का कार्य को लक्ष्य हम लोगों ने बनाकर और जनजाति, अनुसूचित जनजाति के समस्त व्यक्ति, समस्त गर्भवती महिलाएं और पॉजिटिव पाए जाने उनके परिवार के समस्त सदस्य, अगर किसी परिवार में एक व्यक्ति पॉजिटिव पाया जाएगा तो उसके सारे परिवार की पूरी स्क्रीनिंग करके आयु वर्ग और लक्षित जो हमारी है उसमें किए जाने के लिए मंत्रिपरिषद से भी, कैबिनेट से माननीय मुख्यमंत्री जी की अध्यक्षता में इसको हम लोगों ने वहाँ पर पास किया है। इसका लगभग 94,18,000 की जनसंख्या को स्क्रीनिंग करने का 2 वर्ष का हम लोगों ने अवधि के लिए इसका पूरा प्रोग्राम बनाकर तैयार किया है। और आउटसोर्स की संस्था के भी चयन के लिए भी प्रक्रिया हम लोग अभी चला रहे हैं, जिससे कि जो 2022-23 में राज्य मद से मध्य प्रदेश में हम लोगों ने 9.63 करोड़ राशि की भी स्वीकृति प्राप्त हम लोगों को हुई है। और इसके पूरा गाइडेंस हमको जो ICMR के द्वारा, जबलपुर के द्वारा जो यहाँ प्रबंधन और प्रशिक्षण में पूरा सहयोग जो मिल रहा है, जिससे जो हमारे प्रबंधनीय जो कार्य हैं विकास खंडों में, चिकित्सीय जो स्टाफ है, साथ साथ में मैदानी कार्यकर्ताओं को भी हम लोग प्रशिक्षित कर रहे हैं। सिकल सेल जो हमारी आनुवांशिक, जो कि हम सब जानते हैं हेरिडिटरी ये बीमारी है, इसका स्क्रीनिंग किए जो व्यक्तियों का सिंगल सेल जेनेटिक काउंसलिंग भी हम लोग उनका करेंगे। जेनेटिक काउंसिल के कार्ड बनाकर जो कि जो कैरियर हैं या जो लोग डिसीज से पीड़ित हैं उन लोगों को पूरा कार्ड बनाकर उनकी जेनेटिक काउंसलिंग के लिए कार्ड के एक विशेष प्रकार का कार्ड हम लोगों ने बनाया है, जिसे महिला अथवा पुरुष द्वारा विवाह के पूर्व उसका मिलान करके उनको बताया जा सकता है, शिक्षित हम लोग कर सकते हैं कि इससे कैरियर है या पॉजिटिव है, उसके क्या दुष्परिणाम और आगे वाली पीढ़ी में ये रोग ना फैल सके, इसको भी हम लोग काम कर रहे हैं। और सिकल सेल एनीमिया की जो स्क्रीनिंग, रिपोर्टिंग, डेटाबेस, ट्रैकिंग, सिकल सेल, इसका पोर्टल भी हम लोगों ने बनाया है, जिससे कि सामुदायिक और पूरी संस्था स्तर पर स्क्रीनिंग करके, जांच करके ऑनलाइन उसकी पूरी एंट्री की जा सकती है और ट्रैकिंग करके उनका पूरा आगे के लिए भी इस पोर्टल के माध्यम से पॉजिटिव रोगियों का उपचार भी, प्रबंधन, रक्तदान, जेनेटिक काउंसलिंग, रिकॉर्ड पोर्टल ऑनलाइन दर्ज करके पूरी पॉजिटिव पाए जाने प्रकरणों का पूरा फॉलोअप आगे के लिए हम लोग इसको सुनिश्चित कर सकते। नवजात शिशुओं के लिए भी सिकल सेल एनीमिया का जो 72 घंटे के अंदर की जाने वाली विशेष जो जांच की सुविधा है, एम्स भोपाल में लैब की स्थापना की गई है। और आदिवासी इलाकों के नवजातों के लिए जो 72 आवर्स के अंदर की जाने वाली जांचों के लिए एम्स के द्वारा प्रशिक्षित हम लोग अमले को कर रहे हैं। टीम पूरा जो कि झाबुआ और अलीराजपुर में भी किया गया है। महामहिम राज्यपाल महोदय ने हम लोगों को प्रेरित भी किया है और अनेक बार तो राजभवन में बुलाकर हमारी टीम को, हमारे डिपार्टमेंट के अधिकारियों को, हमको और प्रेरित, और उन्होंने पूरी इसको गंभीरता से लेने के लिए जो निर्देश दिए उसके अनुसार हम लोग लगातार आज काम कर रहे हैं। और पूरे 89 ब्लॉक को अब तो भारत सरकार ने भी इस साल के बजट में 2047 तक पूरी तरीके से एलिमिनेशन करने के जो बजट में शामिल भी किया है। तो मध्य प्रदेश में पहले से ही शुरुआत महामहिम राज्यपाल जी की प्रेरणा से और हमारे मुख्यमंत्री जी का भी पूरा सपोर्ट और इसमें काम करने के लिए हम लोगों के लिए निर्देशित वो करते रहते हैं, जिससे अब पूरी जो हमारे जितने ब्लॉक हैं 89 पूरे में प्रोग्राम बनाकर और वहाँ की पूरी पॉपुलेशन को हम लोग स्क्रीनिंग करेंगे, प्रबंधन करेंगे और उनका मैनेजमेंट करेंगे, जिससे कि इसका रोकथाम किया जा सके। आज यहाँ और भी हमारे कई जैसे जो विचार विमर्श होगा और जी दिशा निर्देश जिस तरीके से और गाइडलाइन हम लोग बनेगी, उसमें समय समय पर उसमें हम सुधार करते रहते कि और बेहतर तरीके से कैसे हम लोग मैनेज करके और हमारे जो सिकल सेल के जो भी पेशेंट हैं या कैरियर हैं उनका मैनेज कर सकें। बहुत बहुत धन्यवाद। जय हिंद, जय भारत।
बहुत बहुत धन्यवाद माननीय मंत्री जी। आपने हम सभी को सिकल सेल के प्रबंधन के क्षेत्र में जो प्रगति हो रही है हमारे मध्य प्रदेश स्टेट में, उससे अवगत कराया। बहुत बहुत धन्यवाद सर। और अब मैं अनुरोध करना चाहूँगा माननीय श्री अर्जुन मुंडा जी, केंद्रीय मंत्री जनजातीय कार्य मंत्रालय भारत सरकार से, कि वह इस मंच पे अपना जो उद्बोधन है वो दें सिकल सेल के क्षेत्र में। सर, अनुरोध है आपसे, कृपया मंच पे।
आज के इस सिम्पोजियम ऑन सिकल सेल डिजीज़ के संदर्भ में हमारे बीच महामहिम राज्यपाल मध्य प्रदेश आदरणीय मंगू भाई पटेल जी, राज्य सरकार में मंत्री डॉक्टर प्रभुराम चौधरी जी, हमारे दीपक खांडेकर जी, मोहम्मद सुलेमान जी, खास तौर से उपस्थित डॉक्टर ग्राहम जो सिकल सेल ट्रस्ट के अंतर्राष्ट्रीय ख्याति प्राप्त साइंटिस्ट हैं, आर जया जी, डायरेक्टर ICMR, उपस्थित सभी हेमाटोलॉजिस्ट, भोपाल और देश भर से आए हुए महानुभाव और सभागार में उपस्थित आप सभी देवी एवं सज्जनों, मैं सबसे पहले महामहिम राज्यपाल जी का, राज्य सरकार और राज्य के मुख्यमंत्री शिवराज चौहान जी का और साथ ही साथ इस कार्य में जुड़े हुए, चाहे वो ICMR के हों या यहाँ के ऐसे सभी प्रबुद्ध जनों का बहुत आभारी हूँ कि इस तरह का आयोजन एक रचनात्मक पहल का एक विस्तृत स्वरूप और नेतृत्व उभर कर सामने दिखाई दे रहा है। अभी महामहिम जी से बात हो रही थी तो देश के कई राज्यों में आदिवासी जनजाति समुदाय रहते हैं और उसमें अधिक ये समस्या है। इसके अलावा भी बहुत सारे समुदायों में है, पर जनजातीय क्षेत्र में अधिक है। और मध्य प्रदेश, जहाँ जनजातीय आबादी की संख्या पहले के आंकड़ों के अनुसार 2011 के सेंसस के अनुसार 1.5 करोड़, लेकिन अभी लगभग वो बढ़कर 1,80,90 लाख हो गई होगी, ऐसा अभी बातचीत में चर्चा में आई। तो ये जो इनिशिएटिव है, ये जो प्रयास है, इस प्रयास का सराहना करता हूँ कि मध्य प्रदेश ने वास्तविक रूप से आदरणीय महामहिम राज्यपाल के नेतृत्व में और अधिक मुखर तरीके से इस कार्य योजना को आगे बढ़ाते हुए नेतृत्व कर रहा है। जबलपुर में बहुत पहले से इस संबंध में एक केंद्र भी खोला गया है और उस पर भी कार्य हो रहा है। डॉक्टर दास से हम सुबह में मिले थे और मैं समझता हूं कि अब ये समय आया है कि हमें पूरे देश में, पूरे देशवासी को और खासकर जनजातीय क्षेत्रों में इसे समाप्त करने की दिशा में जो माननीय प्रधानमंत्री जी ने आह्वान किया है उसके साथ चलना चाहिए। और जिस तरीके से हम शरीक हो रहे हैं, सम्मिलित हो रहे हैं, हमें आशा है कि इस बार न केवल बजट में हमने चर्चा किया है बल्कि हमने एक दूरदृष्टि के साथ, एक विजन के साथ इस दृष्टिकोण को अपनाया है कि 2047 के पहले पहले जब हम 100 साल मनाएंगे तो देश में इस तरह के वंशानुगत जो समस्या है वो पूर्ण रूप से सिकल सेल फ्री कंट्री के रूप में अपने आप को पाएंगे, अपने आप को सुनिश्चित कर सकेंगे। कुल मिलाकर मध्य भारत का अधिकांश हिस्सा इससे प्रभावित है। मध्य भारत नहीं, दक्षिण के प्रांतों को भी, या ये हम कह सकते हैं कि पुराने ज़माने में जो साहित्यिक दृष्टि से जिस क्षेत्र को कहा गया उसे दंडकारण्य कहा गया। ये जो दंडकारण्य क्षेत्र है वो तमिलनाडु से, आंध्रा से लेकर नेपाल तक, मध्य भारत से होते हुए नेपाल तक जाती है। तो वो पूरा क्षेत्र इससे प्रभावित है। और जब आप जाएंगे देखेंगे इसका, मैं जिस तरीके से सिक्किल होती है उसी तरीके से मैप में भी ये सिक्किल की तरह दिखती है। तो ये पूरा एरिया इससे प्रभावित है। हमारे लिए अवसर के रूप में खुशी की बात यह है कि हम इस पीढ़ी में इसको एक लक्ष्य लेकर चल रहे हैं। दुर्भाग्य इस बात का है कि पिछले कई वर्षों में हमने इसको उतना गंभीरता से नहीं लिया जितनी गंभीरता से लेना चाहिए। लेकिन सौभाग्य इस बात का है कि अब हम अवसर के रूप में समाधान का रास्ता ढूंढते हुए इस तरह के आयोजनों के माध्यम से हमें भी मौका मिल रहा है और इस डिजीज को खत्म करने के लिए संकल्प भी देश ले रहा है। इसके दो जो पक्ष हैं उन दोनों पक्ष में कैसे बेहतर तरीके से कार्य हो, ये हमें ज़्यादा से ज़्यादा अपने कार्यक्रमों में देखना चाहिए। एक पार्ट है जब हम इस तरह के कॉन्फ्रेंस करके इसे प्री और पोस्ट दोनों का समाधान के लिए प्रयास कर रहे हैं, लेकिन एज ए होल कैसे जागरूकता बढ़े और जागरूकता के माध्यम से इसका समाधान को और मजबूती दे सके, ये पक्ष भी हमारे लिए बहुत जरूरी है। कई तरह की विसंगति, कई तरह के समस्या, कई तरह के उलझन इस कारण से भी हमारी बढ़ जाती है कि हम इस विषय को सही तरीके से जागरूकता के दृष्टि से न हम पहुंच पाते हैं न पहुंचा पाते हैं। अब जब हम ट्राइबल एरिया की बात करते हैं तो हमें इस बात का ध्यान ज़्यादा रखने की आवश्यकता है, या ये एक चैलेंज के रूप में लेने की आवश्यकता है कि जो ट्राइबल लाइफ स्टाइल है वो आइसोलेशन के साथ, आइसोलेटेड लाइफ लीड करता है, क्योंकि वो अपने स्थान पर रह करके खुश रहना जानता है। दुखी है फिर भी खुश है, कष्ट उनको हो रहा है लेकिन उसको इसके बावजूद भी अपने स्थान पर रह करके आनंद, अपने अंदर रह करके, अपने लोगों के बीच में रह करके उसी में वो आनंद ढूंढता है। तो कई बार ऐसे चीज़ों का कुछ लक्षण मिलने के बाद भी वो सोचता है कि वो तो ऐसे ही है, अब इसमें हम क्या कर सकते हैं, या भगवान का दिया हुआ, क्योंकि सभी लोग भगवान के दिए हुए ही मानते हैं, तो वो भी सोचता है कि हमें भी भगवान नहीं दिया। तो इस तरीके से वो जागरूकता का जो मापदंड है वो आज के दिन में सही तरीके से समझ नहीं पाता है, सुदूरवर्ती क्षेत्र में रहने के कारण। आज यदि हम एक एडमिनिस्ट्रेशन के दृष्टि से, जो माननीय प्रधानमंत्री जी हमेशा आकांक्षी जिला प्रबंधन के बारे में, तो आकांक्षी जिला यानी बैकवर्ड डिस्ट्रिक्ट, जहाँ अपॉर्चुनिटी है काम करने का, वो आकांक्षी जिला है। तो आकांक्षी जिला यदि आप देखेंगे देश में अधिकांश तो ट्राइबल एरिया है। अब उन ट्राइबल एरिया में डेफिशिएट होने के कारण, खास करके हेल्थ फैसिलिटी, डॉक्टरों का अभाव, स्कूल्स या ऐसे मौलिक सुविधाएं वहाँ तक नहीं पहुँची। तो एक गैप तो पहले से ही है, और दूसरा गैप है डिजीज बेस्ड अवेयरनेस का, वो अवेयरनेस नहीं है। तो दोनों तरीके से एक बड़ी समस्या उन क्षेत्रों में काम करने के लिए हमारे सामने है। तो हमें इस पर ज़्यादा काम करने की आवश्यकता है कि हम इन दोनों बातों को ध्यान में रख करके किस तरह का अप्रोच अपनाएं, किस तरह का हम रोड मैप तैयार करें, क्योंकि हमने जो लक्ष्य रखा है उस लक्ष्य को तभी हम पूरा कर सकते हैं जब उसके गैप एनालिसिस को हम सही ढंग से कर सकते। हमारे सामने तीसरा जो सामने बातें आई है स्क्रीनिंग की। अब स्क्रीनिंग की जो समस्या है वो भी तब तक नहीं हो पाएगा जब तक उसके इंफ्रास्ट्रक्चरल डेवलपमेंट, उसके मेन पावर। अब माननीय प्रधानमंत्री जी के आह्वान पर इस संबंध में एक बृहद कार्यरूप कैसे बने उसका प्रयत्न किया गया है, और उस प्रयत्न में हमें लगता है कि एक तरफ जो मेडिकल साइट है वो अपने गति से चले, उसमें कितना मोमेंटम हो सकता है, कितना हम आगे बढ़ा सकते हैं। दूसरा है कि हिंदुस्तान में, इस देश में जो इंस्टीट्यूशनल लेवल पे जो काम करने वाली ऐसे तबके, ऐसी संस्थाएं, उन लोगों का इन्वॉल्वमेंट कैसे बढ़े। एक सरपंच क्या कर सकता है, एक ग्राम सभा का अध्यक्ष क्या कर सकता है, एक ब्लॉक लेवल में इलेक्टेड रिप्रेजेंटेटिव क्या कर सकता है, ट्रेडिशनल हेडमैन क्या कर सकता है। इन सारे चीज़ों पर मॉड्यूल हम कैसे तैयार करें जो साधारण तरीके से अपनी भाषा के आधार पर उसका समझ बढ़े। ये जागरूकता का पक्ष मजबूती के साथ हम कैसे पहुंचा सके, ये भी हमारे लिए एक बहुत बड़ा दायित्व, चुनौती भी है और अवसर भी है। तो मैं समझता हूं कि इस मामले में हमें इस बात पर ध्यान रखना चाहिए। तीसरी बात है कि दुनिया में यदि आप जनजाति समुदायों की आबादी देखें तो कई देश के तुलना में सबसे अधिक जनजाति समुदाय भारत में है। बहुत सारे ऐसे कंट्रीज हैं जहां इतने बड़े पैमाने पर इतने समुदाय, यानी कंट्री के दृष्टि से यदि देखें तो जिन कंट्रीज में एथनिक ग्रुप है वहां से भी अधिक भारत की आबादी है। एथनिक दृष्टि से जो ग्लोबली जो रिपोर्ट आता है वो 41 करोड़ की आबादी आती है, उसका 28 to 30% इंडिया में ही है। तो इतनी बड़ी आबादी है, इस आबादी को कैटर करने का ये स्कीम है। तो ये बहुत बड़ा कार्य योजना जिसको चैलेंज के रूप में लिया गया है। जनजातीय समुदायों के अंदर जो एक अपनी व्यवस्था है, उस व्यवस्था के आधार पर चीज़ों को कैसे हम सही ढंग से अधिरोपित कर सके कि यह सुनिश्चित हो कि स्वयं से इसके बारे में ज़्यादा से ज़्यादा उनकी सक्रियता बढ़े। तो एक जो रिसर्च पार्ट है हमारे सामने, जैसे अभी बताया गया कि उन्होंने लगभग इंडिया में, भारत में 28 बार भारत का दौरा किया, डॉक्टर ग्राहम। तो इस तरह से आप सभी भी यहाँ पर मैं देख रहा हूँ, सभी हेमाटोलॉजिस्ट हैं, सभी एक्सपर्ट्स हैं और ICMR के लोग हैं और बहुत सारे इस क्षेत्र में काम करने वाले स्वयंसेवी संस्थाएं हैं। तो ये सारे संस्थाओं के साथ मिल कर के कोलैबोरेटिव वे में हम कैसे इस बात को ध्यान में रखते हुए कि एक पार्ट है जो नए रिसर्च में क्या आ सकता है, उसके अनुसार हम कैसे पोस्ट लेवल पे काम करने के लिए हम ज़्यादा बेहतर प्रबंधन कर सके या हम इस तरह की चीज़ों को अपना सके। दूसरा यह है कि अवेयरनेस हमारा कैसे बढ़े। तीसरा है कि अभी जो डेटा बनाने के लिए जो इंफ्रास्ट्रक्चर, उसको हम अच्छे ढंग से जल्दी कैसे करें। और मुझे इस बात की प्रसन्नता है कि मध्य प्रदेश ने इसमें लीड लिया है और समय समय पर महामहिम गवर्नर महोदय से हमारी बातचीत होते रहती है और वो लगातार इस बात की चर्चा करते हैं कि मैं तो बहुत सारे डिस्ट्रिक्ट प्रोग्राम में तभी जाता हूँ जब लोग वहाँ पर हेल्थ कैंप के साथ स्क्रीनिंग प्रोग्राम भी रखते हैं। तो ये एक बहुत बड़ा इनिशिएटिव मैं समझता हूँ कि महामहिम गवर्नर का है और मैं इसके लिए मैं उनका आभारी हूँ। मैं उसको बहुत बहुत धन्यवाद भी देता हूँ कि इस तरह का इनिशिएटिव मैं समझता हूँ कि एक जो गवर्नेंस के दृष्टि से इलेक्टेड रिप्रेजेंटेटिव के द्वारा गवर्नमेंट के विल के साथ गवर्नमेंट चलती है, लेकिन एक जो खास करके विशेष रूप से ट्राइबल एरिया के जो एडमिनिस्ट्रेशन है उसमें गवर्नर का स्वास्थ्य और शिक्षा के प्रति बहुत बड़ा एक रोल है और जिस रोल को मैं समझता हूँ कि सबसे बेहतर तरीके से मध्य प्रदेश गवर्नर पूरा कर रहे हैं और ये सारी चीज़ें आगे बढ़ रही है। आने वाले दिनों में हमें बहुत सारी चर्चा करनी है और मैं अपने मंत्रालय में भी, क्योंकि इसके बारे में हमने कई बार चर्चा किया है, कई स्तरों पर चर्चा किया है और हमारे इन चर्चा के माध्यम से स्वास्थ्य मंत्रालय के साथ मिलकर के इसे एक स्पेशल प्रोग्राम के रूप में लॉन्च किया गया है और हमारी कोशिश यही है कि हम जितने देश के ऐसी संस्थाएं हैं, जितने ऐसे लोग हैं, चाहे वो इलेक्टेड रिप्रेजेंटेटिव हो या ट्रेडिशनल हेडमेन्स हो या स्वयंसेवी संस्था हो या जो जैसे आंगनबाड़ी सेविका हैं, सहायिका हैं, सहिया हैं, इस तरह के जितने भी लोअर लेवल में सीधे गांव से, कस्बों से, टोले मोहल्ले से जुड़े हुए लोग हैं, उसको इन्वॉल्व ज़्यादा से ज़्यादा कैसे करें। कई बार ऐसा होता है कि सरकारी स्तर पर एक स्कीम बन जाती है, घोषणा भी होती है, लेकिन वो गतिशील इसलिए नहीं हो पाती है क्योंकि इन्वॉल्वमेंट उसमें जितना होना चाहिए वो नहीं हो पाता है। हमें इस कार्यक्रम को एक स्कीम के रूप में नहीं देखना है, बल्कि भारत को एक स्वस्थ समाज बनाने की दृष्टि से जो विज़न हमने 2047 के लिए देखा है कि हर तरह से भारत सक्षम बनेगा, उस दृष्टि से हम सबको, और मैं खास करके यहाँ जो स्टूडेंट्स आए हैं या सिकल सेल से रिलेटेड काम करने वाले संस्थाएं आए हैं या ऐसे जो पीड़ित लोग हैं वो आए हैं, मैं यही आग्रह करूँगा कि हम सब मिल कर के हम यह कोशिश करें कि जागरूकता ज़्यादा से ज़्यादा कैसे फैले, क्योंकि कई बार जैसे ब्लड डिसऑर्डर में यह होता है कि ब्लड की कमी दिखती है शरीर में कि वो पीलिया हो गया, जॉन्डिस की तरह हो गया, तो लोग देहातों में, गांव में, कस्बे टोले में ऐसा कहते हैं कि कोई प्राकृतिक दृष्टि से कोई भूत प्रेत का ये है जिसके वजह से इस तरह का ये हो रहा है। और देहात में कहते हैं कि कोई ऐसा जिन घुस गया है जिसमें भूत जो है उसका ब्लड चूस रहा है, और ऐसे करके पूजा पाठ करने में हम ज़्यादा व्यस्त हो जाते हैं। हमें यह समझना चाहिए कि इस वंशानुगत तरीके से शरीर में जो मशीन काम कर रहा है वो डिफेक्ट होने की वजह से ये प्रॉब्लम हो रहा है, उसको हम कैसे ठीक करें। और उसको दो तरीके से ठीक कर सकते हैं। एक कि आने वाले दिनों में जो हमें काउंसलिंग के माध्यम से सतर्कता बरतना चाहिए वो, और दूसरा यदि हो गया है तो उसका प्रॉपर वे में ट्रीटमेंट के जो साधन है वो हम लोगों तक कैसे पहुंचा सके और कैसे पहुंचाए लोगों को, इसके प्रति जागरूकता ज़्यादा से ज़्यादा हो तो हम इस मामले को बेहतर एवं प्रभावी बना सकते हैं। और जो हम सबका संकल्प है, मैं तकनीकी बहुत सारे विषय अभी आएंगे, मैं लास्ट में इस पर चर्चा करेंगे जब रिपोर्ट आपकी बनेगी। तो रोड मैप हमारा जल्दी से जल्दी बने, आपके अच्छे से अच्छे सुझाव के साथ मैं आप सबको आमंत्रित करता हूं कि लगातार इससे जुड़ करके कार्य करते रहें। मैं समझता हूं कि इससे बड़ा कार्य एक मनुष्य के लिए संसार में कुछ नहीं है जब हम मानवीय संवेदना के साथ जुड़ करके इस योजना को देखें। इन्हीं शब्दों के साथ बहुत बहुत धन्यवाद।
धन्यवाद माननीय मंत्री जी। आपने सिकल सेल रोग के उन्मूलन के संकल्प पर हमारा ध्यान आकर्षित किया एवं जनजातीय क्षेत्रों में जो जागृति एवं जन सहभागिता की ज़रूरत है उस पर जोर दिया। बहुत बहुत धन्यवाद सर। और अब मैं कार्यक्रम के अगले पड़ाव में अनुरोध करता हूँ माननीय राज्यपाल महोदय आदरणीय श्री मंगू भाई पटेल जी से कि वह हम सभी को सभा में उद्बोधित करें। सर।
सभी को नमस्कार। आईसीएमआर सिकल सेल संगोष्ठी कार्यक्रम में अपने बीच उपस्थित केंद्रीय आदिजाति विकास मंत्री श्री अर्जुन मुंडा जी, मध्य प्रदेश स्वास्थ्य मंत्री श्री प्रभुराम चौधरी जी, सिकल सेल ट्रस्ट जमैका से अपने मेहमान डॉक्टर ग्रेहम सार्जन जी, अध्यक्ष जनजाति प्रकोष्ठ मध्य प्रदेश श्री दीपक खांडेकर जी, अपर मुख्य सचिव स्वास्थ्य विभाग मोहम्मद सुलेमान जी, अतिरिक्त MOTA नई दिल्ली से पधारे सुश्री आर जया जी, दिल्ली से पधारे हुए अधिकारी और मध्य प्रदेश के सभी अधिकारी गण, ICMR जबलपुर के डायरेक्टर श्री अपरूप दास जी, कार्यक्रम में पधारे सिकल सेल के विशेषज्ञ एवं स्वास्थ्य विभाग के सभी बंधु भगिनी, भाई और बहनों, प्यारे बच्चों, पत्रकार मित्रों, ICMR आयोजित सिकल सेल संगोष्ठी में उपस्थित केंद्रीय आदिजाति विकास मंत्री श्री अर्जुन मुंडा जी, मध्य प्रदेश के स्वास्थ्य मंत्री प्रभुराम चौधरी जी, प्रमुख मेहमान श्रियों और सिकल सेल की अच्छी तरह जानने वाले, भारत भर में अभियान चलाने वाले ऐसे डॉक्टर ग्रेहम सार्जन जी अपने बीच उपस्थित है। मैं बहुत सालों से उनको जानता हूं। गुजरात का उन्होंने बहुत बार दौरा किया। यहाँ गुजरात के 2 डॉक्टर भी बैठे हैं, डॉक्टर ज्योतिष पटेल और डॉक्टर इटालिया, और कई डॉक्टर वहाँ है उन्होंने भी जब भी प्राइम मिनिस्टर नरेंद्र भाई नवसारी और गुजरात में थे, तभी जो काम हुआ है गुजरात में, अभी 2 महीने पहले भी मैंने गुजरात से पेपर हमारे वहां आता है, उसमें मैंने पढ़ा कि गुजरात में अभी सिकल सेल को थामा गया है। ये सभी प्रयत्न जो करने वाले हैं और जिसकी प्रेरणा मिली है हमको, मैं समझता हूं कि गुजरात में जो काम हुआ उसका यश किसी को जाता है तो प्राइम मिनिस्टर नरेंद्र भाई को जाता है। क्योंकि जब से उनको मालूम पड़ा कि ट्राइबल में सिकल सेल है, तो सभी मंत्री को, अधिकारी को, ऐसे स्वैच्छिक संस्था है, उन सभी को उन्हें बुलाकर मीटिंग करके किसी भी तरह ट्राइबल में अनुवांशिक सिकल सेल है उसको थामना है। और आज भी मैं समझता हूं कि यहाँ जो मैं राज्यपाल के नाते से आया, तभी से मैं समझता हूं कि मेरा एक प्रथम कर्तव्य है कि जिस समाज में से मैं आता हूं, उस समाज में इतना बड़ा जो सिकल सेल अनुवांशिक रोग पड़ा हुआ है, उसके लिए मेरे को कुछ करना चाहिए। एक बार केंद्र के डॉक्टर मनसुख मांडविया जी जो आरोग्य मंत्री हैं, उनको मैंने बोला कि मनसुख भाई, कोरोना 100 साल के बाद आया मगर सारी दुनिया को हिलाकर गया। हमारे ट्राइबल के लिए कोरोना से खतरनाक ये सिकल सेल एनीमिया है, कई सालों से चल रहा है, बहुत से प्रयत्न भी हुए मगर अभी तक हमें उसमें क्योरेबिलिटी नहीं मिली है। और लास्ट टाइम जबलपुर में सिकल सेल विश्व दिन था, तभी वो आए भी। अभी सभी को जानकारी हो गई कि मध्य प्रदेश में सिकल सेल थामने के लिए क्या करना अपना बहुत जरूरी। और आज मुंडा जी यहां आ गए। मुंडा जी को बहुत सालों से मैं जानता हूं, वो झारखंड के मुख्यमंत्री रहे, कई सालों से ट्राइबल की चिंता कर रहे। ग्रहम सार्जन जी भी यहां आए। 2 दिन की संगोष्ठी है यहां। आप सभी डॉक्टरों, स्वैच्छिक संस्था वाले भी सब मिलकर एक अच्छी तरह से उसमें से निष्कर्ष निकलेगा और सिकल सेल को कैसा थामा जाए उसके लिए आप चिंता करने वाले हैं। इसलिए मैं बहुत बात नहीं करूंगा, मगर आज मेरे तो देश के प्रधानमंत्री नरेंद्र मोदी जी का मैं बहुत आभारी हूं कि उन्होंने आदिवासी में चल रही अनुवांशिक बीमारी सिकल सेल के उन्मूलन के लिए बजट में प्रावधान किया और सिकल सेल थामने के लिए आयोजन किया। मध्य प्रदेश के प्रथम नागरिक के रूप में उनको बहुत बहुत बधाई देता हूं और आभार भी मानता हूं। जैसे मैं मध्य प्रदेश का राज्यपाल बना तो मैंने सिकल सेल की जांचकारी शुरू कहां से किया? मेरे राजभवन से ही किया। मैंने राजभवन में जो बाग में काम करने वाले हैं 55 लोग हैं, उसकी मैंने जांच करवाई। तो 55 लोग में 13 लोग वाहक निकले और 2 डिसीज वाले निकले। मैंने घर से शुरुआत किया। कभी बोलता है ना कि दान देना है तो अपने पहले अपने दो, बाद में दिखाओ। उसी तरह कामकाज शुरू किया। राजभवन में ही मुख्यमंत्री और 4 ट्राइबल मंत्री को इकट्ठा किया। डॉक्टर इटालिया को गुजरात से बुलाया और प्रेजेंटेशन किया कि सिकल सेल ये क्या है। ट्राइबल को खुद को मालूम नहीं है कि सिकल सेल क्या है। उसके अवेयरनेस के लिए, जागरूकता के लिए बहुत कुछ काम करना है। और मैं मध्य प्रदेश सरकार का भी आभार मानता हूं कि बहुत अच्छी तरह शुरुआत किया झाबा अलीराजपुर से, और आज 20 डिस्ट्रिक्ट में काम चल रहा है। बहुत सी आवश्यकता है मगर काम तो चल रहा है। मैं कभी कभी अधिकारियों से भी बात करता हूं कि भैया जांच करना है तो कैसा करके करें। पहले आंगनवाड़ी में जाओ, छोटे छोटे बच्चे हैं, 25-30 बच्चे होंगे, उसमें देख लो आप कि किसी को सिकल सेल तो नहीं है, दूसरा कोई और तो नहीं है। सगर्भा माता पोषण आहार के लिए सप्ताह में 1 दिन आती है, वह समय में सगर्भा माता को भी जांच कर लो। बच्चे को दिखाई दिया सिकल सेल तो सीधा घर पे जाओ, और बच्चे के घर पे जाना चाहिए। उनके कौन से पेरेंट्स में किसको है, माँ बाप को दोनों का हो, एक को है। सगर्भा माता है तो उनको जांच करो, उनके घर में दूसरे बच्चे कौन कौन है, उसको सिकल सेल है क्या, वाहक है क्या। प्राथमिक शाला में जाओ, माध्यमिक शाला में जाओ, कॉलेज में जाओ, हमने गुजरात में सब प्रयोग किया हुआ है। मगर घर के हर एक लोग को जांच करेंगे। मैं समझता हूं, यह मुंडा जी ने भी बोला कि सरकार का एक विभाग ही काम करेगा, ऐसा नहीं है। कोई संस्था सेवाभावी है, उसको भी करना पड़ेगा, सरपंच को भी करना पड़ा, चुने हुए लोगों को भी करना पड़ेगा। बहुत सी शक्तियां लगानी पड़ेगी। प्राइम मिनिस्टर बोलते हैं सबका साथ, सबका विकास, सबका विश्वास पहले था, अभी उसमें जोड़ दिया सबका प्रयास। तो हम सब कर सकेंगे। बाल मंदिर में जाना है, बाद में उनके घर पे जाना है, सगर्भा माता है उनके भी संभालना है, उनके जो दूसरे बच्चे हैं उसको भी देखना है। ये काम छोटा नहीं है। मैंने खुद बहुत नजदीक से सिकल सेल को जाना है, बहुत नजदीक से। मेरे सामने कहीं बच्चे का डेथ हो गया, उसमें से जो मेरी संवेदना को ठेस पहुंचा कि क्या है। ट्राइबल के लिए मैं समझता हूं बहुत खतरनाक है, यहां बताया ना कि, और मैं समझता हूं कि देश में भी हाईएस्ट पॉपुलेशन मध्य प्रदेश में ट्राइबल की होगी। कैसे तरह निपटाएंगे, कितनी अवेयरनेस की जरूरत है। कई बार मैं बोलता हूं अधिकारियों को भी कि भैया प्रचार करो तो गांव में जाकर नुक्कड़ करो, माँ बाप को इकट्ठा करो और नुक्कड़ से समझाओ कैसा ये सिकल सेल है, कैसे शुरू होता है, अनुवांशिक है, माँ बाप को होगा तो बच्चे में आएगा आएगा आएगा। गुजरात में हम बोलते हैं, यहां भी मैं बोलता हूं कि जब सगर्भा माता होती है तो पहले महीने से चेक करो, और तभी से स्क्रीनिंग किया, तुरंत इलाज भी होना चाहिए। स्क्रीनिंग हो गया, बाद में इलाज तुरंत नहीं होगा तो रोग आगे बढ़ते जाएगा। कई बच्चे ऐसे होते हैं जिसका मत्था बड़ा हो जाता है, उधर बड़ा हो जाता है, हाथ देखो तो एकदम शुक्ल लकड़ी, पकड़ो तो टूट जाएगा, ऐसा मालूम पड़ता है। ऐसे कई बच्चे को देखा हुआ। वो बच्चे को माँ बाप भेजते हैं स्कूल, बच्चे को इतना दुख होता है, क्या पढ़ेगा बेचारा। ये माँ बाप को सबको मालूम है, मगर उसको मालूम नहीं है कि सिकल सेल है। और ट्राइबल का स्वभाव है एकदम सामने से तुम्हारे पास नहीं आ जाएंगे, सभी को इकट्ठा होकर काम करना पड़ेगा। और स्क्रीनिंग हुई तो इलाज कैसे हुआ। सगर्भा माता को ये पेट में बच्चा है, स्क्रीनिंग होगा तो उनको सलाह देंगे डॉक्टर कि आपको अभी सिकल सेल है, इसलिए दवाइयां लेनी पड़ेगी। मगर उनके घर दूसरा बेटा है, वो सिकल सेल से ग्रस्त हुआ है, उसके लिए माता पिता को भी समझाना पड़ेगा कि एक बच्चा तो घर में तुम्हारा है सिकल सेल वाला, दूसरा बच्चा चाहते हो कि ऐसा ही देखने के लिए। और जब भी माँ बाप का दिल का टुकड़ा चला जाता है तो कितना दुख होता है। 5 साल का बच्चा, 10 साल का बच्चा, मैंने एक परिवार में ऐसा देखा है, एक 4 साल की बच्ची और एक 12 साल की बच्ची, ऐसे इतनी स्वरूपमान बच्चियां, 2-3 दिन टेम्परेचर आया और चली गई। मैंने ये भी देखा है कि कई बार ऐसा बोला जाता है कि मां पर गया है, बाप पर गया है। वो परिवार में 2 पिताजी पर थे, पिताजी तो जिंदे थे, मगर उनकी दोनों बच्ची उन पर पड़ी थी, वो चली गई। और मां पर 2 बच्चे थे, एक बेटा तो एक बेटी थे, अभी करीब 40-45 साल के हैं, वो बच गए। ये कितना बड़ा काम है। कल चर्चा हुई थी, ये तो सर्वे की बात है, स्क्रीनिंग की बात है, इलाज की बात है, मगर आगे जाकर आप 2 दिन जो संगोष्ठी करेंगे, कई ऐसे विचार आप में आएंगे, उसी तरह इलाज का अपने का दिशा मिलेगी। मगर कई ऐसी दिक्कतें बच्चे को होती है, उसमें भी सावधानी रखने की जरूरत। कल चर्चा हुई थी, स्कूल में, छात्रालय में ज्यादातर बच्चे पढ़ते हैं, तो स्कूल में जाते हैं, मगर छात्रालय में रहना है तो सिकल सेल के बच्चे को ठंडा पानी से नहाना नहीं है, उससे भी वो बढ़ता है। एक बच्चा मैंने देखा पराग सागर का, माँ बाप को दोनों को वाहक थे, मगर बच्चा पैदा हुआ डिसीज वाला। और मेरे को मिलने जब भी आया था, मैंने बोला कि तुम तो अट्ठे कट्ठे लगता है, कहाँ तुम्हारा सिकल सेल है? नहीं है मेरे को, मेरी माँ बाप को वाहक था और उसमें से मैं सिकल सेल पैदा हुआ। और एक मेरा भाई जो है डॉक्टर है। अभी देखो, इसमें दूसरी दिक्कत ये भी है कि सारे जो अंग है, जो जॉइंट्स है, और जॉइंट्स भी वीक होते जाते रहते हैं। उठने बैठने में कितनी तकलीफ उनको रहती है। और खुद ही जाने दे, जिसको ऐसे बोला जाता है कि खुद का अनुभव है, डॉक्टर लोग पढ़े हुए हैं, सब जानते हैं, मगर जिसको दुख होता है वो कैसी तरह कितना है, तो उनकी दिक्कतें सुनो तभी में मालूम पड़ेगा कि क्या होता है। मैंने अनंतपुर में जो जनजातीय आयोग के यूनिवर्सिटी है, उसमें एक बार गया तो 4 बच्चे ऐसे आ गए थे, 2 बच्चियां और 2 बच्चा। उसका एकदम देखो तो पैर का घुटना एकदम टेढ़ा हो गया था, बच्ची को देखो तो एकदम पतली बच्ची, अगर जी गई तो क्या करेगी उसमें। ऐसे कई दिक्कतें पड़ी है, उसमें धीरे धीरे जाना है। मगर पहले हमको सारे मध्य प्रदेश में अभी बताया ना, 1,90,00,000 जितनी बस्ती है, जहां सिकल सेल है वहां सभी को मिलाकर एक एक को स्क्रीनिंग करके उनको इलाज करना, ये बहुत बड़ी जिम्मेवारी हमारे पर है। मैं समझता हूं कि मेरे को जानकारी जो है, कई सालों से एलोपैथी के अपना यूज कर रहे हैं दवाइयों के लिए। अभी आयुष मंत्रालय भी केंद्र ने बनाया है, मैं यहाँ के आयुष मंत्री से भी बात किया है कि सिकल सेल में आयुर्वेद को देखो। अगर आयुर्वेद में कोई दवा मिल जाती है तो होम्योपैथिक वाले, यहाँ डॉक्टर बैठे 2-3 मेरे से बात हुई है, होम्योपैथिक से भी मरीजों को अच्छा हो रहा है। हमारे वहां अतुल देसाई करके डॉक्टर है, जिसने सिकल सेल पे ही पीएचडी किया है। 12-15 साल से वो आयुर्वेदिक दवा दे रहा है और कई लोगों को उन्होंने बचाया है। कोरोना में कौन जानता था कि गिलोय काम आएगा? हम पेड़ में देखते थे गिलोय को। या मैं सरकार का कार्यक्रम में गया तो वन मंत्री ने बताया कि हमने 35 करोड़ का कावा पिलाया है कोरोना में। यानी कोरोना जैसे रोग में भी जो आयुर्वेद काम आता है, तो मैं समझता हूं सिकल सेल के लिए भी कोई न कोई इलाज मिलेगा हमको। मगर हमारा प्रयत्न जारी रखना चाहिए ये बहुत बड़ी जिम्मेदारी। अर्जुन मुंडा जी ने बताया ये सेवा का काम है। एक समझो तुम गरीब लोग को, अनपढ़ लोग को, पिछड़े हुए जाति के लोग को, कोई भी अच्छी तरह संवेदना सबके दिल में पड़ी हुई है भैया, किसी में ज्यादा है किसी में कम है, मगर जब भी अपने दुखी आदमी को देखता है तभी हम बैठ रहते हैं, मौज मजा में बैठेंगे तो नहीं चलेगा। इतना बड़ा समाज ये असरग्रस्त है, जहां भी जिसको भी संवेदना है उसके लिए कुछ ना कुछ करना चाहिए। मैं कई बार कॉन्वोकेशन में जाता हूं, पढ़े लिखे जब हमारे आदिवासी ट्राइबल बच्चे को देखता हूं तभी मैंने बोलता हूं कि जिस समाज में तुमने जन्म लिया है, इतने पढ़े लिखे हो, तुम्हारे को सिकल सेल की मालूम है, तो घर घर जाओ और अपने समाज के लोगों को इसमें से कैसे निकाले उसमें अवेयरनेस लाने की जिम्मेदारी है, ये करना चाहिए। दूसरी मैं बच्चों को ऐसा भी बोलता हूं कि जब भी शादी का समय आपका आएगा तभी ध्यान रखना, लड़की कितनी भी खूबसूरत हो, लड़का कितना भी पैसे वाला हो। कई बार देखते हैं ना पेरेंट्स, जो पढ़े लिखे पेरेंट्स क्या करते हैं, अपनी जन्मोत्तरी मिलाते हैं, ये बच्ची के साथ मेरा बच्चे का संसार तो अच्छा चलेगा, रहेगी तो सही, भागेगी तो नहीं। बच्ची के माँ बाप को लगता है कि भैया हमारा बच्चे को सुखी तो करेगी, बच्ची के माँ बाप को लगता है कि ये उनका हस्बैंड है, उसको अच्छी तरह रखेगा तो सही, जीवन बिताएगा तो सही। हमारा ट्राइबल में भी सभी को मैं बोलता हूं कि अपने जो सरकार ने जो कार्ड दिया है वो कार्ड मिलाओ, और कार्ड मिलाने के बाद दोनों को सिकल सेल है कभी शादी मत करें, दोनों को वाहक है तभी भी शादी मत करें। एक को डिसीज होगा, एक को वाहक होगा तो चलेगा, ये भी सभी को समझाना पड़ेगा। माननीय प्रधानमंत्री जी ने जो घोषणा किया हुआ है 2047 में हमको सिकल सेल वाला एक भी बच्चा पैदा नहीं हो, वो करना है, उसके लिए हमको काम करना है। कैसे दिल लगाकर संवेदना के साथ सभी को साथ लेकर कैसे तरह करे, वो एक बहुत बड़ा अपने पर चैलेंज है। मैं समझता हूँ 2 दिन में के कार्यक्रम में बहुत अच्छे विचार से कोई अच्छा निष्कर्ष निकलेगा, और मध्य प्रदेश मैं समझता हूँ कि जो प्रधानमंत्री ने घोषणा किया हुआ है उसमें हम अव्वल नंबर सबके साथ लेकर हम अव्वल नंबर पे रहेंगे, ऐसी अपेक्षा के साथ मैं मेरी बात पूरी करता हूं। आभार। भारत माता की जय।
बहुत बहुत धन्यवाद माननीय राज्यपाल महोदय जी का, जिन्होंने अपनी उनकी जो प्रतिबद्धता रही है सिकल सेल के प्रति उससे हमें अवगत कराया, और इनकी प्रतिबद्धता हम सभी के लिए प्रेरणीय है। और साथ ही साथ जो माननीय राज्यपाल जी ने ध्यान दिया कि जो ज़मीनी स्तर पर इस रोग का क्या रूप है उसको भी समझने की बहुत ज़रूरत है। बहुत बहुत धन्यवाद सर, आपने बहुत हमें जोश से भर दिया है, और 2047 के प्रति हम सभी सजग हैं। धन्यवाद सर। अब कार्यक्रम को आगे बढ़ाते हुए मैं अनुरोध करूंगा डॉक्टर अपूर्व दास जी का, जो कि निदेशक हैं ICMR नृत्य के, कि वह जो सिकल सेल डिजीज पेशेंट्स के लिए ट्रीटमेंट एंड फॉलो अप बुकलेट है उसका अनावरण करने के लिए कृपया उस बुकलेट को लाएं। और बहुत बहुत धन्यवाद मंचासीन सभी विशिष्ट अतिथियों का। अब मैं आग्रह करूंगा ICMR नृत्य के डायरेक्टर डॉक्टर अपूर्व दास जी से कि वह हमारे माननीय राज्यपाल महोदय जी का सत्कार करें एक पुष्पगुच्छ एवं स्मृति चिन्ह भेंट करके। अब मैं आग्रह करूंगा डॉक्टर राजनारायण तिवारी सर का, डायरेक्टर ICMR नीरे से, कि वह माननीय अर्जुन मुंडा जी का पुष्पगुच्छ एवं स्मृति चिन्ह भेंट करके सत्कार करें। धन्यवाद। अब मैं आग्रह करूंगा डॉक्टर प्रियंका दास जी से, जो कि MD NHM हैं, कि वह माननीय श्री प्रभुराम चौधरी जी का पुष्पगुच्छ एवं स्मृति चिन्ह के साथ सम्मान करें। अब मैं आग्रह करूंगा श्रीमती विनीता श्रीवास्तव जी का कि वह मंच पे आके डॉक्टर ग्राहम सर्जेंट सर का पुष्पगुच्छ एवं स्मृति चिन्ह के साथ सत्कार करें। डॉक्टर ग्राहम सर्जेंट सर, आई काइंडली रिक्वेस्ट यू टू, थैंक यू सर, थैंक यू सो मच। अब मैं आग्रह करूंगा डॉक्टर राजा सुब्रमण्यम सर का, साइंटिस्ट ICMR नृत्य से, कि वह मंच पे आके माननीय श्री मोहम्मद सुलेमान जी का पुष्पगुच्छ सर का सत्कार करें। धन्यवाद। स्मृति चिन्ह भी भेंट करके सर का सत्कार करें। अब मैं आग्रह करूंगा डॉक्टर रूबी खान जी का कि वह मंच पे आके हमारे बीच उपस्थित माननीय मिस जया जी का सत्कार करें। धन्यवाद। स्मृति चिन्ह भी अब मैं आग्रह करूंगा डॉक्टर रविंद्र कुमार का कि वह मंच पे आके श्री दीपक खांडेकर सर का सत्कार स्मृति चिन्ह एवं पुष्पगुच्छ दे के करें। डॉक्टर रविंद्र कुमार ही सूत्रधार हैं इस कार्यक्रम के, सो आप सभी से अब निवेदन है कि कृपया तालियों से उनका भी स्वागत करें। धन्यवाद। अब मैं रिक्वेस्ट करूंगा डॉक्टर प्रियंका दास जी का कि वह फॉर्मल वोट ऑफ थैंक्स प्रेषित करें।
धन्यवाद। सिकल सेल स्क्रीनिंग एवं प्रबंधन पर आयोजित आज की कार्यशाला में मैं आप सबकी गरिमामय उपस्थिति एवं बहुमूल्य समय के लिए आभार व्यक्त करती हूँ। विशेष रूप से मैं माननीय राज्यपाल महोदय जी का आभार व्यक्त करना चाहूँगी कि उनके मार्गदर्शन में एवं उनके बहुमूल्य सुझावों से मध्य प्रदेश में सिकल सेल मिशन में बहुत सारे कार्य निरंतर किए जा रहे हैं और उनके अनुभवों का हमको बहुत ज़्यादा मार्गदर्शन प्राप्त होता है। मैं आभार व्यक्त करना चाहूँगी माननीय केंद्रीय मंत्री जी, आदिम जातीय कार्य मंत्रालय भारत सरकार का, जिनके दिशा निर्देश एवं सतत सहयोग से प्रदेश में सिकल सेल उन्मूलन की दिशा में हम लोग अग्रसर हो रहे हैं। मैं आभार व्यक्त करना चाहूँगी माननीय स्वास्थ्य मंत्री जी मध्य प्रदेश शासन का, जिनके नेतृत्व एवं मार्गदर्शन में विभाग द्वारा सिकल सेल रोगियों के बेहतर उपचार एवं प्रबंधन सुनिश्चित किया जा रहा है। I would specially like to thank Dr. Sargent sir, and we are really honored to have his presence here, and I'm sure that we will learn from his expertise and guidance during this 2-day workshop. Sir, the doctors of Madhya Pradesh are very eager to hear you, and I'm sure we will be able to carve out a state-specific strategy for the disease in the state. मैं आभार व्यक्त करना चाहूँगी ACS सुलेमान सर का, जिनके द्वारा सिकल सेल स्क्रीनिंग एवं प्रबंधन की नियमित समीक्षा की जा रही है एवं उनके निर्देश पर विभाग द्वारा मैदानी स्तर पर इस प्रोजेक्ट का क्रियान्वयन किया जा रहा है। मैं जनजातीय कार्य मंत्रालय के अपर सचिव आर जया मैम एवं सलाहकार विनीता जी का भी आभार व्यक्त करना चाहूँगी, जिनके द्वारा समन्वित रूप से जनजातीय समुदाय को स्वास्थ्य लाभ उपलब्ध कराने हेतु वांछित सहयोग प्रदान किया जा रहा है। इसके साथ साथ मैं आभारी हूँ सर दीपक खांडेकर सर जी का, जो अध्यक्ष जनजातीय प्रकोष्ठ है, जिनका मार्गदर्शन हमें नियमित रूप से प्राप्त होता है, न केवल सिकल सेल बल्कि जनजातीय स्वास्थ्य के समस्त मुद्दों पर उनका मार्गदर्शन हमें प्राप्त होता है। मैं ICMR जबलपुर के निदेशक, ICMR निरे के निदेशक एवं पूरी ICMR टीम का आभार व्यक्त करना चाहूँगी, जिनके द्वारा इस कार्यशाला का आयोजन किया गया है, जिससे मुझे पूरी उम्मीद है कि मध्य प्रदेश के डॉक्टर्स और जो पधारे हुए पेशेंट्स हैं और हमारे छात्र हैं वो इसका लाभ उठा पाएंगे। मैं देश के विभिन्न राज्यों से आए हुए विशेषज्ञों का भी आभार व्यक्त करती हूँ, जिनके द्वारा आज के कार्यशाला में बहुमूल्य उपस्थिति दी गई है। निश्चित रूप से आप सबके परामर्श एवं सुझावों से समस्त सिकल सेल रोगों के स्वास्थ्य जीवन शैली को लाभ प्राप्त होगा। प्रदेश के समस्त जिलों से आए हुए स्वास्थ्य विभाग के चिकित्सक, स्वास्थ्य कर्मी, सिकल सेल रोगियों का भी आभार व्यक्त करना चाहूँगी कि जो उपस्थित होकर इस सम्मेलन में भाग लिए हैं और निश्चित रूप से उनको भी इस सम्मेलन से बहुत सारी जानकारियाँ प्राप्त होंगी जो उनके डे टू डे लिविंग में फ़ायदेमंद होगी। आखिर में मैं सबसे ज़्यादा आभार व्यक्त करना चाहूँगी मीडिया के मेरे साथियों का, जिनका बहुत अहम रोल है कि हम इस पर्टिकुलर डिजीज़ के बारे में राइट काइंड ऑफ अवेयरनेस, सटीक जानकारी का प्रचार प्रसार करें, जिससे इस बीमारी के बारे में जन जागरूकता पैदा हो। निश्चित रूप से आप सभी के मार्गदर्शन एवं सहयोग से विभाग द्वारा प्रदेश के सिकल सेल अनुवांशिक रक्त विकार के नियंत्रण एवं उन्मूलन में मार्गदर्शन प्राप्त होगा। धन्यवाद।
धन्यवाद मैडम। अब सभी से अनुरोध है कि अपने अपने स्थान पर कृपया खड़े हो जाएं राष्ट्रगान के लिए।
जनगण मन अधिनायक जय हे भारत भाग्य विधाता, पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा, विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा, तव शुभ नामे जागे तव शुभ आशीष मांगे, गाहे तव जय गाथा, जन गण मंगलदायक जय हे भारत भाग्य विधाता, जय हे जय हे जय हे जय 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 हे।
धन्यवाद। कृपया अपने अपने स्थान पे बने रहें और मैं सभी विशिष्ट अतिथियों से अनुरोध करूंगा कि अब हम हेल्थ कैंप के लिए विजिट करें। अन्य सभी से अनुरोध है कि कृपया अपने स्थान पे बने रहें। आप सभी से अनुरोध है कि यहाँ सभागार के पीछे एक सूक्ष्म जलपान का आयोजन किया गया है। कृपया सभी लोग वहाँ पे जाके सूक्ष्म जलपान ले लें और फिर उसके बाद हम सेकेंड सेशन शुरू करेंगे 12 बजे से, टेक्निकल सेशन। धन्यवाद। सर का ही We are now going to start the first technical session. Request all the dignitaries and the participants to please be seated. Thank you. And please keep your mobile phones on the silent mode. सभी से अनुरोध है कि कृपया अपने अपने स्थान पे बैठ जाएं और अपने फ़ोन को साइलेंट मोड पे कर लें. Request all to be seated, please. We have to start the technical session now. Dr. Ravindra, please help Dr. Sargent to come on the stage. We'll start with the session as soon as Dr. Sargent, Graham Sargent, he's on the stage. It's about 30 minutes.
This is about 30 minutes. You have a timer here?
Will you be able to?
Yes, no, I'm fine here.
Your talk is of 30 minutes.
I'm sorry?
Your talk is of 30 minutes.
It's 30 minutes, is
Yeah.
it?
Yeah.
All right.
And
Right.
there is 2 glasses of water.
My goodness me. Perfect, thank you. And how do I get the first slide? You've introduced me or not?
You can just stay here. No issues, sir. Please. Okay. I think Dr. Graham Sargent is with us, and it's an absolute honor that he'll be delivering the keynote address for this first technical session. And Dr. Graham Sargent is a British medical researcher who studied sickle cell disease in Jamaica. He has directed the MRC laboratories at the University of West Indies and instituted the Sickle Cell Trust in Jamaica, which is a local charity. Dr. Sargent has published several books and approximately 500 papers on sickle cell disease. He has developed different low-cost models for the management of sickle cell disease in countries with large number of patients and limited resources. I now request, and it's an absolute privilege, to request Dr. Graham Sargent to kindly deliver the keynote address. Sir.
Thank you. And that, right, get the first slide.
So, yeah, I think this one.
Perfect.
You can
No.
see there also.
Hang on. Oh, it's there, right, as well.
Yeah.
Can we
And
go, and we
if you
go,
want, I can switch on the...
let me just go back one.
Yeah.
Perfect. Sure. We're in business, good. Good morning again. I'm afraid your English is going to be tested yet again. I'm going to talk a little bit about the differences between African disease in which I work and your own disease. And I'm pressing the button and nothing. Perfect. All right. So why are we here? Well, I was invited to King Faisal Specialist Hospital years ago, and we took the opportunity to look at the disease in Saudi Arabia. And the interesting thing here is that in the southwest of the country, you have the Benin haplotype, and in the eastern province, you have the Asian haplotype, which of course is shared with much of central India. So this is the setup. Elham, I don't speak Arabic, but Elham does, and she was the interpreter. And this particular gentleman is from the west of the kingdom. So, yes, perfect, all right. So there we are. You probably know the outline of Saudi Arabia. You can see the two divisions of Benin, which is marked in yellow, and the Asian haplotype, which is in pink. And let's look at the differences. Let's start with alpha-globin gene frequency. And the issue here, obviously, is that the alpha deletion, the single alpha deletion, is significantly more common in the eastern province, characterizing the Asian form. And then if you look at the hematology, all of these differences are highly significant at the 0.1% level. The hemoglobin F is, now I'm going to, a danger red spot. No, it doesn't, now I've gone and killed it. All right, never mind. Look at fetal hemoglobin, it's much higher in the Asian haplotype. Total hemoglobin is significantly higher. MCV is lower, probably reflecting the higher prevalence of alpha thalassemia, and reticulocytes are lower. So those are major differences. And the importance of this study is it's within the same environment. You can't take Benin people from the US and compare them with Asian haplotype in India. This is within the same environment. You have the opportunity of looking at the two conditions side by side. So a much larger clinical study was then performed by Bimal Kaur, working out of Burla Medical College in Odisha. And this compared 131 patients with SS disease and we compared them with those at that time attending the Jamaican clinic. So this is Bimal Kaur, who made a huge contribution under very difficult circumstances. In the study that we did with him, there were a lot of patients. He said they have positive sickle tests, they have pains in the joints, they got jaundice. We think they have sickle cell disease, but they didn't at that time have hemoglobin electrophoresis. So in fact, we took an entire laboratory. This, of course, would not be necessary with the sophistication currently available in India, but we're talking about 1986. So there is Professor Kaur. And how do we get the patients? Well, he actually, I said to him, Bimal, how are the patients going to know that we're here? And he said, don't worry, he says, every day we put out radio messages saying that this international team is here, and they would come in overnight, and in the morning we would see the patients all lined up waiting to be seen. The first day, I think we saw about 18. The next day, we saw 45. On the 10th day, we ran out of reagents for our red cell analyzer that we had carried. And in the end, in fact, we screened 440 patients, all their family members. So that's the structure of the study. And let's look at some of the results. Here we're comparing the Jamaican distribution, steady state levels, shown in the red columns, and the Indian distribution of the patients that we saw in the orange column. And basically the message, as you see, is that our Asian patients in Odisha had much higher hemoglobins than Jamaicans. Look at reticulocyte counts, and of course, it's very important to realize how important reticulocytes are. We do, on busy days, we would do 50 blood tests a day in Jamaica, and that means we do 50 reticulocyte counts a day in Jamaica. We almost never do hematology without a reticulocyte count. I think the most important index, single index is hemoglobin. The next most important is reticulocytes. So absolutely vital. We don't have automated retic counters. Our automation is done entirely by competent technologists, and their results are extremely reliable. So that's another message. And then, of course, you look at fetal hemoglobin, and look at this, a vast shift of fetal hemoglobin compared to Jamaicans, and you can see the figures below. So we're talking about suggestions of a different disease pattern. Now let's go back quickly to, all of you will know this, but it may be some time since you revised it. But basically, of course, what happens is the Sickle gene is an abnormality of the beta chain, and it's only as beta chains develop, particularly after birth in that transition period, that you begin to see hemoglobin S and the problems. And if you look at the lower figure now, you can see the open circles, the lower line, showing the decline of fetal hemoglobin amongst our normal AA controls picked in the cohort study. They were matched by date of birth and gender with the SS patients. And then the black circles are the black fetal hemoglobin levels. And you can see that fetal hemoglobin declines at a much lower rate in our patients in Jamaica. All right, and the importance of this is, of course, that the higher levels of fetal hemoglobin you have, the more likely you are for your spleen to persist and for splenic function to persist. And we'll go into some of those important messages. So even in the Jamaican cohort, higher hemoglobin F levels are shown to allow the spleen to persist. Look quickly at alpha thalassemia. Of course, everybody, as you know, a normal person has 2 alpha globin genes from mum and 2 from dad. If you deletion of a pair of linked genes gives you heterozygous alpha plus thalassemia, and if you get it from both parents, you have homozygous alpha plus thalassemia. Why is this important? Because it lowers the mean cell hemoglobin concentration, which is a very important determinant of sickling. So we're now looking at a population that has less sickling because of high levels of fetal hemoglobin, and less sickling because of a greater frequency of alpha thalassemia. In fact, 55% of the patients in Professor Bibal's study showed alpha thalassemia. All right, now here it becomes complicated because, of course, blood vessels go everywhere in the body, and every organ system is going to be affected in one way or another by the presence of the abnormal red cells in a patient such as SS disease. But what I want to do really is to focus particularly on the spleen and the bones, which are issues facing Jamaican patients. So let's dwell on the spleen first of all. Here's the prevalence of splenomegaly in the Jamaican population, shown by, I think it's green. Thought it was black, but never mind. You can see 55% of our babies diagnosed at birth have palpable spleens during the first year of life. And you can see the prevalence falls steeply, so that by the age of 10 years, you've actually got less than 10% have palpable spleens. If you look at the Indian population, you can see, that's the red line, you can see that there's very low proportions of palpable spleens in the first year of life, and then they become palpable much later. So you're beginning to see a different pattern in terms of splenomegaly. It occurs, as I've said, in our Jamaican patients as early as 2 months of life. And the lower picture is showing the domiciliary program that we had for giving penicillin prophylaxis, because, of course, in our population, that becomes very important. And why? Let's look at spleen function. Pitted red cells is detected by Namarsky optics. The red line, you can see there's almost no pitted red cells until the age of 4 or 5. Depends what definition you use. We normally use about 10% of pitted red cells as being an indicator of lost splenic function. What happens in Jamaicans, you can see this huge increase. So that by the age of 3, what's magic about 3? 3 years is when the risk of pneumococcal septicemia falls very steeply. So if your splenic function persists beyond the age of 3, you will not be so prone to pneumococcal septicemia. Most of our patients lose their splenic function long before the age of 3, and so pneumococcal prophylaxis is absolutely mandatory. There's the risk of pneumococcal septicemia. All right? Now, if your spleen persists for some reason, sorry, the button doesn't always work. For some reason, and we do not yet understand why, chronic hypersplenism becomes an issue. And this is Judith, followed from birth, and here she is at the age of 3.5 years. And you can see this huge spleen. And let's look at her hematology when she was hypersplenic, and then 3 months after surgery when she's got rid of any transfused blood. And comparing the two, the moral is that hemoglobin has doubled, reticulocyte count has halved, platelets have gone up by a factor of 4. If you look at the blood volume, it hasn't changed. But if you look at the red cell mass, it's gone up by a factor of 2.5 times. Her mean cell life was 3 days when she was hypersplenic, and 9 days, which is fairly average for SS patients, after splenectomy. And look at height velocity. Remember, at this age, height velocity falls by every year until they go into puberty. And yet here, instead of her height velocity continuing to fall, it's doubled. What we realize is that spleen and its associated bone marrow expansion acts like a cancer. It's consuming the calories and proteins needed for growth. So when we're monitoring hypersplenics, some resolve spontaneously. We always see them every month. We do hematology, we do height, and we do weight. And if they start to cross centiles of height, then that's one of our indications for removing the spleen. And in her case, obviously, we had to remove the spleen anyway, which we did. And my button doesn't work. Ah, there we are. There she is, 25 years later, getting married in America. So that's Judith. Is it just a problem here? No, it's not. It's a problem everywhere. Even in Jamaica, we see it. And this is a patient I looked after in Uganda, working with Christopher Ndugwa. And you can see that from the age of 2, she had increasing spleen size to 11 centimeters below the costal margin. By the age of 3.9 years, she had had 32 admissions and 29 transfusions. And I said to Christopher, why are you keeping this spleen in? And he really couldn't answer. So the answer is, take it out. And we took it out the following week. And in fact, from the age of 4, she has had no admissions and no transfusions. And in fact, she had her first child. They sent me photographs just a few weeks ago. So this is a problem. We don't understand, I think we know the optimal therapy under our conditions is certainly splenectomy, but it's something that you're going to have to address in India because it is so common. And here we see a patient looked after by a clinic in Valsad, 12 years old, and you can see on the left a spleen 16 centimeters right down to the right iliac fossa, 69 transfusions. When the spleen was removed, and in fact the surgeons had to enlarge the incision twice in order to get this spleen out, no transfusions since. So this is something, again, that you're going to have to face. Here they are, brother and sister, again, genetic factors, interesting, both having had splenectomy for hypersplenism. We don't understand why some spleens become very large, trapping the red cells, causing serious anemia and often requiring blood transfusion. So let's move on now to bone pain. Dactylitis, you all know dactylitis, painful swelling of the small bones, childhood problem, rare after the age of 5. It disappears. The active bone marrow disappears from the small bones of the hands and feet at that time. In the cohort, Jamaican cohort followed from birth, 45% develop dactylitis by the age of 2 years, often recurrent, usually resolves completely, and it is caused by avascular necrosis of bone marrow, not an intrinsically serious pathology. I'm not saying it's not painful, I'm saying that it is not intrinsically serious. So once you realize this, you can actually treat many of these as outpatients, as we do in our daycare center. The problem there is, in fact, occasionally this abnormal avascular bone marrow gets infected if there's a circulating bacteremia. So a classic picture of dactylitis on the left, and on the right you can see a proximal phalanx on the right. You can see the growth plate, you see the cortex, you can see the darkly staining, highly active bone marrow. And this child had actually had dactylitis and then died from something else. And Professor Diggs got permission to actually examine the finger. And if you look at the metacarpal, that darkly staining bone marrow should have been right down the length of the metacarpal. There is no bone marrow there at all. It is totally infarcted. And you can see periosteal new bone formation below that. All right, let's look at the cohort. Age 2.5 years. One of our children with multiple small bone abnormalities associated with dactylitis. Here she is at the age of 10 years, and every bone affected in the upper frame has undergone premature fusion and a permanent shortening of the affected small bones. And here she is at her 30th birthday party along with her 2 AA controls, Miss Carleen Mason with her back to us and my wife Beryl to the right. And Nicole, the patient, with her hand draped eloquently over the chair, you can see she's got one normal finger, which was her 4th finger. You can say, so what? This isn't a problem in India. And here she is. Side Ganga village in Chhattisgarh. The hand on the left, 4 knuckles, the hand on the right, 3 knuckles. And in fact, you can see, again, she's got very shortened metacarpal consequent on this problem. All right, let's move on, if I can get the button. Right, perfect. The importance of this model, avascular necrosis of the bone marrow, is that it is the cause of the bone pain crisis. And here you see sections through lumbar vertebrae showing these avascular areas. And the patient with this will be distressed and clutching the area of pain, the classic picture of the bone pain crisis. So you've got summarized features below. Let me carry on. Why do people get painful crises? And of course the average student will say, well, doc, it's because they've got sickle cell disease. And you say, yes, we've got sickle cell disease since shortly after birth. They don't get painful crises. So why after birth? So why do they get painful crises? And if you ask patients what they did in the 24 hours before they get pains, this is what you find. Skin cooling, either seasonal, getting caught in the rain, swimming, exercise, infection, psychological stress. On the right is Beryl, my wife, the day after Hurricane Gilbert. That is classic painful crisis weather. So we know that the precipitate, and you know, what's important about this? Get your patients to work out what causes their pains and avoid those issues. We always ask patients what they do in the 24 hours, and then we say, do you go to the beach? No, don't go to the beach. Why don't you go to the beach? Because every time I go to the beach, I get joint pains. So we say, that's a shame. Go to the beach, go in the water, don't stay in long, come out, change your clothes immediately, dry off, don't let the wind blow on you. Simple modifications of lifestyle can often prevent bone pain crises. Let's now look at risk factors. These are longer-term things. Pregnancy, of course, especially the last trimester and immediate postpartum period. But look at hematology. Hang on, we've lost a slide. This is the one that should have come before. Now you're looking at the standardized incidence of painful crisis frequency per 100 patient years of observation. The open circles against age, 15 to 40, no clear age relationship. Look what happens to men. Between 15 and 25, a highly significant increase in pain crisis frequency. What happens? Puberty, testosterone, hemoglobin rising. The hemoglobin in men rises at 0.2 of a gram a year over those 10 years. Over those 10 years, the hemoglobin goes up by 2 grams. So is it a risk factor for painful crisis? And it certainly is. Sorry, that should have been the other slide. Let's look at a simple student project here. Ask your patients what the distribution of bone pain is. Knees, elbows, back, you can see the distribution. Now, look at this. Those highlighted in blue are asking the question, if you get pain in one knee, do you get pain in the other knee within 24 hours? And the answer is there is a highly significant picture of peripheral symmetrical involvement. Now, I can't believe that blood vessels blocking the knee on one side signal to blood vessels on the other side. This doesn't make sense. And so what we think is that, now hang on, all right. What we think is that there's a centrally mediated reflex shunting of blood away from the bone marrow, which of course opens up whole new possibilities for therapy. Let's just look quickly at support systems. This is one of our patients followed from birth. Who is my chairman? How are we doing time-wise? You're all right? All right, thank you. A very generous chairman. This is one of our worst affected patients with bone pain crisis. And you can see they started in the 2nd year of life. And this pattern of increased frequency and increased severity. Except, what happened here? For 4 years, Troy didn't have a single painful crisis. What happened at 14, you ask? His mother came back from England to live with him. What happened at 18? She went back to England. Troy needed mother rather than morphia. And the truth is that this is just an extreme example of the importance of support systems for coping or preventing pains in the Jamaican scenario. I don't know whether this also applies to your patients in India. So let's look at prevention and treatment, identify precipitating factors, avoid them. If they've got high fever or chest signs, beware. They may have something more serious than simple avascular necrosis of the bone marrow. Most pains are not serious pathology. Rehydrate them because they're easily dehydrated. They can't concentrate their urine. They often don't drink. They may have a mild fever. So within a short time, they can become very quickly dehydrated. And then pain relief using the WHO analgesic ladder. And here, the day care center has been absolutely invaluable. All of our patients keep paracetamol at home. All of our patients keep paracetamol, codeine tablets, mixed, a joint tablet at home. And that has been much more powerful in controlling the pain. So this is a message again that you've got to decide whether it's important here. So most of the patients deemed to require narcotic analgesia are treated in the daycare center, and in the afternoon they're given the choice of coming into hospital or going home with the same pain-relieving medicine in tablet form. Over 90% choose to go home. We published our results in the British Journal of Haematology in 1999, and the response initially was, well, you know, that might work in Jamaica, but it's unethical and it would never work in the US or the UK. The next paper from Montefiore was published 1 year later, and they're talking about the sickle cell anemia day hospital for bone pain. And now we recognize that we could not cope in the US and the UK, and certainly in Jamaica, without inpatient resources for that. So I think the domestic use of carefully controlled narcotic analgesia has allowed effective bone care for many, effective home care for many Jamaican patients. And seeking pain relief by arduous journeys to the health center or the nearest hospital in the back of a pickup truck is the worst thing you can do if you've got bone pain. So I think the domestic use of stronger analgesia for bone pain should be a priority amongst your population. But you are the people who have to make that decision. Fortunately, there are many excellent doctors working in the disease in India now. I just want to refer to 2 or 3 early pioneers. We've already talked about Professor Bimal Kaur here on the right, and he died in 2009. And then, sorry, I'm pressing the button like mad, but nothing's happening. Ah, there we are. Dilip Patel, who succeeded Bimal Kaur in Birla Medical College, and he sadly also died, but in fact, there is now a Sickle Cell Institute associated with that institution. And last but not least is, of course, Padma Shri, Dr. Sudham Karte, who originally, well, from Pune and from a non-medical background, has made a huge contribution to the awareness of the disease in India. And this is his center in the village of Dargan. And here we see he's generously named the laboratory after my wife, Beryl. And this is the official opening of that laboratory in 2004. So the final message is, much is known about the disease, but it's mostly in the benign haplotype. There are many differences between benign and the Asian haplotypes. Not nearly so much is known about the Asian haplotype, and you have the challenge of defining your own disease. Thank you very much.
If anybody has any questions to Dr. Sargent, then I request you to please ask it. Any questions? Anybody? No. I think many of them must be thinking about asking it. Okay, so we have one question.
Sir, good afternoon, sir. In your lecture, you explained the after the splenectomy, some patients have wonderful result, and they will not further blood transfusion and other characters, and patient free from their problems. You are explained that after the splenectomy, most of the changes in patients. So please, sir, I want to explain further. After
splenectomy for hypersplenism.
Yes,
right?
Their conditions improve clinically.
Yes.
And he wants further elaboration on that.
Right. Yes, I'm allowed, yes. All right, yes, of course they improve. We wouldn't be doing it if they didn't improve. The fact is that previously they were having frequent blood transfusions. Now they're running hemoglobins of 9, 10, 11 grams with much lower hemolysis. You can see already they're growing better. You've already seen data for a growth spurt. So the truth is that in our society, I see very little reason for continuing to monitor somebody who clearly has the issue of chronic hypersplenism. We do see occasionally spontaneous resolution up to 6 months. So we usually monitor them every month until 6 months. And then if there's been no evidence of spontaneous resolution, they go to splenectomy. I have no reason for modifying that protocol, except, sadly, that 2 patients who were on the waiting list for splenectomy died from superimposed acute sequestration. So the truth is that in our society, chronic hypersplenism is definitely the way to go. Now, your society is different. You may find that removing the spleen has adverse effects from malaria. I just don't know. But those are questions that you answer, not me.
Excuse me. I am Dr. Pradeep Sihare. We advise splenectomy only in cases of hypersplenism.
He says they advise splenectomy only in cases of hypersplenism.
So your question is, are there other indications for doing splenectomy in patients with SS disease?
Yes.
I mean, obviously trauma and other obvious reasons, but no. I think once we actually see a chronically enlarged spleen that is beginning to affect the life of the patient, then we go to chronic, and then we go to splenectomy.
Any more questions?
What is the treatment of bone pain in sickle cell disease patient? You mentioned that rehydration also relieves the pain and other complication of sickle cell disease. And I want to know that how rehydration improve from this complication.
So how rehydration improves the bony pain?
You're asking me whether we have direct evidence that improving dehydration reduces bone pain, and the answer is no. Logically, it is fairly clear that dehydration is a bad thing. It certainly promotes in vitro sickling, so I see no virtue in maintaining them in the present state. So all of our patients are rehydrated. Almost all will take it orally, but if in fact they have difficulty or they're vomiting, then we would put up an intravenous line to rehydrate them for the period of the day in the daycare center. So I think it is very unlikely that you could overhydrate a patient if they're carefully monitored.
Thank you, sir. Any more questions? One more.
Any specific criteria for saying the patient has chronic hypersplenism, like duration-wise or symptom-wise?
Hypersplenic, is there a time period when they have hypersplenism?
Is there a time period when they have all right. We've actually just been analyzing our results of chronic splenic sequestration. And, well, there are obviously different patterns. Acute splenic sequestration is something that we shouldn't get into now, but that is a major problem of morbidity amongst our patients. And so acute splenic sequestration is a reason for closer monitoring, and if they have recurrent events, then we would do a splenectomy for acute sequestration. There is a group who actually have transient chronic hypersplenism, and we're still trying to work that out as to why, if they're monitored, after about 6 months, they have actually spontaneously resolved. And then, of course, there is the classic group of chronic hypersplenism, where the spleen just gets larger and larger, the hemoglobin goes lower and lower. They are clearly going to die unless you do something. And in those, we actually do splenectomy the moment we're convinced that there's no evidence for spontaneous resolution. So it's a complex equation. I don't want to get into acute splenic sequestration because that's a very different scenario, but that is a major problem amongst our patients in Jamaica.
Any more?
Probably the last one.
I think if anybody has any more questions, they can take it.
We can
get it. I mean, you can just have a word with sir separately.
We can have the next questions in the tea break, and so that we don't lose any more time, we can call the next speaker. And before that,
So before I call the next speaker, I would like to request Dr. Raja Subramaniam sir to kindly felicitate Dr. Graham Sargent with a memento. So it has been an absolute honor to listen to you, and I think this is just a trickle drop of the knowledge which we have got today, but there is too much, I mean, so much to learn from you, and we came to know that you have been to India for more than 28 times now. This is your 28th visit to India, isn't it, sir? 29th. Yeah. It has been a very long association, so I request Dr. Raja sir to kindly felicitate Graham Sargent sir. Thank you so much. Thank you so much. Thank you so much. Now we move on to our next talk. Our next speaker is Ms. Vinita Srivastava. Madam, she is the advisor on tribal health to the Ministry of Tribal Affairs, Government of India. And Ms. Srivastava is continuously striving hard to further the cause of sickle cell disease and the other hemoglobin disorders in India like thalassemia. And she has kind of dedicated her now, I mean, I will say life to this cause, and I request ma'am to come and deliver her talk. She will be speaking about the roadmap for control of sickle cell disease in India. Thank you.
So we'll start, as we all understand, it's a genetic condition and widespread among the tribal population in India. Before saying anything, I would like to thank the organizers, because this is very important for us while the sickle cell mission has been launched. It is important that now we start talking about hemoglobinopathies, sickle as well as thalassemia as well. So if we see the expert committee report on tribal health, which was basically done in 2018, has listed SCD as one of the 10 special problems in tribal. And Ministry of Tribal Affairs conducted screening of tribal population in collaboration with ICMR and Department of Biotechnology. This was the first screening which was done at large, and you can see the basically the 8.75 was tested positive. So this is very important because this was the only screening done. Earlier it was done in pockets, but this was done in large, and this is the cohort which we got. So next, please. So what is the strategies and roadmap for prevention and control of management of sickle cell disease? I would like to say that most of the things are known to us, but what is the exact roadmap which we are planning? That is elimination of sickle cell disease as a public health problem in India before 2047. The objective is for affordable and accessible care to all SCD patients, where Honorable Minister also said that now we need to build up the infrastructure which is very much required in the country, which we are lacking. So that is very important. Ensure the quality of care for SCD patients. So while we talk about SCD patients, it's important that the availability of drugs. Recently, just now we saw the doctor surgeon's presentation. These facilities need to be there. And to reduce the prevalence, it's important that the genetic counseling, the awareness is much done. So what is basically strategic pillars are health promotion, awareness generation, and premarital counseling, which we already have heard from so many speakers, universal screening and early detection. So we are talking about 7 crore people who are in tribal areas, and we need to detect them. But just now we were talking to Deepti ma'am and others said that non-tribal populations are equally important, which is, so this target of 7 crores can be enhanced also. This is the primary target which is we are going to take up. And the third thing is the management of affected, the holistic management and continuum of care, which is very important, the management of affected individual at primary care, secondary and tertiary, patient support mechanism, and community adoption, which is very important. The community needs to adopt it, because until they adopt it, we are not going to take it up. So we will not be able to take up in the aggressive manner. So we are planning to have it in 17 states, that is high prevalence states is Rajasthan, Gujarat, Madhya Pradesh, Chhattisgarh, Jharkhand, West Bengal, Odisha, Telangana, Andhra Pradesh, Tamil Nadu, Kerala, Karnataka, and Maharashtra. Partial prevalence states you can see in Bihar, Uttarakhand, Assam, and Uttar Pradesh as well. I was surprised to see when I got some results from the Uttar Pradesh also. So its prevalence is there, it is across. But we are just planning for 70 states, but we are not leaving others as well. This is important. The screening activities will be done in 2 phases. It's like for all individual aged 18 years and below. That is one thing. And phase 2 for all individual aged 40 years and below. So 7 crores people in 3.5 years. And we are planning for Ministry of Tribal Affairs. It's like the Ministry of Health will also do some screening, and Ministry of Tribal Affairs will also do some screening. We will be going to the people. It's like that we will be going through our health camps, through our mobiles. So we will be doing screening in the remote areas of the country. That is the basically a challenge for us, because hardly people, as sir said, Honorable Minister said also कि बहुत मुश्किल होती है कि उन तक पहुँचना. उन तक पहुँचने के लिए हमें अपने आप को आगे बढ़ाना पड़ेगा. जब हम बहुत सारी चीज़ें, आज एक बहुत छोटा सा संज्ञान था कि जब हमें मतलब सुबह मॉर्निंग में बात हो रही थी कि लोहा और अभ्रक लेने के लिए तो हम पहुँच जाते हैं उनसे. अगर आप झारखंड में देखें बहुत सारी चीज़ें ऐसी हैं कि लोहा और बट क्या हमें हेल्थ फैसिलिटीज़ उन तक पहुंचाने की हमारी जिम्मेदारी नहीं है? तो ये बहुत बड़ा चैलेंज है जिसको हमको समझना पड़ेगा. एंड वी हैव टू टेक आवर हेल्थ फैसिलिटीज टू, बिकॉज दे लिव इन आइसोलेशन. इट वाज सेड इन द मॉर्निंग इटसेल्फ कि आइसोलेशन में अपनी जैसी ज़िंदगी उन्हें मिल रही है उससे वो खुश है, बट हमें कहाँ तक पहुँचना है, उन तक किस तरह पहुँचना है, वो भी एक हमारे लिए चैलेंज है. एंड दिस वी आर प्लानिंग कि हाउ आवर रोड मैप विल डिफाइन दैट हाउ वी आर गोइंग टू रीच दोज पीपल, रादर दे कमिंग टू अस, वी नीड टू रीच देम. So approach will be awareness generation using IC and mass media, universal screening as we said till 40 years, comprehensive care for all individual identified patients. That's very important because we are missing our patients. 5 साल की उम्र तक कई बच्चे चले जाते हैं, हमें पता तक नहीं होता है. और अगर मैं केवल MP का ही डेटा देखूं, मेरा ख्याल रूबी है नहीं यहाँ पे, लेकिन अगर अभी MP का ही डेटा देखें तो you'll find the mortality is very high. So this is very important. Leveraging Ayushman Bharat, health and wellness centers, which is very important. Now, health and wellness center doesn't have these facilities. आज बात हो रही थी, I don't know how many CHOs are sitting here, but ये हो रहा था कि CHOs को train करना है. I don't know how many CHOs are sitting here, but this is the important thing that health and wellness centers should be trained for these things. Important. Leverage technology, telemedicine, exclusive portal for tracking POCs test. अभी भी आज बात हो रही थी कि टेस्ट की कॉस्ट क्या होगी, किस लेवल पे हम टेस्ट ले जा पाएंगे. लीवरेज तो कर देते हैं, बट हाउ टू गो अबाउट इट इज अगेन अ चैलेंज. एंड वी आर ट्राइंग टू, I mean, we will be able to sort it out in this week or so. Convergence with health programs, RBSK, which is already there. उसको कैसे, अगर आप हम आंगनबाड़ी में स्क्रीनिंग की बात कर रहे हैं तो RBSK की टीम्स जाती हैं, उनको हमें सेंसिटाइज करना पड़ेगा. जो बहुत दिनों से बात तो चल रही है, बट कभी भी RBSK में क्यों, बिकॉज दे हैव 30 स्क्रीनिंग विच इज़ मैंडेटरी, बट दीज स्क्रीनिंग्स आर वॉलंटरी स्क्रीनिंग्स. अब वो वॉलंटरी बच्चा तो नहीं बता पाएगा, तो वी हैव टू मेक इट की मैंडेटरी दैट RBSK also has to include this screening and as a 31st screening of their program. Then collaboration with, as I said, most of the ministries has to come forward, otherwise this program cannot sustain. और अगर चलेगा भी तो वो अभी तक जितने भी ministries के program चले, this was in isolation. This time when Finance Commission gave us the details, they said Ministry of Tribal Affairs and Ministry of Health both has to. Though Ministry of Health will take a lead, but Ministry of Tribal Affairs has to support it thoroughly. Either it be screening, either it be establishment of centers, either it be awareness generation, either it be training, because if you see the plan, the training wasn't there. So we have prepared a training module for them, that how we are going to train our medical and the paramedical staff, which is very important. Our gynecologists never write the screening for hemoglobinopathies, which is very important. Even same as the pediatrician, they don't understand. जैसे बात हो रहा था पीलिया, सर ने बड़ा अच्छा उदाहरण दिया था, बट आगे से ज़्यादा लोगों को पता नहीं लगता है कि पेल क्यों हो रहा है बच्चा, because the screening is not done in that way. I think दीप्ति मैम will agree कि उन्होंने बहुत सारे पेशेंट्स देखे हैं, और ऐसे बहुत सारे पेशेंट्स आते थे जिसमें ये पता लगता था कि हमारा जो बेसिकली इश्यूज हैं वो कभी पकड़े ही नहीं जाते थे. And engagements of CBOs and NGOs. So universal screening and early diagnosis, which is one of the routine screening and target individuals during OPD. Dedicated dates for mass screening for targeted population at risk. हमारे यहाँ हर दिन एक हेल्थ मेला लगता है, उस हेल्थ मेला में स्क्रीनिंग कब शुरू करनी है ये ट्राइबल अफेयर सपोर्ट करेगा. मोबिलाइजेशन एंड यूजुअल थ्रू आशा एंड एएमस, लेकिन आशा और एएनएम्स के पास इतना काम है, 72 काम है, उनके ऊपर एक और काम लादना थोड़ा मुश्किल होगा. एंड मोबिलाइजेशन एट कम्युनिटी प्लेटफॉर्म्स एंड NGOs, विच इज़ वेरी इंपॉर्टेंट. आउटरीच कैंप जो है सिकल सेल स्क्रीनिंग इन हाई प्रायोरिटी एरियाज थ्रू मेडिकल यूनिट्स एंड मेडिकल कैंप, एज आई सेड अर्लियर. एंड रेगुलर स्क्रीनिंग कैंप्स एट आश्रम स्कूल्स, जो हमारे स्कूल्स हैं, आश्रम स्कूल्स हैं, मॉडल रेजिडेंशियल स्कूल्स हैं, एकलव्य मॉडल जो हमारे पास अभी आज की तारीख में 750 स्कूल्स हैं, ट्राइबल स्कॉलरशिप स्टूडेंट्स हैं, ट्राइबल हॉस्टल्स हैं अलग से बने हुए हैं, और करीब अगर आप देखेंगे तो ये करीब 50 से 60 लाख लोगों की पॉपुलेशन होगी जिसको हम कवर कर पाएंगे. एंड आंगनबाड़ीज एज वेल. सो अप्रोच इनिशियल स्क्रीनिंग डूइंग POC, विच इज़ मोर इम्पॉर्टेंट, बिकॉज सॉलेबिलिटी से हम कर तो लेते हैं लेकिन हम फॉल्स पॉजिटिव और फॉल्स नेगेटिव पे अटक जाते हैं. तो दिस इज़ द अप्रोच फॉर अस. सो यू कैन सी कि what we are thinking of कि इस जगह पे, and even MP has said today कि we will start doing POC, because ये plan जो बना था वो सबका साथ बना था, and district hospital HPLC but at the tertiary care we really require HPLC or the electrophoresis, because it's important to have the if we want to do the red cell indices, that's important that it should be there. Holistic management is again an important thing, which I mean I'm not supposed to talk because most of the experts are sitting here. So screening and early identification, confirmatory diagnostic treatment initiation and management of complications. So now we are planning to have the central of competencies in the states to get the holistic management, and the referrals has to be very strong, which is very important, because the referral mechanism, if it is not strong, we will not be able to handle our patients. So integration with, recently we had integration with Ayush also, so for innovative therapies, जैसे बात हुई कि papaya की leaf से, this is a supportive, this is nothing to do with what hydroxyurea is doing, but somehow something if can be helpful, we should take it up. And this is again was a very good example which we saw in Nandurbar कि योगा के थ्रू उन्होंने काफ़ी हद तक लोगों को मजबूत किया. अब योगा तो आप वैसे भी करें तो फ़र्क पड़ता है बॉडी में, बट उन्होंने योगा के थ्रू they took around 50 children and the results are awaited, but the results are amazing. And I will share those results with you all, because this is a big learning for all of us. So data management, creation of Aadhaar base, which is started by the National Health Authority, which is important. Integration of individual based data with central repository. So जो भी data होगा वो एक ही जगह आएगा. वो even हम भी जो data collect करेंगे, we will keep it at one place. treatment adherence leveraging appropriate technology solutions such as frequent calls, SMS and reminders, which is important कि अगर बंदा वापस नहीं आया अपनी दवाई लेने के लिए तो वो भी हम उनको सूचित करेंगे कि भाई आप पेशेंट हैं, क्योंकि पेशेंट की लिस्ट भी हमारे लिए ज़रूरी है. Monitoring the coverage of PCV coverage and status through the portal. So these things will be done through data management. So ये एक प्लान है कि सिकल सेल प्रोग्राम सम कमेटी एट द स्टेट लेवल होना चाहिए, जिसमें ये सारे डिपार्टमेंट ऑफ हेल्थ एंड फैमिली वेलफेयर, ट्राइबल अफेयर्स, प्राइमरी एजुकेशन, बिकॉज एजुकेशन इज अगेन बिग थिंग विच वेयर वी कैन डिसमिनेट आवर इंफॉर्मेशंस, डिपार्टमेंट ऑफ सोशल वेलफेयर, women and child, academic institutions, civil society organizations. So these are the ministries whom we are connecting with, and we are regularly having meetings to mitigate this sickle cell disease from the country by 2047. So these are the ministries whom we are regularly in touch with. So every week we are having a meeting and we are doing all these things. So these are the role of MOHF and role of MOTA, which has been defined by Ministry of Health also and ourselves also. So if you can see, that the roles have been defined because we have to take up these roles and aggressively we have to take up. I'm not going to read it much, but these are all develop of SOPs and clinicals for this has already been done. I think Dr. Tolika was a part of it and we all were a part of it, but the training and all will be started by us. Medical colleges and all, this also we have kept it. So we are coming up with the center of competencies, which will be the medical colleges and the tertiary care. These AIMS and ICMRs and the medical colleges will be taken as a center of competency, which we were discussing with Dr. Yadav in Indore, because they have all the facilities and they can come up with those. The role of state health department and social welfare department, because Department of Finance has given the opportunity to work for this, for both of the departments. Role of ICMR and research institutions, because this is also defined, because now we have we have some STC funds. This is Tribal Subcomponent Fund, which is very important, and this goes to around 42 ministries, where we can mingle with those, get the things done. So even the ICMR has the same opportunity to. So we are coming up with the Tribal Health Research Plan, which recently I had a meeting with DG ICMR, and we are especially coming up with the Tribal Health Research Plan, where we'll also include sickle cell and other hemoglobinopathies as a key area. So Ministry of Education, Ministry of WCD, what will be the role? So every ministry's role has been defined for this. And this convergence was started in the Ministry of Tribal Affairs, because we understood, because the disease cannot be taken alone. I have been working, we started in blood, while I was in blood cell in Ministry of Health, and we started as hemoglobinopathies, but I could very well understand after looking for 6-7 years that now alone, one ministry cannot do it. It's like कि आपने सोच लिया, हमने कर लिया और जितना सोचा उतना हो गया, वैसा नहीं होता. अभी भी आज जैसे स्क्रीनिंग की बात हो रही थी कि 8 लाख की स्क्रीनिंग हुई है हमारी, तो हमें कितने ट्रेड्स और कितना अभी वो डेटा हमारा पूरी तरह कलेक्ट नहीं हुआ है. मैं अब बात करना चाह रही थी कि कैसे होगा वो, किस तो वो मैं शायद अभी शाम को मुझे जानकारी मिलेगी क्या है. एंड दैट्स व्हाई द प्रिंसिपल सेक्रेटरी गवर्नर हाउस DP Ahuja sir has said कि we want to know how we are going to take up these. So this is important. The role of NGOs, Indian Red Cross Society. Indian Red Cross Society in Gujarat has done a great job. I think Dr. Italia will support me for this, because they have the sickle cell program, and Indian Red Cross Society was holding a program for thalassemia also. So they had done a good screening also, very good screening programs. Also the prevention was done, and so much of CVS was done, I think. And they were able to correct 756 cases, it was like that. So these, the role of NGOs are equally important in making awareness, pilot innovation and early diagnosis. All these things can be done. And so thank you for patience listening. But the thing is that my only concern is because we are here and we want to know from you as well. The roadmap which we are going to define, it has already been decided and so many experts are being the part of it. My only concern is if your ideas come to us in writing also, in my mail also, it will be very helpful, because we want to come up with a roadmap which goes in the interiors. That is very important, because we need to go to the peripheries, go to the patients, go to the tribal people to get the diagnosis done and get them treated properly. That's very important. Thank you so much. Thanks a lot.
If any questions are there, then please ask it. Okay, sir wants to.
Excellent, the lines of management for achieving goals in future. Talking about, if I am a case of sickle cell disease and I am in a rural area and I have to reach for my management, couple of observations that we have is that the patient reaches to a hospital, and usually I am talking about teaching hospitals, wherein majority of the time they are the junior residents who come in first contact with a case who is a critical one. Now what is happening that many a times they are not very much aware about the criticality of the situation. Going from R1 to R2 to R3 and then reaching to the professor, it's a long chain. So I think something can be done as far as this aspect is concerned, because the sickle cell disease patients' criticality is such, they have a very narrow safety margin. They can go on either side in a matter of few hours, and that can be a cause of mortality. So something that should be looked in as far as this is concerned.
So this is very important actually, that's what we were talking about. That the trainings are important, which I said, and we are also talking with NMC for this, that how to include other things, because we don't have much of the hematologists and training is again an issue. So both the things are being taken care at.
Yeah, I think that is one.
I think one more question is there.
Thank you very much, madam, for such an excellent roadmap. As sir already said, there is a long queue in the medical colleges to diagnose, to give them a treatment, whether they hospitalize or not to hospitalized. So what I feel personally, there must be exclusively clinics for the sickle cell or hemoglobinopathy as an OPD as well as the indoor patients, number one. Number two, there must be a comprehensive care system in a regional wise, where they will get under one umbrella, they will get all sort of things, starting from blood transfusion to the end of their bone marrow transplantation. And I think you are the best person, as you improved lot of blood transfusion facilities in India wise. So I think this roadmap will dream come true if everyone will take care and participate regularly.
Definitely, Dr. Sir, that's very clear about from us that the Center of Competencies will be developed. It will be developed and we are going to support it. It's only that we get the proposal from the states and we'll start doing it immediately, because the dedicated funds has been kept for these things. So it's only the proposal, because Ministry of Health has a protocol because at NHM, because I was also a part of NHM, and I understand my limitations that we cannot go beyond tertiary district hospitals and above. So that is a concern which we will take it up. It's a joint efforts. It's not only this is a health issue. Either the Ministry of Health or Ministry of Travel, whosoever takes up. But now, because Ministry of Health has said that we need to take up these issues at the tertiary care, so we will definitely do it, and we'll do it with the State Department, State Health Department only. So all these things will be, I'm going to have some good meetings actually for the clinician, as Matt said. We will have very soon a meeting of clinicians and other NGOs and CBOs separately. And we will draft the things. Accordingly, we will develop this. From April onwards, we will start doing that. Thank you so much.
Thank you. I think rest of the questions we can take during the lunch. I now request Ms. Ruby Khan to I now request Ms. Ruby Khan to please come on the dais and present the memento to Ms. Vinita Srivastava ji. Thank you.
But she always
Thank you, ma'am. Thank you so much. Moving on, we have a slight modification in the schedule. We'll be now having the next lecture by Dr. Reena Das, and then we'll immediately after that we'll break for lunch. May I now request Dr. Reena Das to please come on the dais. Dr. Reena Das is currently working as a professor full-time at the Postgraduate Institute of Medical Education and Research at Chandigarh, and she has expertise in genetic epidemiology, hematology, bone marrow transplantation, leukemia, and medical genetics, and much more. So she will be speaking on the advances in the diagnosis of sickle cell disease. Thank you, ma'am. Floor is yours.
Thank you so much, and it's an absolute pleasure to be here. I consider myself to be part of MP because I did my MBBS from Jabalpur Medical College. So it is actually a homecoming for me coming back to Madhya Pradesh. So can I get my slides, please? So my talk is on advances in the diagnosis of sickle cell disease. However, I will very quickly go through the spectrum of the thalassemia and hemoglobinopathies. Why I'm talking about hemoglobinopathies very briefly here also is that the same population where you have thalassemias, and today we are talking about sickle cell disorder, we can also have beta thalassemia traits and other hemoglobinopathies. Then we also have a condition where the fetal hemoglobin can be increased in an adult. Normally by about 1 year of age, we come to about less than 1% fetal hemoglobin, but an inappropriate expression means that an adult also has increased fetal hemoglobin. Now, when you have alpha thalassemias or hereditary persistence of fetal hemoglobin, in such conditions, you will find that the patient is less symptomatic than how you would expect patients with homozygous disorders to have. Now, what is the definition for screening for hemoglobinopathies? It is basically a public health service wherein laboratory tests are systematically applied to identify individuals who appear normal but are at significant risk to be a parent of a child with thalassemia or having a significant hemoglobinopathy. And there are a lot of screening programs which are there. You could have a cascade screening, which was referred to before, where you have an extended family screening, one index case in the family, and you can screen the entire family, which was referred to earlier. Antenatal women are also a one period time frame where we must do the screening, because here the concern is there to have a normal child. So all of us want that antenatal screening program should be a mandatory screening program for the country, so that and at this particular time, the counseling is much less that you have to do, because there is a concern to have a normal child. So when you ask the husband to come for screening, he also comes running for the screening. That has been our experience, and that's what we are kind of doing. So I'll not go into the mutation. You know that it is a point mutation giving rise to such a pleiotropic type of disorders. And we know that the definition is sickle cell anemia, which is actually homozygous sickle cell condition. Sickle cell trait when only one of the allele is abnormal, such as the parent of a sickle cell disorder case. Sickle cell disease, when we say, it comprises lot of combinations which are there. And in India, apart from sickle beta, we also have hemoglobin sickle with hemoglobin D Punjab. This combination can give rise to sickling syndrome, which is quite symptomatic. The hemoglobin S with hereditary persistence of fetal hemoglobin is not a very common condition, but if it happens, then the patient is not very symptomatic, or it's not a bad combination to have. We have talked about malaria and sickle cell disorders on many occasions, that there is a balanced polymorphism, and it kind of matches the map, with the malaria prevalences. Now, every pregnancy will have a 25% chance of the fetus to be affected, and when we do the counseling, it's important to inform that 75% chance is that the fetus will be normal, either a normal completely or maybe just a carrier. Why it is important is that we have to provide adequate care to children with sickle cell anemia and thalassemia syndromes who already have been born. So both the things are there, looking after the children who are born and also preventing the disorder. So apart from actually just doing screening programs, we have to strengthen our prenatal services, and Dr. Anita Nadkarni will be talking about how that will be done. So we know that looking at the peripheral smear is important because we can see hypochromic microcytosis as well as the sickle cells. 1% sodium metabisulfite test is important to see the sickling test, which can be done in a lab. HPLC is one of the reliable methods, but we understand that it is not possible to go into the and do it in all the cases and the massive scale that we want the screening to be done. So one of the tests which is there is sickling solubility test, which is kind of a point of care test, but there are problems which are there for that. So, the criteria which is there is assured criteria, which is defined as having an affordable test, sensitive test, specific test. It should be user-friendly, not very complicated to be done at the field level. You should be able to get the reports very rapidly. It should be equipment-free, at least not very heavy equipment should be there, and it should be you should be able to deliver it to those who need it. So for rapid diagnosis, there are multiple now competitive lateral flow assay or chromographic immunoassays which are there. Sickle scan, hemotype C, Gazelle, and also paper-based point of care test. And I think Dr. Anita will be talking more about them also. So these are just very briefly that sickle scan, you can, because these are immune-mediated kind of tests which are there, and they are reasonably quick. You know, the waiting time is just only 5 minutes to 10 minutes where you can get a result. So these are tests which are very good to be done in the periphery. Then another microchip-based cellulose acetate electrophoresis, Gazelle. This has been done by the ICMR Jabalpur. They have done and made a publication, and this seems to be a very good test which can be taken up even in the field situation. So, so basically, between the sickle cell trait and sickle beta compound heterozygosity state, which means on HPLC or any other methodology, if we get more than 50% sickle hemoglobin, you need to differentiate the two. And the easiest way to differentiate the two is if you can screen the parents. I think I will advocate that before even trying to do the HPLC. So all these screening tests are just able to tell us that especially the solubility test does not differentiate the two. But if you do the HPLC, you might be able to see the hemoglobin A2. And if the hemoglobin A2 is increased with a high sickle and as well as the increased fetal hemoglobin, that suggests more the homozygous compound heterozygosity with sickle and beta thalassemia trait. So HPLC is what is kind of done in the in tertiary care hospitals only, but this is one of the tests which is an extremely good test and which will be able to give you all the combinations as well. So thalassemia majors can be picked up very easily, thalassemia traits can also be picked up, and whenever we see any abnormal peak, we must do two independent tests, which could include something like looking at sickle cells or on the peripheral smear or sickling test itself, or cellulose acetate test as well. So sickle cell disorder, sickle cell trait will have another peak which is there in the sickle cell window, and these usually are about 35 to 40% is what we usually see them. Homozygous sickle will have more of sickle cell, and normal hemoglobin, adult hemoglobin will be less. Usually the fetal hemoglobin is increased, and here you can see that the A2 is increased. So if you see A2 increased with beta thalassemia, the suspicion of beta thalassemia with sickle is increased. But if you see the fetal hemoglobin concentration, we really won't be able to differentiate. So we can get sometimes complicated situation. One of the HPLC method which we can easily say what is the combination very nicely is the hemoglobin S with D Punjab, which is again a very symptomatic hemoglobinopathy. So this combination can be easily picked up on HPLC. We will not be able to pick this up on the electrophoresis, where we will get a single band in the SD region. So usually these are the kind of women histories that we get. Antenatal screening, you look at the red cell indices, you can't make out really unless you have done an HPLC or any other screening method. So this woman is a sickle cell trait. Sickle cell trait individuals also can have sometimes problems because usually they are not symptomatic, but they could have pain crisis and minute kidney problems which can present to clinical medicine as well. So if we see sickle cell trait in a pregnant woman, then we must screen the husband as soon as possible. Another case, so this child, this lady has come to the hospital, and you can see very severe anemia, but look at the red cell indices. Red cell indices are not really telling you much about any suspicion. So just anemia could be a presentation with these painful crises or leg ulcers, and the HPLC will be able to kind of tell you, but again it is a good idea to screen the family so that we know the exact diagnosis which is there. So again here you can see that the anemia is very severe, hypochromic microcytosis is there, and the A2 is increased, reticulocyte count is also increased. So this is a homozygous sickling disorder. So in the last case, here you can see there is a history of previous child loss, which sometimes comes about if the person is not managed very well. So here this is a history where you can see that on the HPLC, the double peak is there for hemoglobin S and D. The anemia is moderate anemia. Red cell indices do not suggest anything specific, but the reticulocyte count is increased. And if we get a combination in prenatal for the couple to have sickle and beta thalassemia, sickle with hemoglobin D Punjab, then prenatal diagnosis should be offered to them. So this is very easily you can make out, you can do the parental screening and find out that which, whether the paternal side or the maternal side has sickle and hemoglobin D Punjab. This I just wanted to show that we had two cases where these two siblings had presented with high-grade fever, chills and rigors. And what we found was in the peripheral blood, we found nucleated RBCs which are clumped, and also we got Plasmodium vivax infection. They had again come up after about another 4-5 years with a second episode of Plasmodium vivax. And when we talk about malaria and the polymorphism, we basically are talking about falciparum malaria, not vivax. So vivax can happen to them. There is no protection the sickling patients have with Plasmodium vivax infection. So automated blood cell counts are very good when we are trying to look for beta thalassemia traits, and nowadays we actually have district hospitals having these counters, not such high-end counters, but these counters are extremely good to identify beta thalassemia traits versus iron deficiency anemia. But during pregnancy, we have to interpret these red cell indices with caution, and hemoglobinopathies cannot be picked up by the red cell indices. We have collaborated with some statistician in Denmark, and he has come up with this app which is an Android app. This is a freely available Android app which is there, where you need to enter the hemoglobin, MCV, MCH, RBC count, and the red cell distribution width, and it gives you two options, whether it is suspected for beta thalassemia trait or not suspected, and HPLC whether is required or not. So we have been giving them kind of data for different disorders in collaboration, and they have come up with this app which we have kind of validated that this is good, and if this can be utilized wherever red cell indices are available, this could be a good option to be done even in the field. So in conclusion, most cases of sickle hemoglobin can be characterized by clinical history, CBC, hemoglobin HPLC findings, and will not require molecular studies. But for prenatal testing, molecular diagnosis will be required, and we'll be talking more about it after the lunch session. Other cases where conclusive diagnosis is not possible by the simpler test, especially when the child comes after transfusion, whatever tests you do, you'll be basically looking at the sample as a post-transfusion sample. So parental HPLC would be kind of useful in such situation. In only few situations you would like a molecular diagnosis to be done. I would like to take questions if there are any.
Thank you so much, ma'am. If you have any questions, please.
So excellent. I thought that was wonderful, and I really am very interested in the app that you were talking about. So Is this an app that could be used for antenatal women? Because as we know, the red cell indices are a little bit off in the pregnant women.
Yes. This can be used in pregnant women. So basically, you know, we did the study after this app was made. Kind of first, they just made looked at the data, all the red cell indices, and then we gave them specific types when they were preparing the app. Then we had a validation phase where just they did not know any diagnosis. No diagnosis was given, and then seen the specificity and the sensitivity. It's pretty good. Now, the thing is that red cell indices always have some caveat, and we are talking about screening. And we know that when we are saying screening, it is possibly 100% will not be picked up. But in this app, they have put more emphasis on so that we don't miss any case.
Okay.
So what will happen is probably you'll end up screening for advising for HPLC
So
much
you could
more,
have some
so that
false
we don't
positives, but that's
yeah.
okay.
So
Yeah.
that is what is kind of the
Excellent.
possibility of the app.
Thank you.
Very nice lecture. I would like to comment only one slide, that was case 1, where the hemoglobin was 7.7 and MCV was normal and the RDW was increased. So in any case, if there is anemia, normocytic anemia with increased RDW, hemolysis should be suspected.
Yes.
So in our region, we teach our pathologists that if you see such situation, do sickle test.
Yes, it's not only sickle. Our populations also already have complications because of iron deficiency anemia also, as well as beta thalassemia.
Sometimes mix deficiency can occur. But in our region and where the sickle is present, sickle is the first diagnosis. So sickling should be done actually.
Actually, I personally don't have too much experience on point of care equipments because I'm working in a tertiary care center. But I would like to offer anybody because I heard some doctors talking about chorionic villus biopsies and all, and if anybody wants to get trained, and I think we could offer that in our center, that if gynecologists here want to get training, that would be a good opportunity that they could contact me and I can get them in touch with the gynecologists.
Thank you, ma'am, for giving us opportunity.
I think.
My question is that in HPLC you said that when A2 is raised, it is most likely a sickle beta thalassemia cases. But we have seen a certain cases in which there is a glycosylated hemoglobin S which eludes in the hemoglobin A2 level. And the patient is not the sickle beta. When we do the parental testing, it is a sickle cell trait in both the parents. So at what level of the A2 high level we can suspect that it is a sickle beta thalassemia or sickle cell disease हो जाएगा?
I think whatever technique you use, there will be a problem. There will be some cases you might miss, and that is the reason why I think that it is best to do the parents, because when you do the parents, you don't need very complicated DNA level tests also. Your phenotype very easily gets segregated, that whether we are talking about homozygous sickle, because these problems are there. In a given particular case, it might be difficult to identify and say for sure. But usually when the A2 is increased and the red cell indices are hypochromic microcytosis, then you suspect that double heterozygosity is. But that problem will be there. Even if you do HBS, cellulose acetate electrophoresis, we don't know the A2.
I am Dr. Jyotish Patel.
Yes, sir.
I am from Gujarat. Would like to know about a critical case entering to your clinic, and he is majority of the sickle cell crisis patients would come in the night time, and many times it's really an emergency to decide for the clinician that what kind of that case is. So in such a, because it is a not uncommon situation, I would go to the extent that it is a frequent situation wherein they just come as an emergency case without having their records even. So it becomes really important that what kind of management a clinician should be starting, because everything differs based on the the diagnosis. So this situation, what would be your recommendation? Because we are talking about national forum, and it is going to be a frequent occasion for sickle cell. More and more diagnosis would be there, more and more cases would be pouring into the hospitals. So in such a situation, supposing they do not have card, they do not have any information, and still clinician thinks that yes, he is a likely case of sickle cell disease, what would be your recommendation?
So I think probably Dr. Tulika will be able to answer your question better than me. But when a patient comes to the emergency, which is usually, it could be a pediatric emergency or an adult emergency, most of the time they give hydration, oxygenation, and
I am talking about the diagnosis, because they do not have record. If there is a record, he is sickle trait, sickle disease, sickle beta thalassemia, sickle hemoglobin D, Punjab, is fine. But here, this is happening. I have been practicing sickle cell since 35 years. And even my known patients, so many years, if they come, I recognize face, okay, this is sickle cell disease. But some RMO is there, they would not be able to recognize that.
you're right. Actually, we don't have so many so-called sickle, thalassemia doctors, you can say that way. Because in India, it is not just, disease specific. The doctors are not disease specific. It is like you are looking specifically at this problem, but I think our pediatricians or our adult hematologists also, they are looking at multiple disorders. I think in India, probably there are 5-6 doctors who are only sickle doctors, and I think Dr. Deepthi is one of them who have made their name only in sickle. But usually they would be just hematology practice, I think, that goes on. So I don't think I will be able to answer your question very well.
I think rest of the questions we can take during the lunch session now, because we are already running late and we have to cover a lot of time. So may I now request Dr. Jyotish Patel, sir, to please come on the stage and felicitate Dr. Reena Das, Professor Reena Das.
I asked the question and I am promoted to felicitate you.
Thank you so much, sir. And we now break for lunch, and when we get back, we'll start with the lecture of Dr. Raja Subramaniam. So we'll take about half an hour for lunch, and then we'll come here at about 2:50. 2:50, 50. Thank you. Thank you so much. The talk by Dr. Raja Subramaniam. Dr. Raja Subramaniam is a senior scientist at the National Institute of Research in Tribal Health, ICMRs, at Jabalpur. He is a skilled molecular biologist, and he is currently focusing on providing diagnostic services for various hemoglobinopathies, besides training and developing human resources for 19 states with tribal populations, in collaboration with the Ministry of Tribal Affairs. Dr. Raja will speak on the epidemiology of sickle cell disease in India, and I now request sir to please come on the dais. Kindly put on the PPT. I request the media operations team to kindly put on the PPT. Thank you.
Good afternoon, everybody. And at the outset, I would like to congratulate my colleague, Dr. Ravindra Kumar and Dr. Aprup Das for putting up this symposium, which is bringing in experts from various fields, and is a great opportunity for the clinicians of Madhya Pradesh to hear from the experts on how to tackle sickle cell disease. And I thank them for providing me this opportunity to speak on the epidemiology of sickle cell in India. I'm a laboratory-based researcher, so I'm not an epidemiologist by training. I just happen to do some epidemiology work. And epidemiology calculations in India or about India come from United Kingdom School of Public Health, and Frederick Peel has contributed intensively along with some of the experts in India, and has proposed the data or the prevalence that we expect or the burdens to be found in India. And this burden also is not complete, because most of the studies in India are based on tribal populations, and sickle cell per se is not is considered a tribal disease because most of these studies are done on tribals, and it has a pseudo name as a tribal disease, but the prevalence in other backward communities and scheduled castes is also present. So the calculations or the prevalence identified is not complete without having the data from the other communities. So these are a few introductions for the benefit of the clinicians who have come from Madhya Pradesh. And so sickle cell is a neglected chronic disorder in the world, and it was first identified in 1910. It's a great opportunity to listen to Dr. Graham Sargent, and we are all blessed because of his experience and his thoughtful suggestions to us. And he has already given the brief history of sickle cell from beginning from James Herrick. So it's a inherited disorder, and as per the Frederick Peel estimates, from 2010 to 2015, the average number of sickle babies that are expected to be born globally is about 300,000, and which is going to be 400,000 by the year 2015. And in India, estimated 44,000 sickle cell disease babies are born annually. And sickle cell gene in India, this information is plagiarized from Dr. Sargent's recent paper on frontiers in medicine, and it says it's a specific suggestion for the Asian Indian haplotype, and it says it represents a separate occurrence of HBS mutation. A genetic background characterized by high levels of the fetal hemoglobin. He's already compared the Burla study with the Jamaican cohort, and he clearly has dissected out the clinical features why Indian haplotype is considered milder, and that is particularly because of the fetal hemoglobin and the accompanying alpha thalassemia. So the features to tend to inhibit sickling change the expression of the disease and may be modified by nutrition, malaria and other infections, and limited public health resources. And as we are a developing countries, we are improving the health facilities across the nation, and there is a push to make the healthcare available to the nook and corner of the country. And as Dr. Vinita suggested, we must reach out the underprivileged at their homes so that we are able to give equitable health care. And as per the estimates, 3 countries, Nigeria, Democratic Republic of Congo and India contribute about 50% of the global burden of newborn babies. And India is estimated to carry the second highest global burden of the disease. And I mentioned in the earlier slide also, India alone contributes about 44,000 babies to the global sickle burden. In case we are thinking in the last 10 years, we would have added about 500,000 sickle babies in the 10 years. So the burden keeps increasing. We need to identify them. Why? We have a diverse pattern in India, and sickle gene first was detected by Lehman and Karpush in the Nilgiris, and we have a diverse population of ethnic communities which are more than 2,000, and among them, as I mentioned, it's a tribal. It is designated a tribal disease. Many of the tribal communities have been investigated, and we have reports of more than 300 communities being tested on. The prevalence varies from tribal groups from state to state and varies from 0 to 35%. And the next speaker, Dr. Anita, is probably going to speak on the newborn screening. And along with Dr. Anita, in 5 distinct states, we also carry out newborn screening. And we are trying to identify the clinical symptoms or the patterns that affect the children, because 20% of the children in India die before the age of 2, and 30% of the tribal children affected with sickle cell die before the age of reaching adulthood. So, and those studies have revealed the NBS population anywhere prevalence of 2 to 40%. And including the sickle cell trait and the disease, there are about 20 million people suffering from sickle cell in India. And SCD is mainly prevalent in socio-economically underprivileged communities, scheduled tribes, scheduled caste, and other backward communities. Many of them tend to live in remote areas where illiteracy and poverty is abound. And high prevalence of HBS among scheduled communities is due to the combination of factors like high rate of consanguineous marriages, high selection pressure due to malaria, and it is one of the strongest theories that support the existence of sickle cell in countries like Africa and in India, where malaria is abundant. And competitive evolutionary exclusion of beta thalassemia. I mentioned that most of these studies in India are pertaining to tribal communities. So the estimates made for the Indian population is kind of partial. It's not a complete estimate. So unless we have the burden coming from the other communities which are also affected by sickle, we will not have an entire picture of the country. And very few, most of 80% of the studies in India pertain to tribal population, and the other backward communities and scheduled castes contribute only 20% of these studies, and the numbers are very low, so to identify the exact prevalence. So just to give an idea of the low number of research publications on the prevalence of scheduled castes, I am just quoting the papers since 1962 and 2005. And we also have sickle in the general communities like Brahmins and other Muslims and Marathis. So there are few studies on them. So unless we have a picture of all the affected communities, the Indian burden of sickle cell anemia is not going to be complete. And the mission 2047 will be partially successful, if I may say, because we will not be including the prevalence or the burden data of other communities which are included in the sickle cell. So for a complete mission 2047, we also need to have the other communities being screened so that we have a holistic picture of the country on the sickle cell anemia. Based on a few reports, this is a review by Dr. Kola's group, and these give the high burden states where the comprehensive picture of scheduled tribes or other backward communities, general class and SCs are available, and the most of the studies in all the populations is priority is on the ST populations. And these are some of the communities which are affected by sickle in various states. These are Bils, Dodias, Kolam, Pradhan, Pawara, Halba, Gond, Maldia, Hilmaria, Sant, Batra, Otkar, Warli, Jharia. Jharia Mehra are the SC communities. And so Garcia, Nayak, Reli, Koya, Dora, Kurumba, Soligas, and the list goes on. So I'm just listed out a few, and hopefully we will have a complete picture in the near future. As the sickle being given the priority as a tribal disease, and these 10 states contribute about 80% of the tribal population in India. So most of the prevalence loads come from these states as of date today. So what is the public health concern of sickle cell disease? I mentioned deaths occur in 30% of the population before reaching the childhood, adulthood, and even if they survive, the lifetime risk of disease remains. The management of SCA has not gained adequate momentum at national and state level, and screening is not a common practice, and diagnosis is usually made when a patient presents with a severe complication. So that is evident from, we have a sickle clinic in ICMR since 2001 in Jabalpur, where we provide diagnostic support and also the clinical support to the identified patients. So these are suspected hemolytic patients who come to us, and we test them for sickle, beta thal, and any other hemoglobinopathy if present. And we, if they are identified to be sicklers, then we suggest them to register with our sickle clinic, and we have a long cohort which has been operational since 2001, and we have about 1,300 patients so far registered with the clinic, who majority of them follow up regularly, some of them are on and off. And as can be seen, most of the symptoms are visible before the age of 5 years, and these the number of patients coming who are older than 5 are lesser in number, and the simple initially before hydroxyurea was initiated in our clinic, we used to provide folic acid and vitamin B complex, and we were counseling them, and we would suggest the do's and don'ts to avoid disease precipitating circumstances and weather, and providing those simple interventions itself improved the clinical status of the patients, and most of them from severe form and moderate clinical features shifted to milder ones. The average age of the patients on death in Madhya Pradesh in our sickle is about 15 years. And how we arrived at it is through more as a verbal autopsy, because when we scrutinize the data of the clinic, we identify patients who do not come regularly or have absented themselves from a routine follow-up. When we tried to pursue them and we reached the families, then they said the patient is diseased and not available. So we tried to find out the, based on the family data or what happened just prior to the death. We have a few data. The exact cause of death is not known. It is a supposition based on the parental or the caregivers, I think. And splenic sequestration, hepatic failure, deep vein thrombosis are the higher causes, severe anemia, and acute ischemic stroke and fever. And so these are the main things as perceived from the parental or the caregiver perspectives. Why is knowledge of distribution and burden essential for adopting corrective public health? Estimates of affected births in scheduled and non-scheduled groups are essential for assessment, development of healthcare infrastructure, screening programs, treatment and preventive management of ACA is essential. I mentioned that most of the data coming from India is about based on this tribal population. I am not against singling out any other community. It is just the observation that we find I am presenting as a data, and most of the patients who come to our clinic happen to fall in the category of scheduled caste and OBCs rather than in the scheduled tribes. So unless we have a comprehensive picture, we will not be able to provide epidemiological data on the country. One other thing that we find in the clinic is the preferential treatment of male for any health issue or any other family issues. Initially, the pediatric population that attends our clinic happen to fall in the pediatric age group, and the number of males attending are more than 60%. As the age group of the patients on the stratification is taken out, we see the female numbers increase post 20 years. That is the reproductive age, and these patients are the referred patients from the gynecology department. So when they reach the gynecology, if they are found to be anemic, they are referred to us, and then we identify them as sicklers. So this bias also is there when we look at the data. So the caste bias is there and the gender bias is there. It is not specific, it is a habit that we see in our communities in India. It's not that I do or the family wants to specifically inhibit a female getting attention. It's the priority given to male child is more. That's what is evident from the data. So the key challenges and the need of the hour is that we have low awareness among communities and caregivers. There is no national data which is complete. There are various variable models of screening, no referral systems, no crosstalk with NGOs or private partners. So how do we overcome this? Establishing uniformity in screening for SCD, comprehensive care in all states, inclusion of non-tribal population in screening, all antenatal mothers to be screened and followed up. Because if we can prevent the death before the birth of child before coming into the world, we would probably reduce their ill health. Adoption of POCs and digital support, scoping into the raw data of testing at central point on priority, and some of the aspects have been taken up by Ministry of Tribal Affairs, and I would thank Dr. Vinita's efforts here and establishing of a network of public-private partnerships and NGOs. Currently, the issues that haunt us is the current status is no diagnostic facilities still in many district health and public health centers, no awareness among the healthcare professionals for need of screening, burden of hemoglobinopathies in various states is still required, and symptomatic screening. Lack of prenatal diagnostic facility in many states is one of the major things that is going to affect us to avoid birth of newborn affected children. So what we need to do? We need to do a door-to-door screening for most of the vulnerable communities, newborn screening, so that we can identify the children early and put them into therapy so that the children have a better quality of life and their longevity is increased. And we need to screen the school-going children, unmarried adults, couples, And some of the aspects are included in the present mandate that Ministry of Tribal Affairs along with Ministry of Health and Family Welfare have taken up. And prenatal diagnostic centers is a must, and we need an intensive awareness campaign, because we can only remove the low awareness with intensive campaign. And the school introduction of education in mid-school and high school is essential, because children can be changed for the community. Because if the parental population is ignorant or illiterate, it is difficult to make them understand. If the health education about sickle cell is introduced in mid-school, we are also targeting dually. They are screened and they are able to understand, they can pass on the information to the parents, and when they come into the reproductive age, they are aware and they can cut down the birth of sickle cell children. So I've already mentioned antenatal screening and newborn screening for early detection of SCD is extremely useful for improving the quality of life. Therefore, neonatal screening for SCD is recommended. And currently, neonatal screening is going on, but it is in a smaller state. We need to have a universal screening across the country so that we are able to identify them early and put them to intervention. And patient counseling is a key success to improving the quality of life of people who are diagnosed with sickle cell. And genetic cell counseling of services to families at risk, and explain the expectant mothers, the need for testing them and their husbands. Counseling the mothers and newborn children diagnosed with sickle cell diseases, and arrange necessary clinical follow-ups for the newborns. The follow-up of the newborns is also one of the key issues, because these mothers or the parents are in remote areas with low accessibility to the healthcare or poor economic conditions. So when we encounter these parents, they say, हमारे पास पैसा नहीं है, आपके पास clinic के लिए आने. And Dr. Vinita rightly said that we must go to them. So when we plan out the screening strategies, we have to have a method where we reach those people who are not able to reach to us. And the mission Sickle Free India by 2047 needs the development of SCD registries, medical education and research in sickle cell anemia, periodic comprehensive health camps for SCD patients, POC kits, digital health education and engagement programs, qualitative studies among SCD patients, and on patient stigmatization, quality of life and morbidity pattern, documentation of morbidity profile and crisis. The death of sickle patient in our own clinic also, we don't have a first-hand information, or we don't have an autopsy. So we only perceive the death based on the parental thing. And when you go to these communities, for them, they say, "Bacha bimar tha, mar gaya." So beyond that, they don't have any, they go on with the life. So if we want to reduce the death, then we need to have the actual burden, we need to have the actual causes of death, and like we have the methods to have institutional delivery, we must have a method to identify the death, so that we are able to have a better understanding of the causes of death in sickle. And genetic counseling, establishment of special centers for treatments, involvement of community and NGOs for better community reach. And this slide summarizes what we need to do. Develop self-help groups, resource mobilization, sustainable system, identifying disease burden, unified single national program for SCD, addressing the stigma, collaboration of public-private partners, network of referral systems. That will only improve the community empowerment. Thank you.
We can take one or two questions if there are. Anybody has any questions? Okay. So I now request Ms. Vinita Srivastava ji to please come on the dais and felicitate Dr. Raja Subramanian. Thank you so much to both of you. Moving on, our next speaker is Dr. Anita Nadkarni. She is working with the National Institute of Hematology, Mumbai as a scientist F. She has an expertise in gene expression, genotyping, hemoglobinopathies, DNA analysis, DNA sequencing, and much more. She has published more than 130 papers in international and national journals of repute, and she will be speaking on the neonatal screening and prenatal diagnosis of sickle cell disease. So before Madam begins, I just request all the speakers to kindly stick to the timeline, that about 15 minutes for the presentation and 5 minutes for discussion. Thank you so much.
Before I start, I want to thank the organizers for giving me this opportunity to talk on the topic newborn screening and prenatal diagnosis in sickle cell anemia. So basically, if you look, the newborn screening is the practices of testing all babies in their first days of life for certain disorders and conditions that can be hindered with normal lifestyles. And these include serious but treatable diseases, most of which are genetic, which cause serious health problems in initial stages. So what is the purpose of newborn screening? First is to detect the potentially fatal condition as early as possible, often before the infants display any symptoms of the disease. Thus, early detection, timely treatment can help to prevent the lifelong threatening illnesses. If you look at the history, newborn screening started way back in 1960 in USA, and later on it has been expanded to other countries. The main components of newborn screening is education, screening, diagnosis, early follow-up, management, and evaluation. So what are different types of newborn screening are there? One is universal screening, where all the newborn babies born will be screened for sickle cell anemia. Second is targeted screening, where only those babies will be screened whose mothers are sickle cell trait and the high-risk sickle cell patients. Usually, this newborn screening is done by collecting cord blood samples or by heel prick samples. So these are the common disorders for which newborn screening is being carried out. Most of them are the metabolic disorders, and today I will be talking on sickle cell disease. So it is well documented that sickle cell disease is life-threatening. Early complications can be largely avoided if the diagnosis is made early. So thus, newborn screening permits us timely diagnosis, initiation of prophylaxis treatment, that everybody know, vaccination, penicillin, establishment of comprehensive care. And this eventually leads to decrease in the morbidity and mortality. So this chart shows you how the newborn screening is being carried out in the laboratory. The sample can be collected at CHC, PHC. Sample can be either cord blood, heel prick sample, or venous blood sample. Usually the heel prick sample is directly taken on POC divide or on the dye spot, then taken for HBS screening. So usually the HPLC is the, the gold standard, but now the POC also has come for sickle cell in the field work. So once the sample is subjected to SPLC, you have to see the presence of S or absence. If it's absence, there is no need for going for newborn screening. If it is presence of S, we see, if you run a not HPLC, we see for the ratio of HBS to HBA to detect whether, to suspect, you cannot say detect, to suspect is that S homozygote or S trait. In POC, I have written down about hemotype SC and sickle scan because my department has got this experience. Now Gazelle also have come as POC, but we have not used it. So here you just have to see for presence of sickle cell is present or not. And then if you have a facility, you can do confirmation by molecular analysis. This is how the sample is collected. Left side is a cord blood sample. You should be very particular that maternal contamination is not there. In Hillprick, you have to take the proper, the first one which is showing your circle should be fully filled, then only that is sufficient for the testing. This is just tells you the specimen storage. If you have a cord blood sample kept at 4 degrees, should not be more than 7 days. If you have the dried buzzard, it should not exceed 1 month. These are all technical, this thing. Then HPLC, I have already explained you about the ratio. Now I'll show you some of the chromatograms. Now, if you have a newborn screening sample, there are two Biorad machines. One is dedicated for newborn screening, and one is ordinary, which we usually use for adult sample. So these are showing the chromatograms of newborn samples run on variant NBS machine. The first pattern you can see is FA pattern. You don't see presence of S, so that's the normal newborn. Here you see a FAS pattern. This is a sickle cell baby. Sickle cell trait baby, sorry. And this is here you have seen hardly any A, absence of A, F and S pattern. This is sickle cell homozygous. This is same as I said, run on the variant 2. Only the peak patterns are different in two machines. Normal sickle cell trait, sickle cell homozygous. Now coming to point of care devices. The criteria mainly for point of care is ability to diagnose sickle cell disease, low cost, the portable device, accurate result, no instrumentation required, no electricity, no refrigeration, and visual and quantitative interpretation. I will be talking of these two POC, which mainly in detail I'll talk about hemotype SC because we have validated this. So I'll not go into the detail. I think Dr. Reena has covered this. But basically in POC, it is a lateral flow of sample analyte to detect the sickle cell. And monoclonal antibodies are used. So this is hemotype SC. So these are the strip, how it look like. And in hemotype SC, the absence of the band shows presence of the hemoglobin. So in the first strip, you can see there is absence of A. So that's the normal sample. In second sample, you can see absence of A and S. So that's the sickle cell trait, and then sickle cell homozygous. You should always get the control band in your POC. If you, the second you can see if there is no control band, it's not validated. Only the drawback of POC is this method does not distinguish between the HBS phenotype, like sickle cell homozygous, sickle beta, SD disease. It needs the molecular confirmation or the family studies. This problem, what you get, if the hemoglobin is low, you will get a very faint band. So many times you require a quite expert technician to report the reports. This is the another distinct sickle scan. Here, a presence of hemoglobin detects if it's sickle cell trait or sickle cell homozygous. So in India, as such, if you look, there is no newborn screening program. Affected babies are getting identified when they become symptomatic. As Dr. Raja said, some severely affected children die very early in life. So why there is a need for newborn screening? To understand the natural history of sickle cell disease in India, raise a cohort with long-term follow-up and regular review of affected individual, evaluate the benefit of early comprehensive care and possibility of prenatal diagnosis in the future pregnancy. Now I'll just show you some of the data. We have undertaken an assessment of newborn screening in 7 states of India. Madhya Pradesh, then in Rajasthan, Gujarat, Maharashtra, Tamil Nadu, and Odisha. These are the 6 states and 7 centers. And up till now, we have screened more than 55,000 newborns. And you can see we have detected 427 sickle cell homozygous and about 18 HBS beta thalassemia cases. This just shows you the overall table of all 7 centers. And you can see the high incidence was found in Gujarat, Jagadia, and RMRC Bhubaneswar, but overall incidence ranged from 0.5 to 1.6. And then we have got this flowchart for the clinical management of our newborn. We follow them every 3 months for hematological and clinical follow-up. And this shows you the follow-up of our sickle cell newborns. So out of 427, follow-up was only possible in 315. As Dr. Raja mentioned, it's very difficult many times to go in the interior. And we have initiated treatment is 244. And these just gives you the what treatment we gave. And there were about 12 deaths in this cohort. 5 were from Jabalpur, 4 from Gujarat, and 3 from Rajasthan. Only in 2, this thing we know the reason. They say there were infections, but otherwise in other 10 babies we do not know. So, nevertheless, sickle cell disease can lead to major morbidity and mortality and early death. So control of sickle cell disease through carrier detection, genetic counseling, and prenatal diagnosis is a realistic approach. So in genetic counseling, you can offer to the couples having an affected child or the couples at risk of having sickle cell baby, or the heterozygote, you can give the counseling of their progeny. Prenatal diagnosis carried out at 1st and 2nd trimester. Which couples will need the prenatal diagnosis? As you know, in any autosomal recessive disorder, there is 25% chance in pregnancy that you will get the affected baby. So if both the parents are sickle cell trait, one is sickle cell trait beta thal, S, D, or SE. So these are all clinically severe conditions. Prenatal diagnosis, nothing but the sampling of fetal origin. 1st trimester carried out at 10 to 12 weeks. 2nd trimester, amniocentesis, 16 to 18 weeks. 2nd trimester by chordosynthesis, again 18 to 20 weeks. Oh, that is 16 to 18 weeks. There the sampling is Korean villus sampling. Here, amniocentesis, and both these require DNA analysis. And for chordosynthesis, we do it by HPLC analysis. This is just showing a Korean villus either done by transabdominal or transvaginal. This is the original CVS looks like. You have to clean it properly under inverted microscope to get rid of all maternal contamination, because later on you are going to do the DNA extraction and PCR and amplify the sample. This is the strategy we used in our lab for detection of mutation. It just shows you the picture. This is 2nd trimester. Usually couple who are diagnosed late in the pregnancy are referred for this. We require about 0.2 ml of blood sample. Here also you have to be very sure that your sample is 100% fetal. So usually the Claire-Botkin test is used. Diagnostics approach, what we use here is we have standardized that if a hemoglobin A is less than 0.5%, usually the fetus is affected. So the first one is a normal fetus. Second one, you can see absence of HbA, that's a thalassemia major fetus. And the third one is a sickle cell trait fetus. The problems in genetic counseling of sickle cell patient. Clinical course is extremely variable. Unlike beta thalassemia, clinical severity in sickle cell disease is less predictable. Many families have not experienced the previous child with sickle cell disease. And as you know, it is mainly in the tribal population. The couples are unwilling to travel to long distance. There are hardly any prenatal diagnosis centers where CVS is being carried out. and cost involved is many times not affordable. These are some of our data of prenatal diagnostics. We started way back in 1986. If you look at the trend, initially, first trimester references were only 14%, whereas the second trimester were 86. And now you can see that we get more couples referred to us for prenatal diagnosis. That shows increase in the awareness and acceptance of prenatal diagnosis. This is our data. Till now, we have done prenatal diagnosis for more than 1,000 couples for sickle cell and 152 for sickle beta thalassemia. So the take-home message, we can say that both neonatal screening for comprehensive care and the prenatal diagnosis for community control of sickle cell disease must go in hand in hand for any successful program. And in any autosomal recessive disorder, the prevention is only the cure. That's all. Thank you. Any question?
Questions? Any questions? Anybody has any questions? No. Okay. May I now request Dr. Apruv Das to please come on the dais and felicitate Dr. Nadkarni.
I'm just taking the water bottle. If any
Our next speaker is Dr. Deepti Jain, and Dr. Deepti Jain is a former professor from Government Medical College, Nagpur, Maharashtra, and she has expertise in clinical hematology and hemoglobinopathies. Madam has published several papers on sickle cell disease, and she will be speaking on the morbidity profile of sickle cell disease patients in India. I now request Dr. Deepti Jain to please come on the dais, please.
Thank you. I think my job is already done by Dr. Sargent when he spoke about differences in African and Indian sickle cell disease. He talked of most of the clinical presentation, and the care in critical care will be covered by the next speaker, Dr. Jyotish. So I can speak on my newborn screening follow-up experience, or if you have questions, I can do that, whatever you want me to do. Shall I continue my presentation? Yes? Okay, sure, I will do that. So this is just telling the burden of illness of sickle cell disease, and we all know that India falls under high sickle new birth, and what should I say, the modeling have shown that by 2030, India will have the maximum newborn, homozygous born in our country. Also, I would like to bring to the notice the changing epidemiology of sickle cell disease in our country. When I started seeing sickle patients, it was only this belt. It was this belt from Gujarat, Madhya Pradesh, Chhattisgarh, Vidarbha, and Orissa. But now I think, thanks to Vinita, probably, she has made many other sites visible, like Rajasthan. Rajasthan has high prevalence of sickle cell, Jharkhand, Kerala, Telangana, and now there are 14 states which falls under high prevalence of sickle cell disease. So that is the changing thing, and in few years maybe we'll see many more centers having this sickle cell disease. This is just the journey so far. See, the one concept which I keep on telling is that it was the first patient in 1952, the sickle cell in India was described in a tribal population. Since then, the conception is that few people believe sickle cell is only in tribals in India. No, not so. In 1958, it was Dr. Solanki from my medical college who had first seen a non-tribal child with sickle cell disease, a non-tribal from Chandrapur. So it's, again, I want to stress that it is in tribal as well as non-tribal. And then the journey so far has been how we came from paper electrophoresis. Today we have PO point of care test and HPLC, and how we started penicillin prophylaxis and hydroxyurea newborn screening from 2000, and we have facilities to do prenatal, neonatal. At least these facilities should be available in, I think, each state in medical colleges, at least tertiary centers, whichever center we choose to. Now, in the morning we heard repeatedly that we are Arab Indian haplotype, which is characterized by high hemoglobin F. And the mean hemoglobin F, if we see in our country, varies from 16 to 24%, which is high. Why I would say that in the Benin haplotype, it would be around 4 to 5%. So the hemoglobin F level is quite high. And when I used to talk at global platform that we have high hemoglobin and we have a severe presentation, they would say this lady does not know what is hemoglobin F. If hemoglobin F is high, the disease cannot be severe. It has to be mild. But then I know that my patients have hemoglobin F high and they are severe. So then over a period of time, we had to make many publications. I think one of the last publication is with Dr. Sargent also, that sickle cell syndrome in India is potentially a severe one. It is severe, definitely. This is another one. Many such publications were done. However, one thing I would like to tell, that it is not severe everywhere. I cannot generalize what I speak for every place in India. It is different in Gujarat, in Madhya Pradesh, in Orissa, in Nilgiri Hills, in Rajasthan. The severity of disease varies from place to place. Don't ask me, there are many factors, but then it varies from place to place. It is not same. However, for Madhya Pradesh, my experience about Madhya Pradesh is mainly Sivni, Chhindwara, Betul, and Vidarbha and Chhattisgarh. We have really very severe sickle cell patients. The severity is very high. And another peculiarity is what is written in the books is always, you will see maximum pain episodes during extremes of winter and extremes of summer. That's not true. At least in my hospital, GMC, it was from June to November, the rainy season, not the summer and the winter. We do get patients, but maximum admission, it would double during this period, and mortality also would be highest during this period. We know high and early mortality, and it's very difficult to know the exact rate of death, mortality, except you do a newborn screening follow-up, which I have done. I'm not showing the result of that. But overall, if you see Indian patients, the mortality is high. Now seen more in second, third decade. When I started in 84, I thought they live only in first decade. They do not go to second decade itself. But now with proper care, we know, and we have few patients who are 65, 75, but they are exceptions. So I would say the life expectancy is around 20 to 25 years lower than the general population. Now, there is a study from Gudlur in South India where they are following up the newborns until the age. We say the mortality is high in sickle cell below 5 years, but not a single child died in their follow-up. I think they had 120 patients and not a single child died in that area. The disease is of course milder there, but I just want to tell that I can't generalize any statement. Now these are the neonatal screening program which were going on in our country. but Dr. Anita just updated with the latest multicentric newborn follow-up program which is going on in tribal area. That is in tribal area. Now this is some of my experience of newborn. I had only one slide for today's presentation on newborn screening. We have been doing newborn screening since 2000, and my oldest patient is now 22 years old. So had very good follow-up initially, but then I got transferred. So I lost few patients, though I tried to keep in contact. But now I have very good, for last 15 years, I have a very good follow-up of my newborn cohort. And today I have 285 newborns diagnosed at newborn who are under follow-up. I just want to tell you that my experience about newborn would be 20% of them are very severe, very severe. Unfortunately, I don't know, somebody in the audience must be knowing about the severity score in sickle cell disease. We have tried to make one, but we have yet to validate the severity score. What I call severity, you also must call it severe, isn't it? So it is there for bone marrow transplant, but not for clinical presentation. So my patients, you can see that there were 13 patients, only few are shown here, out of 76 initial follow-up for 4 years, 13 patients, 13, 1-3, were admitted frequently. You can see this is how we didn't have a computer to have data in it. So this is my timeline, which is there in every patient. So each color tells whether he received blood or pain or infection. And you can see for what these are the, so these are the lines which tell you that like this was admitted for stroke 3 times, imagine, at such a young age. So we were missing all this, isn't it? We would have, if I wouldn't have diagnosed them in the newborn period, I could have missed this stroke that it was due to sickle cell disease. Infections, I think our commonest problem is infection. And let me tell you, all these patients were receiving penicillin, pneumococcal vaccine, everything, every comprehensive care which a newborn gets anywhere in the world. Okay, they were followed up, everything, but still infection is really a problem. Infection, pain, and anemia. These 3 are still a problem in our patients. So these are the presentation, dactylisis, jaundice, I'll talk about it, and this is a child who had splenic sequestration. Let's talk about it. Now these are the acute events, because now as the patients are growing, our ICU now are full of patients with sickle cell disease with multi-organ damage or multi-organ damage. But the common acute complications, as I said, are painful event, infection, anemia. And in our part, I think even in Chhattisgarh and Madhya Pradesh, fluctuating jaundice is a common presentation. And many a times, these patients from the periphery come as infective hepatitis, jadoo tona kiya, but fir wapas aa gaya. That is their presentation, but they have not been diagnosed as sickle cell disease. For anemia, I would like to tell that acute presentation of anemia is seen in splenic sequestration, transient aplastic crisis, which we all know is due to parvo B virus, which is very transient. And what is very peculiar to our place is transfusion reactions, alloimmunization, very common, and we give blood to thalassemia patients also. But sickle cell patients, when we give blood, they have acute alloimmunization. And it is a very difficult condition to treat, because what will happen, I'll give blood today, patient will pass high colored urine, deep icterus, hemoglobin falls down to 3. So I'm tempted to give another blood transfusion. Vicious cycle, or complication बढ़ते जाते हैं. And the treatment is not giving blood transfusion. For alloimmunization, the treatment is different. So one has to see, for that I think we need to do minor blood group matching and all. That is what I've been always advised by other hematologists. I can't afford to do that. I cannot do at my place. And most of the places in India, we cannot do that. here, that's it. I think another acute presentation of organ damage is stroke. I think 10 to 12% of my patients will have stroke, and the commonest age would be 8 to 12 years, between 8 to 12 years. But I've seen in newborn cohort, they present earlier also. The worst thing about stroke is, I've yet to see a child who had stroke once and did not have again. Once they have a stroke, it is such a morbid condition, they have repeated attacks of stroke. So it's very and it's sad to see these patients who have stroke. So the best thing is to avoid stroke in sickle cell disease. And how we can do that, I'll come to it. I think that's all from this acute manifestations. Chronic complications, I would just like to tell that avascular necrosis is seen in around 30 to 40% of our patients by the age of second to third decade. You may not see in first decade. But here one thing I would like to say, any child who comes with pain in back and hip joint, back pain ही बोलते, hip बोलते हैं, you must suspect AVN at the earliest. AVA can be seen in shoulder joint also, in the hip. These are the common sites. But shoulder joint you see on X-ray, but manifestation they do not have much. But AVN you can detect earlier. That is what I wanted to tell here. Osteomyelitis, not uncommon in infections. We do get osteomyelitis, and at very young age, and for that they are admitted for months together. One thing which we have never discussed is splenic abscess. Splenic abscess is seen very, I think every month I must be seeing 3 to 4 splenic abscesses. And you give them antibiotics for 3 months, at least 3 to 4 months. But if they do not respond, the treatment is splenectomy. There are controversies about splenectomy today, because for hypersplenism I used to do splenectomy, but now I have been told there are some other complications which are coming up after splenectomy. So you have to do it cautiously, not that you do not do, but you do it cautiously with proper follow-up. Eyes, I think one sign which we always had was coma sign. My resident would say, Madam, रात में admit हुआ ये patient, he is sickle. I said, does he have a report? No, madam, he has a coma sign. It's a corkscrew vascular distribution in the eyes, which is very peculiarly seen in sickle cell patients. Of course, this is a benign thing, but then severe things are there, but not as common as in sickle SC. I have seen only 2 patients SC. In India, we do not have SC. And many of the places I have seen SC treatment you will do. This is from African population. In India, we do not have SC. The other thing I would like to tell here is trait, sickle cell trait. I've seen people giving hydroxyurea also to patients who are AS, that is sickle trait. Sickle trait, I would say, only under stress conditions, high altitude, severe infection, sometimes in pregnancy, they do have clinical presentation, but the books have mentioned renal manifestations and stroke sometimes in patients with trait. But do not give routinely folic acid, hydroxyurea to trait patients. Traits are for counseling. That is why we call them Vahak. They are the spreading, they spread the disease. So Vahak, that is what we call them. Heart, yes. About heart, Western books describe pulmonary hypertension is a common cause of death. However, in our place, it is renal failure. And what we see in heart as morbidity is cardiomyopathy and arrhythmias. Sometimes I see dysarrhythmias in patients of sickle cell disease. Okay, now this is a slide showing what are the bacteriemic pattern we see in patients with sickle cell disease. And as you can see here, that it is the Staphylococcus which is highest. Highest is Staphylococcus, then E. coli, Klebsiella, and Salmonella. So the message here is, it is not only Streptococcus pneumoniae. In spite of giving prophylaxis, we do get this, and I just heard from my previous speaker, that the cause of death were infections, whatever they knew. Yes, infection is very common. So you have to admit a child who comes with fever, about 100 degrees or more. Do not take risk and start straight with higher antibiotics. Never be conducive with antibiotics in patients with sickle cell disease. Acute chest syndrome, one message I would give, this is another cause of mortality, quite seen in our, but it is usually that you give IV fluids. My teaching, when I was a resident, give IV fluids as soon as the patient of sickle cell comes with pain. Give Lomodex. No, not now. IV does more harm because we just keep on giving fluids. We never measure it properly, and it is a very common cause. Acute chest syndrome starts with pain, and if you give more fluids, it precipitates into acute. VOC goes into ACS. That is what I want to tell. And every child from the age of 5 years must have a spirometer, ya balloon fulana, whistle bajana, anything for better lung compliance. So they do well when they have acute chest syndrome, that's all. We do get patients of acute chest syndrome. Splenic sequestration, I think we teach the mothers to palpate spleen. Hepatic, I'll have to skip. Kidney, I just want to tell one thing is, renal, my patients in second decade, the commonest cause of death is renal failure. And we need to do every year screening for involvement of kidney, not when the urea and the creatinine is high. You do microalbumin, eGFR, and if it is abnormal 3 times, I do it from 5 years of age every.
this is our first sickle cell super specialty hospital at Bali. It's a 100-bed hospital supported by 100 doctors, 14 doctors, and we manage all cases right from pediatric to adult to surgical to medical, whatever it may be. So I'll be talking in half an hour. One is the sickle cell issue in ICU and how to manage it. Let me be very honest about this slide. This is actual mortality data of our hospital, 2022. We lost 24 cases and we had totally 971 admissions, out of which 599 were pediatric cases and 372 were adults. Mortality 22 out of 971, 2.26%. Majority they survived at home. No deaths as far as pediatric cases is concerned. Whatever deaths we had, they were types. I would like to draw your attention to age, which is all adults. I would like Hello. Yes. If you go into the scale hours, which I have mentioned, and scale days, let me tell you that majority of the deaths we had, they were within 24 hours of admission. Majority of the deaths which we had, they were referred patients from outside. Majority of the deaths we had, they had an issue of overhydration and precipitation of acute chest syndrome. As you are seeing the list of the causes, I have made it bold and underlined also that even in India, the number one cause of death in sickle cell disease patient is acute chest syndrome. If we have to design a critical care, tertiary care hospital, we need to address this issue of acute chest syndrome. Can we prevent it? We may not prevent it 100%, but we can certainly minimize it. When we talk about various genotypes, SS, S beta thalassemia, or S hemoglobin D Punjab, is there a change as far as management is concerned? Management remains the same, whether it is homozygous or double heterozygous. There is not much of a difference as far as that is concerned. Which cases should come to ICU and why should they be there in the ICU? If you look at the design of the sickle cell ICU, it's very important that they should have a Fowler bed, which should be motorized one. Number two, they should have a facility of a commode whenever in need by the side of the bed. Number three, it should have a multi-parameter monitor and all facilities of ventilation. Facility of echocardiography, blood gas analysis, CT scan, 24/7 laboratory backup, HPLC facility 24/7, and blood bank facility must be there when we are managing these critical patients. And when these facilities are there, it becomes easy for a clinician to manage these. We all know that it's a sickle-unsickle cycle which is going on in our body, and that irreversible sickle cells are possibly responsible for various manifestations of sickle cell disease that we have. all said and done, the pathology, the physiology is altered one. What we need to do is, we need to bring back the abnormal pathology to its basically a stable state. Sickle cell ICU admissions are basically for acute chest syndrome, acute sequestration crisis, severe painful crisis, requiring 3 analgesia and more. Cerebrovascular stroke, sickle hepatopathy requiring partial exchange. Sickle cell crisis with multi-organ dysfunction syndrome. Post-operative cases may be splenectomy, hip replacement, cholecystectomy, or after delivery. This is the analysis of OPD and IPD ratio. Of 372 cases we analyzed, they had total 4,357 OPD visits. And out of these, 1,360 were the admissions. So, every third visit there was a possibility of an admission in these patients. Why I am showing you is because of the reason that it is a teaching and it is a belief that sickle cell disease patients in India are milder in nature. Is no more true. They are symptomatic, they definitely need care. The sickle cell crisis means a sudden change in a stable state of a case of sickle cell disease. It may be a painful crisis, sequestration crisis, a plastic crisis, acute chest syndrome, or hyperhemolytic crisis, hepatic crisis, dactylitis, and there is a list of it. Why it occurs, when it occurs, whom it occurs, and what treatment to give is a question mark. Everybody knows that mental or physical stress or external environment or some infection, bacterial, viral, or malarial, can precipitate it. It can occur at any time, and it can occur to anyone, a pediatric case or an adult or adolescent. And what treatment to give, it depends on so many factors. When it comes to a painful crisis or a sequestration crisis or any admission in the hospital, my priorities are like this. First 10 minutes, clinical examination, differential diagnosis, order investigation, decide about the treatment plan. Second 10 minutes, IV access, sample collection, first dose of analgesics if there is a pain, antipyretics, multiparameter monitoring, oxygen supply, as per the need, intravenous fluids, question mark about blood transfusion, need of antihypertensive agent, or even anti-G for that matter, at times vasopressor agents and use of diuretics. The third 10 minutes is for counseling. Patient and the relative are to be called upon, they should be counseled that what we are going to do with the patient. Majority of the time we take it for granted that this is a tribal disease and they are less spoken people, they would not ask us more and we do not need to counsel them. That is a belief. I think this is a modern era of science. We need to counsel them whatever is going to happen. A case of painful crisis can go into acute chest syndrome by evening and patient can die. A patient of acute sequestration crisis, you feel that one blood transfusion would be enough, patient may die. A patient who comes with a painful crisis goes for acute kidney injury and patient can die. So, it is a totally unpredictable disease, and that is why it is very important that we must counsel all these cases, and that counseling should be in detail, if possible in morning and evening, at least for 3 days when patient is in ICU. We should also explain to them the probable course of the disease, likely complications, and explain about the possibility of acute chest syndrome. When we counsel, we make a condition, at least 2 relatives, responsible relatives should be with the patient for first 3 days. And we ask them that keep your relative ready for blood donation if there is an emergency need. The pain is everywhere in the body, but the severity of pain may differ. It could be lower limb, upper limb, backache, chest pain, abdominal pain, and even a headache. This is the analysis and observation of pediatric cases and adult cases. If you look at this slide in the white background, what I have tried to show here is that chest pain was more common in adults. Number 2, backache was more common in adults. And number 3, headache was also more common in adults. Having said that, whenever such patients are there, if they have got a chest pain, use spirometry right from day 1, from first hour. If they have a back pain, it's very, very painful condition and it requires stronger analgesic agents. And at times it is combinations. And if there is a headache, there is no choice but to get CT scan done immediately. It's an emergency. And going further about the severity of the pain, these are the charts that we are seeing day in, day out. They are there in the textbook, in the literature. But pain perception is different for every case, and I don't think that these charts are useful very much when we are in the clinical practice. I think best thing is believe whatever patient is saying. If he says it is a severe pain, believe that it is a severe pain. Design your strategy of planning accordingly. Look at this. Sickle pain is the worst pain mankind has today, and it is intolerable. Demands first dose of analgesics within 5 minutes. Pain is common than the most frequent, and whenever you have given one second choice, third choice, और आप बोलोगे कि हाँ आपको तो देखो मैंने उसको बाजू वाले को 2 दिया है, आपको तो 3 दिया है. Don't complain about the pain. I have seen doctors and the residents telling that like this, that we have done enough for you. No. Take words of the patient. It's his demand and it is his feeling. So give enough analgesic agent and multiple analgesic agent as per the need of the case. And it is always good to have a continuous monitoring of such cases on multi-parameter monitors. Mild pain is fine with paracetamol and codeine. Moderate pain can be managed with paracetamol, codeine, or ibuprofen, or diclofenac, or ketorolac, or butyl patch. But severe pain requires your real thoughts. Intravenous medication in the form of ketorolac, pentazocine, butorphanol, butyl patch, at times contramol, at times diclofenac, whatever you give, but select one agent, give at a required interval, give the maximum dose. If no control, supplement another drug at 3 hours interval to have a good coverage. In our hospital, what we do, we start with ketorolac, we supplement with either pentazocine or butorphanol, or at times we give even the butyl patch. Having said that, if there is a pain persistent, we use even tegretol, diphenyl hydantoin, we use even hydroxyzine, hydrochloride. So these are the medicines which are available as a spectrum, and let me tell you, this kind of severe pain is occasional and it is not so frequent. Do not worry about the addiction component. Do not worry about the dependence on this. It is the requirement of these agents at that particular moment. Having said that, there is a role of physiotherapy, music therapy, use of laptops and the mobile nowadays, and one more thing. I always allow, not only allow, I encourage relatives to sit by the side of the patient even in ICU. Do not worry about the infection component. There are people who move in and out of the ICU, right?
we are not dealing with a neutropenic patient. We are dealing with a case who has got a pain and he requires soothing effect of the relatives around. Drug used for pain, if you see this, majority of the patients were okay with 1 or 2 drugs. Very few, 14.16%, they required 3 drugs, and very few required 5 drugs. So this pain can be managed very well. If you look at the consumption of our hospital for various agents, we use 8,049 ampules of ketorolac, excellent pain control. And this year it is 7,960. I do not know whether the hospitals that you are running, how frequently you use ketorolac. Otherwise, it is a wonder drug and it should be used. In patients, stop complaining of pain suddenly. That is the most dangerous sign. Patient came with a pain score of 10, and you go in the afternoon round, patient says, sir, I am better. And you go in the evening at 7 o'clock, patient sleeps. You arouse them and patient opens mouth, opens eye and says, कैसा लगता है आपको? Patient says, साहब बहुत अच्छा लगता है, नींद आ रही है अच्छी तरह से. That's a bad patient. In next 12 hours of night, you are going to face a mortality, let me tell you. He is a bad case. And be on toes. Either he is heading for a cerebral complication or he is heading for a chest complication, right? So be careful as far as that is concerned. When we talk about the hydration, I'll spend few seconds or a minute on this. When we talk about the hydration, think about euhydration. Think about overhydration. Think about dehydration. When we talk about sickle cell, it is hydration, means you have to hydrate, pani piyo, batla lagao, pani, nahi. That is not the way that we should be managing case of sickle cell disease. We should evaluate that. At least sickle cell disease patient in ICU requires proper monitoring of hydration through IVC collapse, echocardiography, input and output chart, even the catheterization if there is required. Where you want to push fluid, whatever you are going to the vein. And look at this, lot of interstitial fluid is there, 80%. There is extracellular fluid, there is intracellular fluid. Only 20% is plasma and we are pushing fluid there. Where you want to hydrate? Now the literature has come and there are reports that intravenous fluid has done more harm than good. This is the literature. This is the publication in 2022, yes. Intravenous fluid administration and risk of adverse outcome in sickle cell disease patients hospitalized for vaso-occlusive crisis. This was a root cause of acute chest syndrome. In fact, we made them, aggravation of the condition. They were better off without this. We made them worst. So it is very important that we teach these kind of techniques to the healthcare provider, maybe primary, secondary, tertiary, whatever it may be. But it is very important that we should have a wisdom in using intravenous fluids in these patients. A schematic presentation here. Whenever there is a cold, there is vasoconstriction, CVP goes up, it is a vasoconstriction, and in a vasoconstricted vessels, you are trying to push more fluid in. That is causing problem. So there is a caution that do not use unnecessary intravenous fluid. In our hospital, we do echocardiographic monitoring twice a day. We are stringent as far as that aspect is concerned. Perfect, either it is a zero balance or it is a negative balance. We are cautious when there is a plus 5% or 10%, because that is the cause of acute chest syndrome precipitation. Electrolyte analysis, you can see we have analyzed 2,144 electrolyte reports. Very few had significant hyponatremia, majority were eunatremic. We hardly have seen much of a differences in the potassium level also. What I see that these patients with sickle cell disease are having reasonably good electrolytes and they are balanced. They are not destabilized as far as that is concerned. If you want to maintain which euhydration, which fluid you will use? You should use 5% dextrose or dextrose normal saline 0.45%. Please do not give a lot of sodium to these patients, that will harm these patients. And monitor input and output chart. Use Lasix when it is required. Use it. 70% of our ICU patients, they receive Lasix drip, Lasix infusion, right? And I think that is the key of survival of the sickle cell disease patient in ICU. Use of blood transfusion and use of exchange transfusion. Blood transfusion, every patient has a stable state hemoglobin. I have a patient who has got 4.5 gram per cent hemoglobin of the age of 65 years. She is fine, she is cooking, she is washing clothes, सब कुछ कर रही है, उसको ब्लड ट्रांसफ्यूजन देने की जरूरत क्या? She is stabilized at that. And many times it is because the blood is free for sickle disease patients, there is a tendency on the part of the doctors that try to use it. हाँ मिल रहा है तो दे दो ना, कोई बात नहीं है. कभी कभी पेशेंट भी बोलता है कि साहब अभी आए हैं, अभी कब आएंगे, अभी आया तो जरा लगा लो एक ब्लड, क्या बात है, गवर्नमेंट देती है, आपको क्या तकलीफ है? Before 7 days I had a phone call from Bharuch hospital that the patient was to be discharged, and a patient of 22 years of age was discharged, received one blood transfusion, 8 gram per cent, went into acute chest syndrome, died. So blood is a culprit. We cannot treat these patients like thalassemias that we manage. A word about acute exchange transfusion. What is the purpose of exchange transfusion? It is to lower hemoglobin S concentration to less than 30%. Now, whosoever does partial exchange transfusion, it's my humble request, we are in the century of technology and the availability of the laboratories around. Please, please, please estimate hemoglobin S concentration if you really want to benefit these patients. And exchange transfusion, partial exchange transfusion, if you plan, you cannot plan exchange transfusion like a plan surgery on the next day morning. I will call anesthetist, depending on his requirement and the feasibility, we will plan exchange. No, exchange transfusion is a requirement. Even in the middle of the night you have to do it. Patient is deteriorating, oxygen saturation is going down, RR is going up, X-ray is showing pulmonary edema. You have to do it in the middle of the night, and HPLC should be there 24/7 in every hospital who does exchange transfusion. Because we have to find out that how much HbS we are removing and what we are achieving. Without that, it is difficult. And my word of caution, every patient who is undergoing exchange transfusion, please, please, please do two things. One is CBC. Look at the hemoglobin level. Many times we do not know what was the level of hemoglobin of the donor. Many times it is going up, which will make things adverse. And HCT, hematocrit, you rightly said. Hematocrit, if it is going up, it's a bad sign. That is why it is very important. Yes, I'll be completing. It's very important that we always take into consideration the various laboratory methods at our advantage. Fever is a symptom which may be because of bacterial, viral or malaria. We need to find out what are the causes. Dr. Dipti Jain already mentioned about the various bacterial pathogens which are responsible as far as India is concerned. There is specifically absence of pneumococcal sepsis in our India, and for which we are talking a lot. These are the various reports of our hospital, and as we see, our blood culture report positivity is 19.67%. And let me tell you that majority of the organisms that we found out, the salmonella was commonest of the lot, and the salmonella which we got in one patient was resistant to all. We gave Paraxin chloramphenicol empirically, and patient got cured of it. Malaria is again common in India, and it is one of the very, very important cause. These are the different antibiotics that we use. We even today we start with ceftriaxone. I believe that it's a good drug even today. Malaria is a real issue as far as India is concerned. We need to do good peripheral smear examination. She is Bharti, my wife, who is looking under the microscope. Rapid diagnostic tests are misguiding us a lot. There is a need to do PCR studies along with, and malaria prophylaxis should be done. Malaria parasitemia in sickle cell disease is less because it is vivax. It only invades the younger RBCs. That is why the parasitemia is less, and it is difficult to diagnose and detect them. But antimalarial should be used as a routine in prophylaxis, but it should also be used and thought of as a cause of fever. When acute chest syndrome is there, there is a problem of shock and the perfusion, sudden pooling of blood. And look at this tamanna on the extreme. Came to me in 2011, we did splenectomy, turned up after 11 years, no crisis, no blood transfusion, no follow-up, no folic acid, no hydroxia. She is studying in diploma engineering. She is fine. So there is a definite role of splenectomy in hypersplenism 1 and recurrent acute sequestration crisis. These are the patients who have undergone splenectomy at our place, and after doing splenectomy, their crisis rate has gone down tremendously, practically none for that matter. They have a different shapes, different sizes, and coming to acute chest syndrome, there are various reasons for it. What is important is this is a case admitted even today. Look at day 1 X-ray, it was clear. Look at day 3 X-ray, was showing right-sided pneumonia. Look at the CT scan, the right whole lung is involved, and even this patient has got a little fever today, and these are the reports. There is a discrepancy that this patient had 8.7, where is that? Yeah, 7.18 CRP on admission. Today it is 189.19. And this patient, although has got a rise in CRP, that patient has got a negative procalcitonin. We have thought of viral pneumonia as a cause, and we have started managing on that. Having said that, coming to aplastic crisis, it's a common cause as far as low persistent and recurrent low hemoglobin is concerned because of parvovirus infection. A word of caution to any patient who is admitted in the hospital, they should never be allowed to go to toilet. Otherwise, there are deaths that we have found in toilet in a sickle cell disease patient. It's an instruction, strict instruction to the sister. They should never be allowed to go to toilet alone. A case of sickle cell disease with cerebrovascular stroke, came with headache, did CT scan, extradural hematoma, operated, fine, went home, passed 12 science examination, studying in college. Avascular necrosis of head femur, damaged head, removed, and patient had undergone hip replacement surgery. A patient of osteomyelitis, sequestrum removed, patient is healthy, without fever, patient is fine, no problem. Look at this, brother and sister, middle one is elder, Utsav is younger one. Utsav has got 100 admissions by now, sister has got only 2 admissions. Look at the difference in the same family. So it is not that the disease remains same in the family members, it differs from one to another. Sickle cell disease is a systemic disease, and every case teaches us a lot. Every case is different, every time he is different. So that is why I say sickle is not simple. I tell to my cardiologist friend that you deal with 3 vessels. We as a sickle cell doctors, we deal with millions of vessels. We require more expertise, we require more technology, we require better infrastructure to manage all these patients. Vinita ji is here. So our institute should come up in such a way, it should have 10 times more budget than UN Mehta, and we should have a huge hospital which is catering the services of sickle cell to the maximum as far as this is concerned. So friends, this is what I had to share as far as critical management in ICU is concerned. Over the last 35 years, I think every case that we managed was a different lesson to us. and keep our eyes open, keep our mind open. We learn from every case. When we meet you all, we learn from you also, and I think life is full of learning and full of enjoyment. Thank you very much for patiently listening.
Thank you so much, sir. We can take one or two questions. Anybody has any question? Yes, I think.
Thank you very much, sir. Such a nice presentation. And my observation is also same. Acute chest syndrome is one of the most common complications which I faced. Belongs to basically a department of transfusion medicine, and we have 5 postgraduate seats also. And last 6 months, we did more than 8 automated spectroptia red cell exchange.
Yeah.
That red cell exchange is purely, we have in-house facilities for HBS estimation as well as the hematocrit estimation. Results are excellent and very good. And only one, there is that patient is a multi-organ failure patient, so they die next day. But rest of the patient, after 6 months, they did not turn up for the blood transfusion or any complications. That is my personal observations. And I would like to know that how much you are having experience of red cell exchange with a fully automated spectropia or other apheresis machines.
See, I am not the person who owns red cell apheresis machine, right? And I had discussion with one of my US friend, and they said that red cell apheresis, once you start, how much time does it take?
Sir, spectropia will not take more than 3 hours.
More than?
2 to 3 hours. 1 to 2
2 to
hours
3 hours.
Is enough.
And how much HBS does it bring down?
Sir, 10 to 17%.
I tell you, we do exchange transfusion, partial exchange transfusion. Usually our strategy is to do partial exchange transfusion if possible with 2 bags. 2 bags. Okay. For example, 50 kg patient is there, we do it 2 bags. Majority of the patients, they have got decline of hemoglobin S by 30%. 30%. The time taken is 1 hour. Number 3, the cost effectiveness, right?
Definitely.
Huge,
yes,
unbelievable,
yes.
unbelievable.
Huge,
Yeah.
The kit is costing about 7 to 10,000 only.
Yeah.
But the rest of the things are same. Bag we have to use the same. Blood we have to use the
That's
same.
true. But I think blood volume required will also be more.
Blood volume required more.
That would be more, sir. Yeah. So here, what we do is we just ask them to reserve 2, get 1 bag. Then if there is a need, we get another bag, right? And I tell you, our experience is it works very well. And out of interest, I just spoke to my one of the friend. He said, now even the Western country is trying to shift on partial exchange transfusion rather than red cell apheresis. That was his input. Yeah. Thank you, sir.
Sir, is there any difference in treatment regime of sickle cell anemia patients and sickle beta thal patients? Like there are very specific indications for blood transfusion in sickle cell anemia, but what about transfusions in sickle thal patients?
I mentioned in the very first or second or third slide possibly.
Yeah.
See, we do not go by the genotype, whether S beta thalassemia or S beta plus or SD Punjab, right? What we do is, why there is a requirement of blood transfusion, why there is a low hemoglobin level, right? Is it hypersplenism? Is it acute recurrent sequestration crisis? What it is? Has he gone for a cerebrovascular stroke, right? So it depends on that. I personally feel that genotype does not matter. It's the cause that we have to find out. Yeah.
If it is sickle beta thal 0, they require more transfusion than other patients. But you should know, sickle beta plus, no. But beta 0, they
So excellent, you have a beautiful hospital. Would definitely want to compliment you on that. So I just had a question because you said that patients post TKR, cholecystectomy, you put them in the ICU. So we do many surgeries for patients who come to us for hip replacement and other major surgeries at our hospital at AIMS. We're not an endemic sickle area, but we get patients with complications.
Yeah.
So, but we never need to put them in the ICU. So do you do pre-surgery transfusion in patients who are anemic? We do a simple transfusion. In other patients, we do a partial exchange transfusion. And with that, we've actually found that the perioperative period goes really smoothly, and postoperatively, again, we've not had any complications. We've never had any sickle patients who've needed to go to the ICU. So that was just a comment that I wanted to give.
Thank you, madam. This is very interesting question. One thing is that as far as perioperative management and requirement in terms of blood transfusion, we have done hip replacement with 6.2 gram% hemoglobin without any blood transfusion. No. I'll tell you why they are kept in the ICU. 6.2 gram% hemoglobin. We have done a splenectomy with 7.2 gram without blood transfusion. Our hospital strategy is we never ever think about raising the hemoglobin more than 10 gram% to get them for surgery. That is one. Number two, what we do as far as splenectomy is concerned, after surgeon clamps splenic vein and artery, we do hemoglobin right into the operation theater. And majority of the time, in 85% of the patient had either same hemoglobin or there was little rise in the hemoglobin because of the handling of the spleen. So, yeah. So these patients remain stable intraoperatively. Now coming to why they are kept in the ICU. In fact, keeping in the ICU is only for one reason. We are really concerned about acute chest syndrome because they are bedridden. At times, because of the anesthesia, they may even breathe shallow. And that is an observation period. Otherwise, I am telling you ICU, somebody say that this is high dependency unit, it's fine, right? It's just for the sake of the observation that we do not land up with some critical situation wherein we are not able to manage patient. That is the only purpose. Yeah.
Thank you so much, sir. I think we'll now break for tea, and before we go for tea, I now request Dr. Apruv Das sir to please come on the stage and felicitate Dr. Jyotish Patel. Ji. Huh? Thank you so much. We'll now break for tea for 15 minutes, and we'll be back with the last two talks of the day. Thank you. Welcome back to everybody. I request the media operations team to provide the caller mic for our next speaker.
म्यूट करो.
ठीक है. Request everybody to be please seated. Hello, hello. Request all to be please seated. We need to get on with the next session. Sir, I request to be please seated for the next session, please. Thank you. So it is my indeed a privilege for me to introduce the next speaker. It is Dr. Pradeep Sihare. Dr. Pradeep Sihare, who is a pediatrician at Bilaspur, and he is a clinician with more than 33 years of experience, and he will be speaking on the day-to-day management of sickle cell disease. Sir.
I am thankful to the organizers for giving me opportunity to speak in front of you. I'll give my own introduction. I am born and brought up in the sickle region and practicing there. Since last 42 years I am doing sickle care and using hydroxyurea from 1995, and I have never seen serious side effect of sickle cell disease, hydroxyurea, and running a self-financed non-profit sickle cell center at Bilaspur since last 5 years. Previously also I was practicing sickle cell disease, but the documents are not there, but since last 5 years we have some documents about my practice. So my topic is day-to-day care of sickle cell disease. Sorry. As it has been discussed that sickle cell disease, sickle hemoglobinopathy is remained a neglected part of the research, but now people have started taking interest in the sickle cell disease. And previously it was thought that it is in the tribal region, tribal people and in the scheduled caste, but now so many people have already said that it is not confined to the tribal people and scheduled caste. And of course it is a hereditary in nature, but can be managed properly. And sickle in India is a neglected field of research actually. And most severe affected children still die, born in low-income countries still die of undiagnosed of bacteremia, meningitis, acute chest syndrome, splenic sequestration, and malaria, that is called as natural elimination. And those who are surviving, sorry, yeah, जरा मेरे को इसका function बता दो. Pointer. The pointer is not working. Okay. Here. इस पे देना. Only. चलो. I'm sorry. And those who are surviving has poor quality of life. Look at these teens. See, last one is 17 years, other one is 16 years, and this is 14 years. They have delayed puberty. Neonatal screening is the solution, and it has been discussed, so I am not going to discuss it. But in developed countries where neonatal screening and comprehensive care and hydroxyurea they are using, most survive well into the adult life, and life expectancy is about 50 to 60 years with better quality of life in these countries. and then they are doing genetic counseling and prenatal diagnosis, and they are reducing the birth of the sickle patients. Interventions can improve the sickle cell survival, and it has been done in USA. They have increased the sickle cell survival. Now we don't see these patients, these complicated patients, because now the things are changing due to urbanization, improvement in economy, access to the general health, and improvement in has improved the survival of the sickle patients, creating demand for the sickle specific treatment. And one more phenomena is that is widespread migration. The laborers from Chhattisgarh and the sickle belt, they are migrating to Delhi, Ludhiana, Chandigarh for the employment, and they are living in a very bad condition, poor hygienic condition under this group is living under the flyover. And when they get this problem of sickle cell crisis or something, the doctors over there are not aware of the treatment, and they have to run back to our place. So we have to train other doctors also. And previously the sickle population was stable, but now because of they are surviving more, the birth rate is increasing and death rate is decreasing. So there will be increase in the population of the sickle cell patient, and they will demand the hospital care more. Then changing scenario. With the increase in knowledge about the pathophysiology, comprehensive care, use of hydroxyurea, infection control, early and effective treatment of the sickle crisis, the pediatric fatal disease is converting into the adult chronic disease. I am not going to discuss about the natural history of the sickle cell disease, but infants are asymptomatic up to 3 to 4 months of life, and some infants can have rapid fall in hemoglobin, fetal hemoglobin, that can cause splenic congestion, crowding of spleen, that is functional asplenia, which leads to ineffective phagocytosis, because the cyanocytes are filled with the broken RBCs, so which is a battlefield for macrophages to clear the bacteria. So they cannot do the phagocytosis in the crowded atmosphere. So the infection pass away from this, the bacteria pass away from the spleen, and that is why sickle patients have more infections. Then acute chest syndrome, splenic sequestration, infarction and abscess, they are also common in the early infancy. From 6 months to 1 year, it is a dangerous period, most of which can be prevented by and more effectively treated if we know the diagnosis of the sickle cell disease, underlying disease. So universal newborn screening is required. From 6 months to 5 years, that is also very important period. Mortality is increased more in this period. These are the complications which can happen. It can be prevented by comprehensive care and the hydroxyurea. Adolescent is a serious time. Other than the physical problem, there is delayed growth, priapism, hip, AV and hip, and psychosocial problems are more. Stool drops are there. They are neglected in family. They have depression, suicidal tendency, and drug addiction. This can be dealt with. They need major clinical and psychosocial support in addition to comprehensive care and hydroxyurea. After 20 to 30 years of age, they have honeymoon period. The bone crisis reduces, the quality of life is better now. The patient can engage in full-time employment and social activity. They get married, produce children, commonly default from the hospital, and they say कि अब तो मैं ठीक हो गया हूँ. But we need to educate them about the chronic organ damage and continue comprehensive care and hydroxyurea even when they are not having any symptoms. And after 40 years of age, the chronic pain again starts, reducing stamina, decreasing hemoglobin because exhausting and shrinking bone marrow. The chronic organ damage starts giving symptoms like renal impairment, cardiac failure, pulmonary hypertension, pulmonary fibrosis, leading to early death. They need pain therapy, chronic blood transfusion, specific organ assessment and support, and query hydroxyurea, because hydroxyurea in adults, some in adults it works and some adults it does not. Then in our center, last year, this data is from 2022. Before that, we were having problem with the data. Now, one of my colleague, he is appointed for sickle cell disease only. He is looking after it and he has prepared this data. And we have registered 553 patients in of sickle cell disease, out of which 309 are sickle SS above 5 years, and this is the number, and 24 are not reported since last 6 months, and so we have 429 regular follow-ups, and we have distributed 94,500 hydroxyurea capsule at a subsidized rate in 2022. All patients are receiving hydroxyurea. 2 are receiving convalesce, that is L-glutamine and NDARI. Because of the recurrent myelosuppression, HP was not increasing, and they have chronic pain, but now with the NDARI, they have 8 gram of hemoglobin and settled down. We asked them about the bone marrow transplantation, but they refused. 2 patients are receiving both hydroxyurea and convalesce, that is NDARI. 6 women are planning for pregnancy, so we have stopped hydroxyurea and shifted to convalesce. No blood transfusion is required and the hemoglobin is maintained. So NDARI is also a good drug. 1 patient received chronic blood transfusion to break the cycle of the recurrent vaso-occlusive crisis in 2021, who was not responding to hydroxyurea. So we have total admission 43, new cases 15 patients who were not registered with us, non-sickling illness were 3, and 1 patient admitted 3 times a day, 3 times, because he is from a broken family and he is a drug addict. So from our patient, only 23 patients admitted, that is 23 out of 429. And patient from follow-up, when we are looking at the patient from follow-up, then 23 patients, 2 had splenic sequestration. Vaso-occlusive crisis was there in 11 patients. Out of them, 4 were the defaulter, they left the treatment. Pneumonia and bronchopneumonia in 6 patients. Anemia in 1 patient 2 times, because he has just joined, he was on very frequent transfusion. He was maintaining 4 to 5 gram of hemoglobin, so he was receiving very frequent transfusion. And after the effect of hydroxyurea came, say about after 5-6 months, the requirement of blood is reduced, and now he is settled down with only hydroxyurea. And we had 1 death, that is from MODS. This patient also defaulted since 1 year. So when he came, he was in a very bad shape. We tried everything, but we could not save him. In our patients who are taking hydroxyurea, who are registered with us, we never had acute chest syndrome in hydroxyurea group and no serious complications. So comprehensive care, it has been discussed already. Hydroxyurea we are using after 9 months of age in all children, irrespective of their signs and symptoms. But if the 6-month-old child has symptomatic or has vaso-occlusive crisis or hand-foot syndrome or anemia, we start hydroxyurea with 20 mg per kg and follow the CBC. So comprehensive care, this is the list. I am going to discuss it separately. This is also we'll discuss. So whenever the patient comes first time, it is seen by the pediatrician. Either I see or I have two other pediatricians. They see the patient. They stabilize the patient, treat the sickle crisis. If indoor admission is required, then we treat the sickle crisis, treat anemia, see for deficiencies and coexisting disease and presenting illness. Sometimes presenting illness is diarrhea, and the patient is found to be pale, investigated, and found to have sickle cell disease. Then we confirm the diagnosis by doing HPLC and define which variant is there. Growth assessment is done, review and update the vaccination of that person or child. We do baseline lab assessment like HBsAg, HIV, SGPT and serum creatinine. Assess pre-existing organ damage. Some people join us at the age of 22 years with AVN of a hip. So we assess the morbidity and treat, send them to orthopedician also for the treatment. And we start hydroxyurea and penicillin if the child is below 5 years. Family support and education is done by Dr. Vinod, who was in WHO for 15 years as a surveillance officer, and he has done job in JPGO also. So he is a public health doctor. He is only seeing the sickle patients. So he has time. He talks with the patient. He has personal relation with the patients. Sometimes वो phone पे भी patient को consultation देता है, and to elevate the parental and caregiver concern, dispel misconception, and family screening of the index patient. All family, whichever patient, we are doing family screening free of cost, and discuss implications of the parental genotypes and counseling of the sickle trait, because father, mother are sickle trait, they also get worried कि नहीं हमारे को भी तो है, तो he counsels them. Then we call them every 2 months for follow-up, and we monitor personally. So Dr. Vinod see all the patients, look for well-being, any complaint or crisis, complete physical examination, CBC is done, which is must. And sometimes patient cannot come, he is very, very far away. So we don't call them very frequently. They send the CBC report from there at their place, and Dr. Vinod see the report. If any complications, then the report is seen by us, and we suggest the treatment. So in this case, the patient has to purchase medicine from their own place. So during OPD follow-up, तो हमारे विनोद डॉक्टर पूछते हैं कि भाई आपका बच्चे कैसा है, ठीक है कि खेल कूद रहा है कि नहीं खेल कूद रहा है, दूसरे बच्चों के बराबर स्टेमिना है कि नहीं है, काम करता कि नहीं करता. तो पेशेंट वेलबींग, एंड देन मदर फादर से पूछता है कि तुम लोगों की चिंता खत्म हो गई कि नहीं हो गई, बिकॉज वो उनका पैसा भी खर्च हो रहा था, चिंता भी रहती थी रोज रोज कि बच्चा कब बीमार हो जाएगा. तो बोले अब नहीं होता, आजकल तो बिल्कुल खुश रहते हैं. Third thing which we emphasize that continue the treatment. ये आज की परेशानी तो दूर होगी, तुम्हारी पैसे भी बच रहे हैं, और तीसरा है कि ये क्रॉनिक ऑर्गन डैमेज को बचाने के लिए है, तो बच्चे की लाइफ भी लंबी होगी. व्हाट्सएप कंसल्टेशन है, रूटीन इमरजेंसी, जो छोटा मोटा बच्चे को कोई प्रॉब्लम होता है, डॉक्टर विनोद उसको हैंडल करते हैं. And none of my patient is frustrated or depressed. So we ensure the routine vaccination is done, and according to Government of India or the IAP vaccination schedule, and special vaccines are given like pneumococcal 23 along with if the child has received pneumococcal, then we ensure that the pneumococcal 23 is also given. HIV is routinely given. Hepatitis B is routinely given. If the patient is affording, then we give typhoid vaccine and meningococcal vaccine. They are not meningococcal vaccine. Meningococcal infection is not common in our area, but if patient can afford, we are giving. And influenza every year if the patient can purchase it. So we do catch-up vaccination and mixed vaccination to the late joiner who are joining late. We are doing growth monitoring of each and every children because due to increased metabolic rate, they used to be malnourished, but now with the use of hydroxyurea, the metabolic rate is decreased and they are having normal growth pattern. Now we don't see delayed puberty also. Previously we used to give testosterone to the boys of 18 years or 17 years for the puberty treatment. But now we don't use it. We don't need it. So this is home management plan we give to the patient for the sickle crisis. This is this is a booklet which is given to the patient, and all the treatment and reports are compiled in this. इसी में बुखार का प्लान भी है. And this is a checklist जो पेशेंट के फाइल में पहले से है कि हम लोगों को कब कब क्या क्या करना है, तो पेशेंट को भी मालूम रहता है कि क्या करना है. एंड कॉम्प्रहेंसिव केयर कि उसके पास में भी रिटन एक डॉक्यूमेंट है कि जिससे वो पढ़ सके कि मेरे को क्यों और कैसे ट्रीटमेंट मिल रहा है और कब मेरे को फिर से फॉलोअप के लिए जाना है. एंड दिस इज पेडिग्री चार्ट. एंड सिकल मरीज को हर 2 महीने में फॉलोअप के लिए क्यों आना है, वी हैव एक्सप्लेन इट एंड इट इज़ रिटन इन दिस बुकलेट कि भाई क्यों आना है. अदरवाइज दे थिंक कि डॉक्टर बार बार बुलाता है, फालतू बुलाता है. सो व्हाट इज़ द प्रोडक्टिविटी, वी हैव रिटन इट. एंड ओपीडी में भी वी इंश्योर दैट कि वो आएँ और जल्दी से जल्दी जाएँ, मतलब उनका टाइम वेस्ट ना हो. सो सेपरेट रिसेप्शन इज़ देयर. उनका फीस भी कम है. हाइट चार्ट वही लोग लेते रिसेप्शन में. ब्लड बैंक में उन्हें तुरंत रिपोर्ट करीब 20-30 मिनट्स में रिपोर्ट्स मिल जाती. डॉक्टर विनोद इज़ लुकिंग आफ्टर पेशेंट्स, तो वो बहुत जल्दी हो जाता काम. एंड दवाई लेके वो 1 घंटे या 1.5 घंटे में हॉस्पिटल से चले जाते हैं. एंड वी हैव गिवन द वार्निंग साइंस. दीज आर द वार्निंग साइन. वेन एवर यू हैव एनी प्रॉब्लम, यू कम अर्ली. And look at this hemogram. This is the follow-up chart. See the hemoglobin 11 gram, 11.9 gram, 12.8, 10. So they are maintaining good hemoglobin, and MCV 113, 111, more than 100 is the MCV. And on remarks you can see that they never had any problem. This child had one time he had myelosuppression, and platelet count went to the 84,000. So we stopped hydroxyurea for 15 days, and after 15 days the child recovered. Indoor care, prompt diagnosis and management of sickle crisis is necessary, is required. एंड आयुष्मान योजना जब से आई है तब से हम लोग बहुत फ़ायदे में हैं. बिकॉज पेशेंट पहले बहुत लेट आते थे, डिलेड एडमिशन होता था, लिमिटेड इन्वेस्टिगेशन कर सकते थे. नाउ वी आर डूइंग दे आर कमिंग टू अस. वी आस्क देम टू एडमिट बिकॉज आयुष्मान योजना में दे डोंट हैव टू स्पेंड. सो देयर इज अर्ली एडमिशन. वी आर डूइंग प्रोटोकॉल बेस्ड ट्रीटमेंट. प्रॉपर इन्वेस्टिगेशंस आर डन. proper drugs are given. There is no shortage. And previously there used to be premature discharge. Now the discharge is complete. Discharge is done when the treatment is complete. So previously people were using, still people are using hydroxyurea in those patients who has acute pain, severe anemia, increased infection or hospitalization. But we are using in all patients to prevent the chronic organ damage, all affected, sickle affected patient after 9 months of age, and if the patient is symptomatic, then after 6 months of age. So we have 3 types of patients now. The older patient who joined us with the complication at the late age, now they are relieved with hydroxyurea and some have recurrent problem but better than before. Second group is young patient who has joined us at the age of 4 to 5 years and which presented with recurrent vaso-occlusive crisis, ACS, recurrent anemia and blood transfusion. Now they are stabilized with hydroxyurea and don't need any crisis management or blood transfusion. And this is the third group. We have a group very young children who joined us in infancy and receiving hydroxyurea. They are completely unaware of the sickle pain, crisis, blood transfusion and other complications of sickle cell disease. And sometimes their parents says कि साहब पड़ोसी बोल रहे थे कि वो बच्चे का तुम्हारा सिकल का डायग्नोसिस सही नहीं है, ये तो इतना हेल्दी है कि दूसरे बच्चों से ज़्यादा अच्छा रहता है, तुम फिर से चेक कराओ. We have to do genetic testing of these patients. For blood transfusion, top of blood transfusion. So it has been discussed, I think. I am not going because he is saying the time is up. Actually, he has shortened my time. So, comprehensive care, genetic counseling is advised if the first child is sickle. Do family screening for future children, do prenatal diagnosis, genetic counseling and post-marriage screening and preconception screening is advised. So this couple, the lady has sickle cell disease and he is sickle AS. Father is straight and mother is diseased. They were fighting. So Vinod counseled them कि you can have child, अपन उसका prenatal diagnosis कर लेंगे. So Dr. Vinod motivated them. They had child. This child luckily is AS. And so for prevention and monitoring of the chronic organ disease, we do yearly checkup. We do CBC, LFT, RFT, and RFT mein, for if the child is more than 10 years, we are doing 24 hours urine protein or protein creatinine ratio after 10 years of age. And we are not doing TCV because we don't have the apparatus, and ultrasonography after 5 years of age for gallbladder stone. We do X-ray hip after 10 years of age, pulmonary function and for the restrictive and obstructive lung disease after the age of 80 years, echocardiography for ventricular dilatation and tricuspid regurgitance, pulmonary hypertension after 15 years of age, and eye examination after 10 years and hearing test after 10 years of age. So hydroxyurea, I am just going to skip some of these slides because tomorrow it is going to be covered. It is safe, works in all ages, no resistance, no drug resistance, no addiction, no drug dependency. We are starting with 20 milligram per kg and escalating it to 35. But our aim is to ideal dose is desirable effect without toxicity. Maximum dose without toxicity is our aim. The preparation is only 500 milligram capsule. So liquid preparation can be made by diluting this with the normal water. And there is a paper from Boston. It is they have stated they have concluded that the hydroxyurea solution prepared in mildly heated water maintained at room temperature have chemical and functional stability for several months, and this solution was used in baby hugger study. Adverse side effect, there is transient leukopenia, pigmentation also occur, hydroxyurea effect on immunity. There is no increased infection due to neutropenia produced by hydroxyurea, normal predictable response to immunization, and normal development to natural immunity after to the infections. Monitoring, it should be, MCV should be around 100, and the WBC count should be 2000 to 5000, and platelet count should be more than 1 lakh. Hydroxyurea underuse. There are abundant evidence, thousands of papers that hydroxyurea is effective and safe. Many healthcare providers have inadequate knowledge about hydroxyurea. There is unrealistic fear and limited support by the lay organization in government hospital. There is inconsistent delivery system. So a patient does not get the supply regularly, so the effect is not consistent. So they are not convinced about the hydroxyurea. And last thing is that this is an orphan drug and not promoted by pharma. So pharma company MR do not go to the doctors, so they are not writing this drug. Thank you very much for patience listening. Thank you.
Thank you so much, sir. We can take a few questions. If there are any. Anybody? Any questions?
Yeah.
And not in America and UK. Is it because we are now diagnosing more patients?
One thing is that because previously the birth rate was high in sickle patients and death rate was also high. So the sickle population was stable. But now they are getting treatment, they have prolonged life, the death rate is decreasing and the birth rate is increasing because of the better antenatal care. So there will be rise in the population of the sickle patients in coming years, and it will decrease only when we will start doing prenatal diagnosis and marriage counseling.
Before they were diagnosed as a sickle disease,
yeah,
they were misdiagnosed and mistreated.
Where?
Anywhere. A patient who is diagnosed at 25 years of age, till 25 years, he was misdiagnosed and mistreated. He was never treated as a sickle disease patient.
Okay.
So what we are doing at the moment, identifying and diagnosing more and more sickle disease patients, that is why the figure is...
We are diagnosing only those patients who are missing, who missed that the train before. At the age of 25 years, we have detected that the patient is suffering from sickle cell disease, so we are treating them. Yeah. Awareness has increased.
So very nice, and I really would like to compliment you on the excellent care that you're providing to your patients. I think that's just wonderful. And hydroxyurea, as you've shown, is such an important drug, and it's very safe. But you also highlighted how it's important to monitor, because when you saw myelosuppression, you stopped the drug. So I think this is a take-home message for everyone that it's a very safe drug and we should do monitoring, and with that we can really improve the quality of life. So excellent, thank you so much.
Just one comment from our experience.
Yes.
We have started one comprehensive sickle cell clinic where government provides a permanent doctor who will look after the sickle patient. He will not be transferred or go anywhere else in other PSC, CSC. And we provide only technician and a counselor over there, and it is something like a daycare unit. It is also, patients are also admitted if there is a need of admission. Initially when we started, we have about 1,200 patients. Now it has reduced to 700 patients only, just because most of the patients are started with hydroxyurea and the number
of their own
decreased.
Yeah, that is sometimes it is dangerous.
Patients are same, they are still coming, but prices have reduced and that very less patients are coming.
See, we apart from our clinic work, we are educating the other doctors also from all our region. The people have started using hydroxyurea, and that is why we are seeing less patient, because every doctor is now treating sickle cell patient.
Thank you, sir. I now request Dr. Ruby Khan to please come on the stage and felicitate Dr. Pradeep Sihare. Please, ma'am.
Thank you.
Thank you so much.
ये वो आपके डॉक्टर मंगा रहे थे।
Now we move on to the last speaker of the day, and we have with us Professor Tulika Seth from the All India Institute of Medical Sciences, New Delhi, and she leads the technical working group for hemophilia and hemoglobinopathies at the AIIMS, and she's also a member of the executive committee of the Hemophilia Federation of India. Dr. Seth is also one of the founding trustees of GAP, that is Genomics and Public Health, which looks at genetic literacy among the public, and she will be speaking on the newer therapies in sickle cell disease. I request ma'am to give her lecture.
Okay, so thank you so much. Well, my slides are coming up. I just wanted to give thanks to the organizers for this really interesting meeting, which is discussing all the problems of patients with sickle cell in such a comprehensive manner. So the topic that has been assigned to me by the organizers was recent advances in the management of sickle cell disease. And this is actually a really big talk, but I will try to go through it quickly, because this is a really exciting time. For more than 20 years, we really only had hydroxyurea, and no other drugs were approved for sickle cell disease. And now we have many drugs available and many more coming in the pipeline. So sickle cell disease, we already know that it is due to a point mutation, but this one point mutation, not only does it cause anemia, but it causes polymerization and sickling, and it leads to a pro-inflammatory state. So even if you are controlling sickling, you may not be controlling hemolysis, and if you're not controlling hemolysis, you're not controlling inflammation. So that is one of the reasons why this affects every organ of the body, because the inflammation can affect every organ system. We already know the different types of crisis, so I will not go into that. Often the focus is only on VOC. And though it is important, but it may not be the only thing. And the reason I'm mentioning this is because even though we have hydroxyurea and we know that it can be very effective in many patients, but in spite of hydroxyurea, we still see many patients have end organ damage. So obviously we need to have even better medications than hydroxyurea. So this is the pro-inflammatory state which is there. I won't go into it in the interest of time. And now that we are understanding the pathophysiology much better, some of the newer targeted therapies are directed towards different pathological steps. So what we're going to talk about, I'm not going to talk about the goals of care, principles of care, and I think tomorrow we have a very good lecture on hydroxyurea. I'll just limit to the newer advances, a little bit on bone marrow transplant, some of the newer approved medications, gene therapy, gene editing, and some pipeline innovations. So first of all, I will talk about hematopoietic stem cell transplant, which is colloquially called bone marrow transplant. Now, this is an approved therapy, and many of our students are doing sickle cell transplants in the private sector. We have not done a transplant for sickle cell disease at AIMS, but we routinely do transplants for hemoglobinopathies as well as a variety of other disorders. And there are clear-cut guidelines for which patient should go for HSCT for sickle cell and which should not. The reason being that even though the risk of mortality and morbidity is less, but it is there. And so ideally you need a patient who has some complications, for example, stroke or recurrent VOCs not amenable to treatment, or impaired neuropsychological functioning, or sickle lung disease, or nephropathy, or some retinopathy. So with any of these kind of disorders, these patients can be taken up for transplant because, as I said, there is a risk of mortality and morbidity. There are also now some very good predictors of survival, and this is a very recent publication which can identify patients who will do well with transplant, and you can then select the patient so that you can opt for a patient whose survival chances are good with the transplant process. But as I said, it needs a lot of discussion and deliberation, and we should talk to the patient because some patients may develop chronic graft versus host disease or other complications, in which case you're basically exchanging one problem for another problem. So this is not something that should be done lightly, and patients should be aware, and there should be an informed consent so that the patient can understand that what the benefits they will get and what the benefits they will not get. The other thing is that if you take a patient very late who has multiple complications, again the patient should understand that those complications will not be reversed by transplant. So this is a very nice review by Dr. Krishnamurthy, who many of you will know, and he has talked about how it's important to have this discussion with the family. And the only other thing that I would like to highlight is the criteria for transplant are basically made by the West, and I think now that we are seeing more and more severe patients in India, it is time that we look at our data, compile our data, and perhaps even come up with guidelines for transplant in the Indian context, because I do feel that now there are some sickle cell patients in India who would definitely benefit from transplant. So again, moving on to the better understanding of how sickling and other things happen, we have now got a plethora of new drugs. We just heard from Dr. Pradeep about his experience with Endari. So L-glutamine was approved in 2017. It is a amino acid, and it's a precursor for a nicotinamide adenine dinucleotide. And what it does is it reduces the red cell sickling erythrocytosis. It also may reduce oxidative stress, which contributes to the pathophysiology. And in a study that was published, they did find that patients who were on this had a reduction in the crisis. Now, how do you take it? It actually is quite a large dose that is required to be taken. So the recommended dose is 0.3 grams per kilogram of body weight, and it has to be given twice a day. So the positive part is that it can be combined with many different therapies. It is a type of nutritional supplement, and there are not too many serious toxicities. However, even though it was approved in 2017, there are still some questions, and there's a lot of recent publications which say that there's probably more questions than answers. One is that there are a lot of adverse events like nausea and non-cardiac chest pain, fatigue, and musculoskeletal pain, and many of the patients who even were on the original trial could not complete the trial and had to be taken off. So we're not really sure too much, but it is approved, but we don't have any long-term follow-up data of the original study. So, but it is a safe option, and I think this is something that can be used in some patients and can be combined. Now we move to another drug which a lot of you in India may be well aware of, and now that we've understood how selectins work and their role in adhesion of platelets and endothelial cells, we now have a targeted therapy, crizanlizumab, which is a humanized anti-P-selectin agent. And it is basically a monoclonal antibody, and it was approved by the SUSTAIN study, and we now have this available in India, and we have a lot of experience in India using this. So this agent, when it's used, it basically upregulates P-selectin is upregulated and overexpressed, and that contributes to VOC, and this agent blocks the P-selectin. And when we use it long term, we're able to reduce the number of VOCs that these patients exhibit. And this is data from the SUSTAIN trial, where this was a randomized double-blind placebo multinational study, and they randomized patients to either receive crizanlizumab at 2 different doses or a placebo, and they found that majority of the patients had a reduction in their annualized VOCs. They had reduced hospitalization, because remember, the goal of any therapy is to keep the patient away from the hospital. So if your patient's requiring hospitalization, you need to recheck what you're doing and maybe do a course change. So this was very important, and it was approved. And as you can see, when using this, there were some patients who had not been well treated on hydroxyurea, and who either with hydroxyurea or even without hydroxyurea, these patients had a improvement in the rates of VOCs, leading to less healthcare visits. So these were some of the reasons why it was approved, and we now recommend the 5 milligram dose. And with the 5 milligram dose, you can see a greater than 2 times reduction of VOCs and reduction in healthcare. So this is something that is there, but again, we have a very nice talk tomorrow, and I don't want to steal the thunder from that, but I think in our experience, we found that patients with hydroxyurea, some patients needing the transfusion support. So just with standard of care, the majority of our patients can do well, but it's important to start therapy early, monitor therapy. There may be, of course, some patients who will use these drugs, but all of these drugs have side effects. You need to be careful. This is a drug that needs to be kept in a refrigerator, so obviously you need it to be administered at a hospital, and it can be it's an injection which can be given to our patients, and they need to come back regularly for their next injection. Now, other things that we know is that some patients who have a higher hemoglobin may do well, and this was shown in some studies, and that was one of the reasons why transfusion may be indicated in some patients. And this is an agent which we don't have in India at the moment, and this is voxelotor. And this is the first-of-class agent to increase the affinity of hemoglobin for oxygen. And how this works is it inhibits the polymerization of the hemoglobin S in hemolytic anemia, and it increases the hemoglobin, and it is believed to also decrease the risk of VOCs in patients. And this was approved in the phase 3 HOPE trial, which did go on to show that patients who were on the drug had a reduced, had an increase in the hemoglobin, as well as, so 80% of the patients had an increase in hemoglobin, and it also, and the hemoglobin was maintained, as well as a decrease in the VOCs. So this had a twofold benefit. And this led to the approval of this agent, but as I said, it's not currently available in India, and we don't really know when it will be coming. Again, all drugs have side effects, but the side effects were manageable and easily taken care of. And this increase in hemoglobin that was seen with voxelotor also resulted in changes in the transcranial Doppler value. So this could be an alternative to transfusion in some patients. And how to use it? This is an oral agent, so unlike crizanlizumab, it's not injectable, and it is a disease-modifying agent, and it has a relatively good safety profile, though some of the adverse events are headaches, diarrhea, abdominal pain, fatigue, and nausea. Now we come to the fetal hemoglobin inducers. So hydroxyurea also is one of the fetal hemoglobin inducers, but there are other agents that have been used. Earlier we read about things like decitabine, which is a hypomethylating agent that we use in myelodysplastic syndrome, but there's significant toxicity with those agents, and so they kind of were not really something that were in vogue. But we can now think of even changing the genotype of sickle cell disease. And we know that when you're changing the genotype, you may cure the patients. So what is exactly gene therapy? So gene therapy is an approach in which we modify and correct the genes. At the moment, most of the gene therapy is done using autologous stem cells, which are harvested from the patient. It is important to note that when you're harvesting stem cells from sickle cell patients, you must not use GCSF, because that can actually precipitate a crisis. We use plerixafor, which is a much more expensive mobilizing agent, which is used in multiple myeloma patients, but that is safe in sickle cell patients. And then we use lentiviral vectors to edit the genes. And there are several trials that are going on, and this is just a cartoon to show how first you have to collect the cells, then you modify the cells, and then you do myelosuppression, because you have to eradicate the person's own stem cells, and then you transfuse the modified stem cells back to the patient, and this will correct the genes. So there have been a lot of criticism and concerns about these procedures, but now they are getting approved, and there are many companies which are now commercially also doing gene therapy. And pretty much most of the gene therapy that is done nowadays, so this is one gene therapy that is approved, in which what they're actually doing is that they are so when you have your normal fetal hemoglobin, it converts to adult hemoglobin. There is a switch that is there. So basically what you're doing by this gene therapy is preventing that switch. So you end up again with fetal hemoglobin, and this gene therapy is effective not only in sickle cell but also in beta thalassemia. And as I said, there are many trials that have been successfully done, and this is now soon going to be approved. There are other groups that are working in other areas doing different types of gene correction, but the Bluebird Bio is one of the agents where they have done this gene therapy with the fetal inducers. Now, what is the difference between the transplant and gene therapy? So when we're doing an allogenic transplant, you need to collect stem cells from either a brother, sister, or some other donor. We need to give very heavy doses of conditioning regimen. In the autologous gene therapy, you're collecting the patient's own stem cells, but you still need to give some conditioning, but we don't need to give immunosuppression because it's the person's own stem cells that are coming back. So we don't need immunosuppressive agents. We don't have risks of this graft versus host disease, because even if you do HLA matching from a brother or sister, there are still some minor alleles that may be different, and you can get graft versus host disease. You have to find a donor who is matched, and when you're doing autologous, there's no risk for the donor. And so this is a lot safer than the HSCT and can be done in older patients. And in fact, at the moment, gene therapy is only approved for adults who do not have a HLA match. So then we have gene editing, which is really exciting, and we're fortunate to have Vinita ji with us. She is helping sponsor a gene editing program with DBT. So these are some of the gene editing tools, and I think I will have to rush through this, but there are, again, looking at the BCL11A gene is something that is being suppressed by CRISPR gene editing, and again, you end up with a high hemoglobin F scenario. So these are some of the, and RNAi technology is also being done. This is a British group that is looking at that. So I'll skip on that. And there are still pros and cons of gene editing, and we need to be careful about this because there are a lot of off-target gene effects, and we know that genes don't only control one thing, they may control many things, and also genes are ubiquitous in different organs, so we need to be very careful, and there are multiple CRISPR gene editing trials that are ongoing. There are also multiple new drugs coming, and one of the exciting ones is metapivate, and for those people who have seen patients with PK deficiency, pyruvate kinase deficiency, this is a drug which is approved for that and is now showing some good efficacy in patients with sickle cell. Other anti-inflammatory drugs are also being evaluated. A lot of trials are ongoing. Some of the things that we could repurpose are simvastatin, omega-3 fatty acids. Antiplatelet agents are also being evaluated to prevent stroke. So this is another area where I think much more research can be done to find the ideal antiplatelet agents for sickle cell patients. We know that the neutrophils contribute to netosis and inflammation, and this is, so far this has been studied mostly in animal models, but there may be agents that could target this. So, so there are potential other vascular pathways that are being evaluated. We already heard about the P-selectin, but others are also in the pipeline. So there's a lot of excitement in this. One of the things that I think is really important is monitoring. At AIMS, we've evaluated a T2 star MRI, a cardiac MRI for patients with iron overload. And even though we don't have too much data in sickle cell, but I think for patients who are sicklers who are regular transfusion, this is something that we would be happy to share. This is a rapid cardiac MRI sequence that can be done in 8 minutes versus the usual 45 minutes, and there's no proprietary software related to that. So I come to my final slide. So prevention and management of VOC, at the moment we've only had hydroxyurea. We need to make sure that we manage and prevent infections as much as possible with penicillin prophylaxis and vaccination, and treat the anemia if patient requires treatment, give folic acid and packed RBC support if indicated and carefully. Monitor patients for long-term, lifelong for complications, iron chelation and monitoring if patients are multi-transfused. So I think with these kind of things, we actually can treat the majority of our patients, but there are a subset of patients who may benefit from HSCT, crizoluzumab, L-glutamine, voxelotor, mitapivat, and I think it's important for us to be aware of these products and their indications to use them in the right patients. Gene editing and gene therapy are here. We're actually going to be participating in a gene therapy trial for hemophilia. So it's not that far in the future. So I think, again, it's important for us to be aware of this so that we can guide our patients when the trials come and when the treatments are there. But I still feel that many more innovations are required to help patients with their difficult quality of life and to reduce the morbidity and mortality. Thank you.
Questions, we'll be happy to take.
Thank you very much, madam, for such a nice exploration in a recent advancement. I would like to know one thing, your experience with HSCT, and in particularly in pediatric patient.
So we have not transplanted a sickle patient at my center at AIMS New Delhi. But I do know that many of my students in the private sector routinely transplant sicklers, and I'm aware of their results and outcomes, and you need to select the right candidate. So as I said, the patient should have had some complications, so he deserves to have a transplant, but he should not be so sick. If you pick a patient who's had devastating stroke or multiple or got really bad organs, because see, you must remember that we do have to give chemotherapy to these patients. So if their liver is completely damaged, kidneys are completely damaged, we do something called an HCT-CI score. So if your score is very high, then your risk of dying from the bone marrow transplant is high. So you must not, and since this is an elective procedure, it's not like a relapse leukemia where you will have to do it. It's an elective procedure, so you should pick the right candidate. He should not be so sick that he has a high risk of death during the transplant. So with good selection, we have 100% results, 100% survival and 100% event-free survival. That is that they don't reject and they are cured of the sickle cell.
Madam, I belongs to MGM Medical College, Indore. I am a professor, head of transfusion medicine. My colleague, Madam Malpani, she is the head of the department pediatrics, and we are doing a good number of bone marrow transplant. And 5 adult we did a hemopietic stem cell therapy. And out of 4 us working very well, but we lost 1 patient, and that because of some further complication after the discharging from our hospital.
So I'd like to congratulate you.
Yes,
I think that's very good. That's good result. And what we always do recommend is that if you are, so first of all, in fact, whenever you start a transplant unit, it's always a good idea to start with autologous transplant, then to do leukemia transplant, and then to do hemoglobinopathy transplant. And in hemoglobinopathy transplant, first do thalassemia transplant and then move on to sickle, because sickle is slightly more difficult than even thalassemia transplant. So I would say good results, and anybody else who's planning to do that, just follow that sequence, because once you've done it this way, then you'll be familiar with all the complications. You actually end up being an ICU physician when you're doing transplant. So congratulations.
Splendid presentation, ma'am. One question I have for stem cell hematopoietic transplantation, which you talked. You said that plerixafor is far better than GCSF.
Right.
So, what is any specific?
It's very simple. So GCSF is used for all bone marrow transplant mobilization. Even in multiple myeloma, we can use it. Sometimes in myeloma, lymphoma patients, because they're very poor mobilizers, plerixafor was developed for these patients. Now, when they started doing transplants for sickle cell, they found that with GCSF, because you see a sudden increase in the white count, right? You end up with, you may have leukostasis, you may have, bone pains, you may have other problems. It can precipitate a VOC. So for that simple reason, nobody uses GCSF for mobilization in sickle cell patients. This is the only group where it is contraindicated. And we have an alternative. So if you didn't have an alternative, you would be stuck, but we have an alternative. And so plerixafor and GCSF we can use in myeloma, lymphoma patients. And usually we don't need it in other patients, so we don't use it because GCSF works as well. But plerixafor can be used in any transplant, and it is specifically indicated for sickle.
Madam, we are using plerixafor when they are not responding to the GCSF.
Okay, so you're using GCSF.
We are doing CD34 count.
Okay, so that's you're brave. You're very brave.
Capable to achieve the targeted number.
So the other thing is, at AIMS, we follow the guidelines, because if we don't, and if something goes wrong, it will come in the newspaper. So we always follow the guidelines, and the guidelines say plerixafor. Yes, please.
Okay, one last question.
Hello. Exciting newer therapies for sickle cell disease, and many of them are curative too. I'm just thinking, and I have a question too, that we had one patient who had a cerebrovascular stroke. We operated, and then he survived. Now, usually this is a very serious complication wherein as per guideline, if there is a possibility, he can be offered bone marrow transplantation.
So I completely agree. So
Yes,
the one option would be to do regular red cell exchange in this patient. The other option could be transplant. I completely agree.
But then both for which they did not agree to us. Now what has happened, that over last 2 years, he is just on the routine medication supportive, and he comes for a regular follow-up, and to our surprise, he does not have any symptoms for that matter, and he is remaining really good. So my introspection is that there are situations wherein such patients, they go in for a remissions for years together. I remember that Kion Pan, who was the first patient who was transplanted by Grady Memorial Hospital, and he was transplanted and he got diabetes and died of septicemia later on. He cured of a sickle cell disease. So I just want to know, what is the longest survival of disease-free after bone marrow transplantation?
So the longest survivor in the world, you saying?
In the literature, because I am not.
I'll have to look that up. But as I said, the patients, when I was in the US, we did routine sickle cell transplant, and the majority of patients would have good quality of life. But as I said in the Dr. Krishnamurthy paper, it's a discussion that you need to have with the patient. Sometimes you may have a patient who had a crisis or a stroke which was precipitated by a one-off event, and in that case then I completely agree there's really no need to offer transplant. If you have a patient who's having recurrent stroke and then has got a major stroke, that might be the right candidate. And again, as I said right in the first slide for transplant, I think we need to look at our data and come up with our Indian guidelines. These are all Western guidelines. And we are seeing a shift in our patients. 20 years ago when I started in hematology, it was routine for people to say, oh, sickle in India is a mild disease. Now from all the deliberations today, we can see it is not a mild disease. So again, we're seeing a transition. Perhaps the patients are surviving, the ones who would have died in the newborn period, and they had the more severe phenotype. So I think it's a really exciting time, and it's important for us to collect the data, to publish, to have lots of these discussions and interactions, and as I said, why not have our own guidelines for bone marrow transplant?
Okay, thank you, ma'am.
Thank you so much. I now request Dr. Deepti Jain, ma'am, to please come on the dais stage and felicitate Professor Seth. Thank you so much, ma'am. So with this, we come to the end of today's symposium. It was indeed a very exciting day for all of us, with so many dignitaries, luminaries, and we had so much to learn from everybody. And it is great to learn that the government is taking the initiative very positively about the sickle cell disease, and the 2047 target has been sort of fixed for it now. So with this hope in mind, I request you all to be present tomorrow again. We'll be having 6 lectures followed by a panel discussion. So I hope to see you all tomorrow. Thank you so much for being here. Thank you so much. Request all to please